diesen Herzfehler.
Wir sind online, Max. Kannst du mir mal verraten, also es kommt ja eine ganz spannende Eröffnungszeremonie und dann kommt ein ganz spannendes Lied und das hast du getextet, ja? Wer hat denn da zugestimmt, dass du die Melodie nehmen darfst?
Also es war Udo Lindenberg höchstpersönlich und ja,
Ja. Und wie
genau.
kam das dazu, dass du seinen Text umgetextet hast?
Also ich war schon länger Udo Lindenberg-Fan und da habe ich mir gedacht, das Lied Durch die schweren Zeiten passt eigentlich perfekt dazu, weil wir Fontans haben ja auch immer schwere Zeiten und kämpfen uns da durch und deshalb habe ich mir gedacht, passt ja eigentlich prima und deshalb habe ich dann dieses Lied quasi umgetextet.
Okay. Und das ist ein super Text geworden. Und hast du bestimmten Wunsch an viele Menschen? Hast du einen bestimmten Grund, warum du das für dich als Fontani getextet hast?
Also, weil ich wollte halt einfach, dass auch andere Leute quasi mitkriegen, dass es so einen Herzfehler gibt und dass es auch Kinder gibt, die unter diesen Bedingungen leben.
Okay, das ist super. Und hast du selber einen Spruch für dich?
Kämpft dich durch die schweren Zeiten, wie auch der Refrain in meinem Song.
Und wie war das noch mit halbem Herzen?
Ja, mit halbem Herzen und vollem Bock aufs Leben werde ich alles dafür geben für dieses geile Leben.
Ist das nicht super? Ich glaube, unsere Zuschauer, die können sich alle schon riesig freuen, dass es bald losgeht. Wir werden 12:55 Uhr starten.
Ja,
Ja, dann seid gespannt.
ich habe zwar ein halbes Herz, aber habe trotzdem vollen Bock aufs Leben.
Super. Ja?
Okay.
Da.
Das ist vorbei, oder?
Ja, dann kannst du noch mal so winken und dann legen wir das
So.
wieder hier. Was? Liebe Teilnehmer, ich würde Sie bitten, Ihre Plätze einzunehmen. Ich freue mich sehr, heute den Staatssekretär Herrn Beck in Vertretung unserer Ministerin Grimbenne, ich denke, die Grußworte im Namen der Ministerin wird aus ihrem Munde, werden die sicherlich uns allen zur Begrüßung gut tun. Und ich freue mich, dass die Referenten, Ärzte, Teilnehmer ihre Plätze einnehmen und bitte unser Team schon mal in Bereitschaft, weil nach den Worten von unserem Staatssekretär werde ich euch hier hoch bitten. So, Herr Beck, sind Sie so lieb, kommen hier hoch. Ich bin sehr froh, dass Sie es geschafft haben und ich würde Ihnen hiermit unsere Begrüßung in Ihre Hände geben.
Ja, meine sehr verehrten Damen und Herren, liebe Frau Sänger, ich bin ja beruhigt, dass Sie auch noch nicht fertig sind. Ich habe es kaum geschafft, hierher zu kommen. Der Verkehr war sehr dicht und von daher bin ich froh, dass ich hier bin und ein paar Worte an Sie richten kann. Ich möchte Ihnen zuerst die Grüße der Landesregierung und insbesondere von der Gesundheitsministerin Frau Grimbenne übermitteln und kann Ihnen sagen, dass wir stolz sind, dass wir Sie heute in diesem schönen Raum, das ist der schönste Veranstaltungsraum der Landeshauptstadt, begrüßen können zu Ihrem Symposium und Ihrem hochkarätigen Symposium. Sie beschäftigen sich mit einer sehr schwierigen und wichtigen medizinischen Frage und wir sind stolz und ich habe ein bisschen geguckt, wer hier heute alles anwesend ist, dass wir wirklich internationale medizinische Expertise hier in diesem Raum versammeln können. Und ich denke, Sie werden dann den Nachmittag nutzen, um Ihre Erkenntnisse zu teilen und Ihre gemeinsamen Fragen zu bearbeiten und hoffentlich dann auch damit eine fachliche Weiterentwicklung hier an diesem Tag auch für sich mit nach Hause nehmen können. Dafür wünsche ich Ihnen viel Erfolg und auch viel Freude an der heutigen Arbeit. Es geht aber bei dem Thema Fontan-Herzen ja nicht nur um medizinische Fragen und deshalb gestatten Sie mir auch noch 2 Sätze zu sagen zu Frau Sänger und ihrem Team und auch dem Fontan-Herzen e.V. Es geht ja bei der Krankheit auch darum, dass die Familien, die davon betroffen sind und die Betroffenen selbst natürlich eine große Belastung haben und dass auch viel getan werden muss, um auch diesen Familien ein gutes Leben und Teilhabe zu ermöglichen. Und da leistet der Fontan-Herzen e.V. aus meiner Sicht und aus unserer Sicht wirklich wichtige Arbeit, für die wir uns auch bedanken wollen und dem ich auch durch meine Anwesenheit heute in Vertretung der Landesregierung hier auch Wertschätzung und Respekt zeigen will. Vielen Dank, Frau Sänger, für Ihre Arbeit allgemein und insbesondere auch für die Vorbereitung dieses heutigen Symposiums. Dafür wünsche ich Ihnen heute nochmal alles Gute, gute Gespräche, gute Erkenntnisse, einen guten Austausch, auch eine gute Zeit in diesem schönen Ambiente. Und ich danke Ihnen, dass Sie mir zugehört haben und wünsche Ihnen alles Gute. Vielen Dank.
Herzlichen Dank, Herr Beck. Ich denke, gerade Professor Grabitz weiß auch, wie sehr unsere Gesundheitsministerin in Sachsen-Anhalt bei unseren Themen mit dabei ist. Sie erinnert sich sehr gern an unser Treffen hier in Magdeburg. Und ich möchte unser Team bitte nach oben bitten, denn wir haben eine kleine Überraschung vorbereitet. Bitte der Max. Max ist unser Vertreter für alle Fontanis, denke ich, heute hier. Komm mal mit dir vorne. Genau. Wir haben nämlich heute eine ganz große Überraschung. Wir wissen ja, dass Sie alle ein Herz an unseren Kindern auch so ein bisschen verloren haben. Sie sind tagtäglich für unsere Kinder im Einsatz. Wir haben Familien hier dabei, die genau hinschauen. Und der Max, der hat ein ganz besonderes Lied umgetextet. Und von wem ist denn das?
Das Lied ist von Udo Lindenberg, nämlich Durch die schweren Zeiten.
So, und der Udo, hat der gesagt, wir dürfen die Melodie nehmen?
Ja, das hat er.
So, das ist schon mal was ganz Besonderes, extra für Max und für alle unsere Kinder. So, wie bist denn du dazu gekommen, dieses Lied umzutexten?
Also ich war halt schon länger Udo Lindenberg-Fan und da dachte ich mir, das passt ja eigentlich ganz gut, wegen durch die schweren Zeiten, weil wir kämpfen uns ja auch oft durch die schweren Zeiten. Und ja, genau, das hat halt dann gut gepasst. Und dann kam ich halt auf die Idee, das einfach umzutexten.
Genau, und du hast ja ganz, ganz tolle Passagen da drin, ne? Welche gefallen dir so am besten?
Also der Refrain, das mit Ich kämpfe mich durch die schweren Zeiten und noch dieses wir sind doch Lichtgestalten füreinander da, das.
Und hast du noch mit halbem Herzen?
Ja, mit halbem Herzen und vollem Bock aufs Leben, wenn wir alles dafür geben, für dieses geile Leben.
Ja. Und mit diesem Einstieg bitten wir Film ab.
Morgen steh ich auf, seh den Albtraum weiß. Eine Ärztin kommt herein, fragt mich, wie ich heiß. Warum muss ich ein Fontan
This applause is for you, Max. On behalf of the whole team, which I would like to thank, the board of directors, the advisory board, everyone's here. Max, I know that you have a great wish. First of all, being visible. People don't know anything about your condition, and that's what you wish for. And you would think it was cool to sing with Udo Lindenberg and with all your friends. I hope that Udo has seen that and he's as touched as we are. And we all cross our fingers that this may come true. So it's our song now. It's the association song now. So thank you very much, Max. And thank you for coming up on the stage, team. Dear doctors, dear participants and guests, on behalf of the board of directors, the advisory board, and all members of Fontan-Herz e.V., I would like to welcome you to the second Fontan-Herz-Symposium. It is a great honor to welcome you here today from all parts of Germany, Switzerland, Denmark, Austria, and even from the US for the Day of the Child with Heart Disease. No association in Germany is focused and interdisciplinary on the serious Fontan issues we have on the agenda today as our Fontan-Herzen e.V., our association. We all know that here that not everything is good with 2 to 3 Fontan operations. Since our first Fontan-Herz-Symposium in September 2021, children and young people from our ranks have died again. Some are doing very, very badly. The PLE and especially the BP diagnoses are increasing. Figures are also frightening. According to the relevant brochure of the German Federal Association of Children with Heart Disease, 7% of Fontan patients develop bronchitis plastica and 15% PLE. That is almost a quarter. There is no longer any question of rare. In the Fontan book of the Heart Foundation, it can be read that 10 years after a transplant, less than 50% of the Fontan patients are still alive. It is a frightening figure. 10% of children born with heart disease do not make it to adulthood. This means nothing more than desperate parents having to let go of their children forever. That is why our focus should be on saving as many children as possible. Against this background, for us at Fontan-Herzen e.V., there is no alternative to a symposium of this kind. You and your colleagues are the first contact persons and bearers of hope for our families. You exchange ideas with each other personally here and network internationally. Here you get concentrated into concise insight into the latest state of research and treatment options for the lymphatic system and the very complex, special, life-sustaining and operated heart defect. Dear guests, the experiences, observations and study results you have brought with you will provide a compact overview in 23 contributions at our second Fontan-Herz-Symposium. We hope for protection against complication, and that's very important for everyone, and for important discoveries of correlations in cardiovascular diseases, also for rare diseases, which would not have existed without the study of the Fontan circulation. It is therefore very encouraging for us that you are here. Please, dear doctors, our families urgently need your support on their individual journeys. It is about buying time and keeping the children and adults as stable as possible. We all know here that the whole body suffers when there are complications. Unfortunately, We hardly learn anything about multi-center studies or whether well-functioning Fontan circuits are compared with non-functioning ones in order to find causes for the differences. Often people don't believe us parents when we make assumptions. After all, we're not doctors. But trust our observations. Don't be condescending. And I forgot to click on my slides. Don't be condescending. Trust our observations, don't be condescending. Our assumption that in Fontan patients, budesonide does not work only in the intestine led us to Professor Reitschik. We are very curious to hear what he has to say about the relentless complications, as he calls them. Since not even the 30 or so centers for rare diseases in Germany are able to help Fontan patients, we would like to see a few interdisciplinary Fontan competence centers, which are internationally networked, to deal with all the questions related to the artificially produced Fontan circulation. These are not intended to replace the care provided in the heart centers or by the cardiologists in private practice. They are intended to complement them. This is our first draft of how we envisage these centers. This is not the moment to go into details, but we sincerely hope that solutions will be found in the interest of all those affected by Fontan. And here I have another photo. Do you recognize Professor Grabitz? He and Professor Kramer have accompanied me for 18 years as the mother of a daughter with Fontan-Heart. And both have been supporting members since the founding of our association 11 years ago. Professor Grabitz often said to me, actually, I wanted to wave off your ideas. But the more I think about it, I think he's not the only one, by the way. But the more I think about it, somehow there's something to it. Close to the patient at eye level with parents and always willing to take parents' non-scientifically based gut feelings seriously. For this, I thank many doctors, and especially you, Professor Grabitz, from the bottom of my heart. I am pleased to hand over the floor and the chairmanship of our second Magdeburg Fontan-Herz-Symposium to you. Thank you very much for your attention. Dear Ms. Sanger, thank you very much. Especially, thank you very much for re-inviting me. Let's say, as host, in order to make the transitions between the different presentations. I'm very impressed by the range of different topics that we are going to see today. I think interdisciplinary look is what we are looking at here. So we have the cardiologists on the one hand, and we have the other experts on the other hand. And just before we start, in the meantime, since the 31st of March, I'm an emerite professor. So I'm very happy that my successor, Roland Hase, is here. So intensive care is in his hands now in Halle. And I thank you for the good cooperation. So we have a timer here, and this timer gives the presenters an idea of how much time they have. I think you understand that we have a very demanding, very sophisticated program, and we need to be on time. So we start with a block dealing with the indication of the heart transplant, and I'm happy to introduce Thilo Fleck. He he is going to speak about the heart transplant in cases of failure of the Fontan circulatory system and the results from Freiburg. Thank you.
Well, thank you, Professor Grabitz, Mrs. Sanger, for the organization of this symposium. Dear members of Fontan-Herz-Symposium e.V., I would like to talk about heart transplants for failure of the Fontan circulation. If possible, we could have the slides as well on the monitors in front. If not, then it works as such. Okay, first of all, what are the indications of heart transplant? In principle, every patient who has evaluated for a heart transplant, I have to ask the question whether all invasive surgical and medicinal possibilities have been exhausted. So it means that we have come to the end of the line, so to speak, and all therapy options that we will get to know in the symposium today have been exhausted, must be exhausted before you get to do a heart transplant. But that also means that with the increasing cyanosis, with all the performance decrease and protein loss enteropathy, and which can lead to a high death rate. So even if you don't meet the classic heart transplant criteria, increased liver problems, etc., we will come to it later on. So if these possibilities, these indications are given, then a heart transplant evaluation can happen. So what is important for us is what is the cause of the failure of the Fontan circuits. There are two possibilities in principle with two blocks, meaning one is the pump failure of the unicameral heart. This pumping failure means that the body is no longer supplied sufficiently, especially the liver and the intestine tract, and you all know the symptoms. And furthermore, it leads to the increased filling pressures in the heart, and there is a constriction, and it has leads to increased pressure in the Fontan circuit. And the other cause is an increased lung pulmonary pressure. I didn't mention that there also can come to stenosis in the pulmonary vessels. If that's not the case in the pulmonary vessels, it's quite small, and the restriction is the resistance is quite high, then it will come to a backflow and a problem of outflow and to bronchitis plastica. And the problem is that these patients have a high risk, an increased risk, and because if we implant a new heart and the donor heart is possibly not able to fight against these resistance, this pulmonary resistance, and it's very difficult to evaluate the pressure because there is no flow in the circuit and no pressure can be built up. So the evaluation in the beforehand is very difficult. Why is it so important? Some colleagues have shown in 2017 that patients with a good function of a unicameral heart have increased the mortality after transplantation. This is the red line, meaning a survival rate after transplant of under 40%, meaning the results are worse than a spontaneous course. And so a transplant doesn't really increase the survival chances and or the life quality necessarily of a patient. So furthermore, it's also the case that if it comes to a failure of the pumping chamber, that there are a lot of risk, and they differ from patients with two-chamber heart that are undergoing a transplant. One of the questions that we have to ask ourselves: is the liver already damaged this far that when it comes to the transplant and we have to give liver damaging medication, is the liver at all possible to survive the transplant, or will there be an acute liver failure? The next problem is that many of our patients, in the framework of the surgeries that has been done, they have so-called homograph material, human tissue that was implanted. Our immune system recognizes this tissue, and if it can also be working against it. So if this external strange tissue is developing antibodies, then the patients are under a high risk after the transplant. So in Freiburg today, we are trying to prevent this, and also when it comes to blood plates, then we don't do external transposition. So if it can also lead to extended waiting times and also deeper ingress into the immune system. Also, when it comes to a protein loss enteropathy, then also the lymphocytes get lost via the intestinal system, and so the patients have before the transplant an immune weakness, and it was shown that patients with a protein loss have a higher risk for infection. And that means in Freiburg today, when it comes to patients with PLE, we are very much more careful because the risk of an infection is much higher. The second problem is that unfortunately we have found collateral vessels, and you know what I'm talking about. They can lead to bleeding risks, and furthermore we have patients with a cyanosis, with a chronic cyanosis. That means also the function of the blood plates that this leads to an increased risk of bleeding due to during a transplant. And then we have patients with situs inversus, where the heart is at the right place. All of these aspects during the transplant, you have to, so to speak, do an image, a reversed procedure. This is very demanding when it comes to the surgery and also time. And furthermore, we have patients, they have deformities of the thorax due to the many surgeries, partly also of the spine that you can see here, and they also have a the situs during the surgery can lead to a lot of additional growth, and the time can be very long during the surgery, sometimes up to 8 hours. And also there's a lot of scarring. But when it comes to the transplant, to the actual transplant itself, of course, we have to change the surgery from a one-chamber to a two-chamber circuit. So everything has to be reconstructed, and also the aorta at certain times, where we also use the donor materials. So it also is very problematic if you transplant the heart. Usually you take it and you store it on ice, but during this time it's only a limited supply with nutrients, and the longer the heart is stored, the more difficult, because it probably won't get started again, or it can due to very high pressure come to very high pressure in the heart, and the loss and therapathy and does not recede. And so in Freiburg since 2017, we have used the so-called organ care system, also called heart in the box. The heart is being put in a heart-lung machine, in a miniature heart-lung machine, and for the entire time it's been supplied with a blood and oxygen and with nutrients, and it keeps beating the entire time. So first, we were the first worldwide who were using this with children, and we could show that this using of the organ care system, we compared it with a group of children that were transplanted without organ care. The ischemic time was much shorter. You can see here the ischemia times much shorter, and so the surgery times is 620 minutes, is almost double of on the left with controlled patients of 329, and also a much shorter ischemia time. And interesting, if you look at the hearts at 1 year on, even though it was a very complex surgery and transplant, the filling pressure are much lower, and that also gives you the chance to solve the problems of PLE after transplant. What are the results in Freiburg since 2017? We have had 17 patients with single ventricle heart, 12 male, 5 female. The median age is 15 years. The youngest was 9 months and the oldest 40 years. The waiting time on the HU list is 134 days, but the range can, of course, vary. We had patients that only had to wait for 4 days and others 3.5 years. So the palliation stage of our patients, one could be transplanted after Norwood 1, 4 with a failing gland. If the unicameral heart would fail, then in failing gland, then we wouldn't do a surgery. But then 12 patients had failing Fontan. 11 had PLE, 1 had plastic bronchitis, Fontan-associated liver disease, 11 patients, 1 had cirrhosis with esophageal varices, and 1 had hepatocellular carcinoma. Since the survival after HX is 82%, the use of organ care system has increased to 67% of cases since 2017. Time in hospital, median 43 days, 32 to 176 days. 3 patients unfortunately died. 2 of those, one died after 10 or 43 days due to a sepsis, 1 after 181 days after multi-organ failure. This was before the box system, and we had very high filling pressures, and the problems couldn't be solved. So what's good is that we did not have any rejection, no transplant vasculopathy, and the median time now is 4.7 years since transplant. So the oldest patient was transplanted 13 years ago. And in your Fontan AV brochure, you report on him. It's a very emotional, very interesting case. I met the patient at the football game last Wednesday, so he's enjoying life. None of the porcine patients does have PLE or bronchitis plastica symptoms any longer, and all patients have a normal liver function. And what makes me very happy, and we also evaluated the quality of life, we can say that it's a normal quality after the heart transplant with Fontan patients, which makes us really happy. So many thanks for your attention, and I'm looking forward to your discussion points and remarks. Any questions or remarks? I think that we will also have the chance in context to touch upon certain points. Many thanks. Would you agree that we continue in the program? The question is now, what can be done before a transplant? And so the title is I'm moved one on.
Sorry. I didn't read it well. Okay. New strategies for improvement of durability of a Fontan circulatory system. The floor is of Rainer Koslik-Feldmann. Yes, thank you very much. Dear Ms. Sänger, dear audience, thank you very much for the invitation to this very special symposium. It was a very heartfelt introduction to our symposium. So we have an end-stage therapy for Fontan-Herz. So I don't see it here. So the question is, when do our children or the adult patients need a transplant? So the title is very daring, new strategies to improve the durability of a Fontan circulation, and that's what it's about. Can you make a Fontan heart more durable, more functional? So that's very daring because there are lots of circumstances or considerations that have been dealt with. But the problem, Ms. Sänger, that we have is that there's so many ideas in the area of the pediatricians, but they don't make it into the clinic and into the day-to-day of the work in the clinic. And then we don't have, we do have certain techniques, but we don't have the necessary studies, the serious medical studies with double-blind studies, etc. When Francis Fontan invented his procedure, it was about a different heart failure, which is the surgical repair of tricuspid atresia. But now we are more and more talking about the hypoplastic left heart when we treat Fontan patients. And the Fontan therapy now is 50 years old, a little more. And the operation, the surgery has been modified so that initially we had a Fontan where we included the atrium, then there was the lateral tunnel, and today we have the prostheses, the extracardial prostheses. And now we have more than 70,000 patients that have been treated, and they, so the univentricular heart are treated with the with Fontan, the tricuspid atresia, the heart defect for which Fontan circuit was initially developed. Then we have the hypoplastic left heart syndrome. We have the 3 PACES operation concept that you're all familiar with. So we have the hypoplastic left heart complex, additionally, where we have very small functions of the heart, and also we have a hypoplastic second ventricle even in these cases. And other heart failures are rare failures. So I'm just mentioning this because we always have to think about whether Fontan is unavoidable, especially with the hypoplastic left heart complex. We have to think about it twice. If we can, how we can recruit the second ventricle. So the Boston team has initiated a large program. So the Fontan that we avoid is the best Fontan. if we have a functioning circuit. And we can also do this after the first stage 1 step, but even after the second step. So it's not only the surgical process. There's a North American group and another group that are introducing the hybrid process, where you make the first step without a machine. And this was possible in a number of patients to train the heart, or retrain the heart. Why do we even talk about new and other possibilities in the Fontan therapy? So here we have the 3 ages of the Fontan operations, surgery, and the survival figures of the patient. So at first glance, it seems that the original Fontan surgery had the least prospects, and now we have 95% of survival. So this is a better picture. But we have to say that the newer groups have not been accompanied for such a long time, and what has improved is the heart surgery as such, because at the beginning several patients died shortly after the surgery, and if we clean this accordingly, then the graphs are pretty alike, or pretty similar. So with the establishing of the Fontan circulation, we initiate something that is very difficult to avoid. So what are the complications? You will be aware of that, but the most important complications that lead to mortality are a higher grade AV valve regurgitation. That's the highest cause of high mortality in the Fontan surgery that leads to a high mortality, and this affects 10 to 40% of the patients. Then we have arrhythmias, 60% affected, and then dysfunction of the ventricle affected 50%. And the non-cardiac functions, in English you talk about FALD, FOLD, the Fontan-associated liver disease. After 20 years, 57% are affected, and after 30 years, more or less 99%. Then kidney failure, 8%. Thromboembolic events, 30%. Here the figure was lost. And especially when I heard about the lung resistance, some patients develop chronic lung embolies, and this can also be a complication for the Fontan patients, and this can lead to a thinning of the blood. Then we have PLE, about 10%, PB. That's all figure 4%, PB 4%. That's all figures from the newer literature. In some cases, it might be higher. So we've seen it very well. A problem is that on the right-hand side, we will never be able to establish a natural circulation, because the blood comes back from the body. On the right-hand side, this is a normal heart. It goes to the lowest pressure that we have in the mammal range, and then it goes through the lung and then back into the system. In the Fontan circulation, the blood goes passively into the lungs, but at a higher pressure. And sometimes this can be mitigated by a artificial window, but then the patients don't have a normal rate of oxygen, and then the blood will be driven into the body at a higher pressure. And what you can have to consider is that patients' age and the heart chambers are deteriorating anyway. So this means that the arterial pressure is increasing, and the blood needs to flow against a certain resistance, and that is one of the worst problems over time. So we have the pulmonary resistance, which is an essential factor of right-sided flow regulation. So we have to consider the pulmonary vascular growth, which is reduced by reducing the blood flow into the lung or into the heart. But we have to reduce it. But this also leads to other complications. So if there is too much blood in the lung, then that can lead to complications that which can make a transplant difficult. Children with a stenosis also have a poor prognosis, and this means that during the process of aging, the lung resistance increases anyway. So if we have a normal heart volume, then even if the best of cases, the normal mean lung pressure is between 13 and 14 mmHg. So if we have a triple dysfunction, then this will lead to a further increase of the pressure in the circulation. So the breathing in Fontan is also a factor that has repercussions on the circulation. So here you can see on the left hand a healthy heart, and on the right hand you see a Fontan heart. So here you see the influence of the breathing on the blood circulation in the heart. So here you see that between the mountain and the valley, the circulation plays a very important role. So in the Fontan heart, there is a different distribution in the influence of the blood into the heart. So at the end of the inspiration, there are negative flows to the lower half of the body. So there are several procedures. So we can make the simulation here. So inspiration, this is a Fontan heart. And if you look here at the hollow vein, you can see that the flow is diminishing. This is a patient where the breathing is ongoing and there's no flow in the hollow veins. And if we look at these images, we see at the beginning of the inspiration a flow in the hollow vein, but at the end of an inspiration, the flow is non-existent anymore. So we can see the flows inside of the heart, and we can see where we have problems. So what can we possibly improve for our future Fontan patients and our current Fontan patients? So we need an optimized first step, the pulmonary vessel growth through the pulsatile flow. So even in Glen, we don't have a pulsative flow anymore. So we've heard this before. There was a patient that was going to have a heart transplant, but there can be also, if necessary, there can be new or additionally shunts. and the Glen later if necessary. We still need to look at the overcirculation. Some colleagues say that a little overcirculation is tolerable, so if we have the circulation inside of the lungs. So many centers now are of the opinion that if we have the AV valve is not tight, then we need a surgical optimization. We have treatment of arrhythmias. That's a morbidity factor. Then anticoagulation, not only in the patients with a window where we are afraid of a connection to the brain, but generally this should be indicated in patients to have an anticoagulation for the reasons above mentioned. And Mr. Fleck already mentioned that the aortopulmonary collaterals are not only a nuisance when you are in surgery, but they also lead to stress on the ventricle. And if we leave it like that, then there is a permanent overload which leads more quickly to a dysfunction. So here with the MRT flow measurement, where we wanted to try to find out if they are relevant. So the lung arteries and the backflow from the veins. So here in this example, we have a failed flow of -20. And so we should think about whether we should close it. Sometimes it also comes from this arteria, and so we have to close them in order to do away with the flows. But normally it's not the only thing, the only collateral that we have in these patients which we have to look for. So then we have the veno-venous collaterals, which lead to cyanosis. A strong cyanosis can also lead to a load on the body as a whole. Then we have anticongestive treatment of the ventricles themselves. It's still very difficult and diversely discussed. So what is clear is that if a Fontan patient is in a bad state, then we don't have so many options. So in the movie, we saw a child with a mountain of pills. But of course, as we said before, there are not a lot of studies that tell us whether we are doing a good thing or not with these kinds of treatment approaches. So the pulmonary afterload reduction and the minimization of energy losses in the venous flow. This is something that we know about, so that the patients, the strength of the patients can be improved. Then another important aspect, and we can also use the FortiFlow measurements for that, is that maybe even before Fontan surgery, we could think about optimizing the flow in the tunnel. So here we have a study that shows that depending on how we connect the tunnel, then we could have a loss of energy. Here it is optimized, so we have more blood flow in the left lung than in the right one. And if we optimize this further, then we could find a balance here and avoid the loss of energy, because we don't have anything to improve the passive blood flow. So lymph anomalies. So we can see here that also the arteries are not looking very well. So we should try and solve that. So lymph anomaly is a symptom of the Fontan circulation. In some patients, it came even before Fontan sport. So we saw in the movie, we saw skiers, and the experts are recommending this for Fontan patients, but we don't have a lot of data about how dynamic and static components are playing a role here. But it's a sure thing that Fontan patients, if they have a static load, they're interesting measures. So the venous pressure can go up to 40. So in millimeters. So in people with a normal heart, it's 2. So then there are more ideas about contractile Fontan tunnels in order to inject a little energy into the circuit. Then auch the permanent subpulmonary pump. We haven't heard as yet about stem cell therapy for the ventricle, and then heart transplant. So we will see whether one day we will have xenografts, so pork hearts, no, pig hearts, sorry. So there are some studies underway at the moment, so that could be a progress if one day it works somehow. Of all these procedures, Norwood, Zanosh, all this means that you have a heart-lung machine operation, and a heart-lung machine surgery with a newborn leads to a detriment of the brain function. So that's why Schanze-Gießen have introduced the hybrid surgery that does not need the machine. And here we can see that the initial survival rate is better, but in the long run, there is not a big difference between the two. But at least the newborns were spared a big surgery with a heart-lung machine. So this kind of procedure is being used with children below 3 kilos or that are very immature. And with the hybrid procedure, you really have gained a important progress. So treatment of hypoplastic left heart syndrome and complex is still associated with significant morbidity and mortality. The aim is to improve the outcome of these vulnerable patients, to reduce trauma in newborns, and to postpone operations until later infancy. So now the idea is to use vascular plugs. They are not approved for that, but it is indicated. So if you cut a hole in it and implant it, then you have a flow reduction in the lung. So we have tried this with 7 patients. And we have the same program after the surgery than with the hybrid. So we see lots of material here inside of the child. You see the dots, then you see the stent, and in the here you see the flow that is accelerated, and this is something that we have known for some time. Of course, we have problems with new procedures too. We have many post-operative interventions. 2 patients sadly passed, but the plugs can be taken away very easily again, and there are certain arguments that see that there should be not too much damage in the lung tissue. So you go into sedation, you have a newborn that doesn't need intensive care, and we need to find out whether we have a better somatic development, whether we later on have a better neurological development. What is sexy for the neurologist is that if he has to operate the child for the first time, then we have the comprehensive stage 2, as we call it. He has a child that never has been operated on, and there's no scar tissue, and they can concentrate on what they have to do. So this is also indicated for HLHC as a bridge for biventricular circulation. So we still have to find out a lot. We need more studies. So now we have the idea of the contractile Fontan conduits. And the idea is that we build it into the wall of the tunnel. And as we see here, so we have the tunnel with 2 valves, and we have a forward flow for the patient. So with the help of a pacemaker, we could make the heart beat. It doesn't look sensational, but if we further develop, then this could be a good a complementary treatment. So there are Fontan patients that can implant. So we can implant a Fontan cannula. And Mr. Hart is going to talk about this because he is part of the working groups that have done this. So this is the second publication. And these are images that I have copied from your publication, where we can see here in as a photo and schematically. So with the innovative Fontan cannula, this procedure is simplified by reducing the number of anastomoses required to only 3. And if the function of the ventricle is impaired, this can be upgraded to a biventricular assist system by cannulating the ventricle or atrium and aorta. We can also have a 4-way situation permanently in order to maybe possibly avoid a heart transplant. So what can we say? The unphysiological Fontan hemodynamics is the main trigger of a number of Fontan-associated complications we observe in our patients. Detection of abnormal hemodynamics is therefore crucial in order to be able to initiate the right treatments. A non-surgical first step could be beneficial for myocardial reserve and for neurological development. So we also have to look what strategies we will still find in order to strengthen the ventricle system. Then strategies for preserving ventricular function. Innovative strategies for Fontan completion could reduce or delay non-cardiac complications. And permanent Fontan-specific assist devices as an alternative to heart transplant. Thank you very much for your attention. Thank you very much for this systematic introduction. Do you have any pressing questions? Otherwise, I would take one question for Nick, who is going to talk about a concept for a Fontan cannula.
Dear Ralph, ladies and gentlemen, some things have been said, and we don't only have medical professionals here, but also some in the audience that are not, medical experts. So some repetitions in my presentations, but you will see that maybe it will get more understandable. Univentricular heart cannot be treated. That's what we heard. It can only be corrected functionally, and the only heart chamber is relieved in terms of volume, and Mr. Koslik-Feldman says 30% after 1 year. It's a European standard, and there will always be additional problems. The Glen anastomosis, the upper anastomosis that leads to this 100% relief of the heart, so the entire pressure is relieved from the heart chamber. The circuit is separated by 50%, therefore we have cyanosis. But and when it comes to the total cavopulmonary anastomosis, we have a connection VCI-PA, and the only advantage compared to Venn is that the circuit is separated at 100%, so the difference in the heart load is the same. It's just the lower cyanosis, but it is on to the detriment of the unphysiological high pressure. So what we have is one chamber, non-pulsative flow. The pressure will rise, and then the performance is limited. We have the risk of thrombosis. We have also, especially with all patients, follow-up diseases, more or less, and always a worsening of the heart insufficiency. And so we don't know exactly why, but the therapies that were mentioned probably can help. What are the problem areas? I called it them. On one hand, the whole technical flow is very difficult because of all the surgery, all the connections, and Mr. Kosnik has mentioned it also, and therefore the high pressure. Then the lung itself, the tissue can get infected, there can be thrombosis, there can be a collateral flow, and the shunts, the outflow, and the throughput resistance can be affected. And if the lung tissue is not properly supplied, therefore these medication that we give in order to lower the pulmonary resistance, and is difficult. So there can be other organs being affected, and the outflow from the heart can also be affected due to the many surgery, and then it can have a lot of influence on the heart, on the muscles, on the valves, on the rhythm, on the fibrosis. And so how does it continue, this flow problem, this inflow problem? There is a restriction, and also these are observations that were made with a patient lying down. But if you stand up, then the pressure is 40 to 50, and without any restrictions. All these measurements we take were with the patients lying down. So as you are sitting down, so it's of course clear that the pressure is much, much lower, and that's one of the problems. The other problem is in the lung. The throughput resistance is higher, therefore the throughput, the flow is less. So the lung cannot function properly for many reasons, and there is bronchitis plastica, there is blood coughing, childless. The heart itself, the pump function decreases with all patients because of the valves, and the rhythm is a problem. The muscles are getting thicker, and the aorta, on the other hand, the valve can be untied, and the volume load and the heart rate performance is affected. All of the other organs are affected as well, the intestines and the kidney, etc. And this is the result of a non-functioning or not properly functioning Fontan. So we have clinical problems that lead to a failure of the right heart, the lung flow, etc., and or we have a left heart problem, and that the ventricular is not working properly, the aorta. And Mr. Kosik-Feldman mentioned it too. The left heart failure can also lead to a backflow from the right heart. So this is what the patients look like. These are the classical failing Fontan patients. Young man with a heavy disease, and it's only skin and bones. He has no fat tissue, and this is a failing Fontan. Then you have to find out, is it more of a left heart failure problem? Does the chamber not work properly? Or is it a right heart problem? Does it mean the circuit is not working properly? So as the young man looks, and you can see it here with the ultrasonic, it's water in the belly, and the story reads as such: many surgical operations, catheter, stents, and pacemakers, etc., PLE. So the fenestration, and if you don't know any longer what to do in order to remove this blood clots, and last but not least, what remains, and that's the topic of the presentation, the possibility to have to do a transplant, where we have to replace the sick heart in order to give the patient a chance to survive. But most of the patients are so sick that we have to take them off the list because they cannot undergo the surgery. This is the medication, the cocktail that we mentioned. You know, also these mentioned in order to improve the blood flow, medication for the intestines. And then, because everything is being lost in the intestines, it has to be replaced, proteins, iron, etc., etc. This is the cocktail of medication. But still, you have a picture like this. You look at the protein and the albumin and the liver parameters. All is in the normal area, but it's still far below the normal values, and these patients are severely ill, and so what can be done? So we have failing Fontan, a failure of the right heart. They are too ill for a transplant. So what can you do? Can you use an artificial heart and transplant it? And so in order to remove these right heart problems, and therefore, thank you, fortunately, we have a company that is providing a technical solution and make the surgery a lot easier. That's what I wanted to present to you today. One of the surgical pioneers, Mr. Prettler from Zurich, who used an almost elaborate surgery in order to put to connect the Fontan circuit to a beating artificial heart. You can see here the venous system. The blood was removed and sent back to the lung aorta, and this whole Fontan has to be rebuilt with a lot of complicated measures in order to pump the blood back into the lung. This is a picture from the publication, very elaborate. It was described in 2008, and you didn't hear anything for a long time because many of these surgeries and publications were probably failed. Mr. Chesnova from Erlangen has published a similar case, different technology, and then the company came and said, the chair of the company is a heart surgeon, so he said, we want to make something new. We want to use the Fontan system and make a special cannula to alleviate the surgery and to make it less elaborate. So this cannula was developed that can be connected, and so how it's being done with a lot of planning, a lot of preparation, and a lot of, a very smart pediatric surgeon. And then you can have a drawing. And then, yes, that was the order for the company to get it done like this. And in principle, you can see the upper and lower hollow vein, and there you can see the pumping chamber pumping the blood back into the system. And this was a patient that was too ill for a transplant. He had a one-chamber heart with a follow-up disease, and therefore you can turn it into a two-chamber heart, one of them an artificial one. But this gives you the possibility of a relief and a recovery, and hopefully we get this patient fit for a transplant. Here you can see the picture. We also will have a video of the patient in a minute. This was before and after the transplantation with the artificial heart. These are the protein values that recovered overall thanks to this artificial heart. And from this patient became this patient on the right. And so the problem of the one-chamber heart that worked well, this problem due to the failure of the right heart, you can, via this support, without any change in the chamber heart, you can help the patient. And so here we have we'll have him 5 months later, and he could receive the transplant. So we published everything else, and we mentioned it too. And a lot of things I talk about is technology and medicine, but I think it's much more helpful if we let the patient talk. And therefore, we have a film that we have and prepared. Please, can you show it?
Ganz schlicht kann man es ausdrücken. Hätte er das Berlin Heart nicht bekommen, wäre er ganz einfach 2-3 Tage später gestorben.
Unfortunately, we cannot hear the
Ja, es ist halt so, und da muss ich doch immer weinen. Du weißt doch, dass ich da ein kleines Päuschen brauche, um die Tränchen zu verdrücken. Also das Berlin Heart hat uns quasi gleich nach dem Herz natürlich alles bedeutet. Weil es hat ihm Überleben garantiert. Er hatte wieder sowas wie ein Leben, weil vorher war er ja so schwach, dass er gar nichts mehr machen konnte. Und dann mit Berlin Heart ging es so Schritt für Schritt ging's bergauf. Dann hat sich noch diese schlimme Darmerkrankung verbessert, wo man wusste, wow, wenn es mal so weit ist, da besteht Chance, dass das vielleicht weggeht.
Ich hatte nie irgendwie das Gefühl, dass es nicht sicher ist. Ich habe mich immer wohl damit gefühlt. Ich bin irgendwie verwundert, weil als ich es an mir hatte, da hat es sich nicht so angefühlt, als wäre es alles Handarbeit gewesen. Ich dachte, das wäre alles in der Fabrik gemacht mit Maschinen, die es automatisch herstellen. Aber es hat mich verwundert, dass jetzt alles handgemacht ist und dass jedes einzelne Detail nachgeschaut wird. Und auch wenn die kleinste Sache nicht stimmt, dass es sofort entweder aussortiert wird oder verbessert wird.
Er war ein Fontan-Patient, also eine große Herzkammer, der auch noch eine eiweißverlierende Enteropathie hatte. Das ist eine schwere Zusatzerkrankung, die durch den Herzfehler kommt. Und das Fantastische war ja auch noch, wir konnten dann schon mit dem Berlin Heart sehen, dass nach wenigen Monaten eine deutliche Verbesserung eingetreten ist. Und das war ja fast noch besser.
Zwischen jetzt und damals gibt es eigentlich keinen großen Unterschied. Weil jetzt geht es mir auch wieder besser. Und ich würde sagen, jetzt geht es mir genauso wie mit dem Berlin Heart. Ich finde, das pocht stärker als normal. Aber das kann auch genauso gut daran liegen, dass ich nie ein normales Herz hatte. Aber ohne das Berlin Heart hätte es auf jeden Fall nicht geschafft. Beruflich bin ich mir nicht ganz sicher, aber eigentlich so IT-Techniker oder Metzger.
Ich bin überwältigt eigentlich von meinen Gefühlen, auch die Einladung hierher. Er hat sofort gesagt, da fahre ich hin. Ich bin total beeindruckt, muss ich wirklich sagen. Also ohne Berlin Heart hätte es auch gar keine Transplantation mehr gegeben, weil er hätte gar nicht mehr, also er war so schwach, dass er nicht mehr transplantiert werden konnte. Und das Berlin Heart hat ihm das Leben eröffnet. Und ein relativ normales Leben sogar. Und ich weiß noch, wie wir dann die Transplantationsnachricht bekommen haben, da hat er noch gesagt, weil er ja durch das, dass er so sehr schwach war, war er dann immer noch schwach. Nur nicht mehr ganz so dolle. Und dann hat er gesagt, am liebsten würde ich es noch ein paar Monate behalten, damit ich noch stärker werde. Muss ich gleich wieder weinen? Ja, macht doch nichts. Und da darf man auch mal weinen. Ihr seid sozusagen unsere Lebensretter und das für ganz, ganz, ganz viele Kinder.
Well, I think this tells you much better how the patients benefit from it, and I think what the young patients saying actually with the format then is much better. The protein problems have been solved, and you can see them too. And I think with these technical possibilities, there you have a chance to get this patient into a state where we as doctors can consider to put them back on a transplant list. Thank you to the company. They don't really make any money on it. They invested a lot of money into the cannula, and I think this deserves an applause. Thank you.
Okay, about the emotional. This was also about the emotional access to these questions. So if there are no questions, then thank you very much. And now I would like to ask two colleagues on the stage, Stefan Schubert and Eugen Sandika. Dear Ms. Sänger, thank you very much for your invitation. Thank you very much, Dr. Grabitz, for your introduction. So after hearing all these presentations, and this was the reason why I said maybe we've come to a point now where we should have a little discussion. And this is why we decided against yet another presentation, but in favor of talking about it and what it is about for us, because basically we have therapies and we can offer them, but in part, as we heard in Nick's presentation, we have the feeling that we are too late. We arrive too late at the patient in order to introduce an effective treatment with the aim of getting him out of the clinic and to establish a long-term perspective for the patient. And this is why the symposium today is a very good opportunity to discuss. So, dear patients, dear parents, we can take you on our journey, status quo now, and I think we have further developed in comparison to where we were before. But we have to talk about the moments, and we have to talk about awareness. And I would say that we as Heart Transplant Center, we see patients in different kinds, in different kinds of how they are, and some of them are not in different kinds of conditions. Sorry, and sometimes they are in bad condition and too bad for operation. So in Bad Oeynhausen, we carry out 6 transplants every year. So the difference is now that the patient population, we have a 60. So we bridge the time until the transplant with a Cystivae. Because the waiting time has increased, we have to say that, and we don't have any donor organs, not enough, and we need to bridge this gap for our patients. But we can see that the survival rate of our patients has improved. And I think that if you look at our center data and internationally at the data, then this is replicated. And we also know that the transplant is the last thing we want to do, but we still have a better and better projection. So the question is, how long do we tolerate PLE, for example, and other complications, and how soon should we start discussing a transplant? So these are our results. We know most patients survive the transplant. They have a good outcome. They do need medication, yes, but they have a good life quality of life. And another thing is that something has changed in the last 10, 20 years. So people have a better quality of life. So the transplant management, the immune suppression, etc., everything has improved so much that life is better after the heart transplant surgery. And if we look at the single ventilation, then Fontan, this does not have an effect on the outcome of the surgery. So the surgery is effective enough and safely enough in order to guarantee a good quality of life for the patients. So we have to look at the title of this symposium. So is it the 3 operations? And this is in the awareness of the patients, of the parents. So they have their 3 operations, and then that's it. So we do have to do something there, because that's not the case, and that's not the truth. So there are many interventions coming up after that, and many problems also. Yeah, and people have to be aware of that, and that's something that I would like to discuss. Just briefly, let's not lose track of the other organs. So this is why the interdisciplinary approach is so important. We need cooperative centers, centers that know about the interdisciplinary circumstance, and they need to know what it means for the patients, and we need much more inter and multidisciplinary approaches. So I would like to ask our predecessors, so what are our questions anyway? The questions are, one is when is the right moment for listing? Why would we list if it's a Fontan failure or a ventricular failure? And what would we change? Or what alternatives would we use? Maybe the cannula. So we have to evaluate the signs and maybe not treat the symptoms for many, many years rather than deciding for a transplant. So what do we have here at hand with the cannula? Yes. I would like to talk about the game changer. 2012, I discussed this with a company, the support for the Fontan patients. Then after many years, finally we achieved this. And then we had the treatment, and now we have a state where we see that the reservoir is not necessary anymore. We have to think about it. And then Mr. Enhausen came and said, what do we do now? And they said, well, we have a new idea, a new design of the cannula. I gave it to him. And we have talked about this. And this is how we constructed the new cannula. And we have continued to experiment with it. And now we have a patent and the approval of the EU. And from the beginning, I said that it's not that I have a big interest in this cannula. We need to prove the feasibility of it. So it is implanted in Munich, in Berlin, and in Vienna, in 1 to 2 patients. And they didn't have any complications at all because of the cannula. And the implantation was also a preparation for the implant surgery, and improved also the waiting time for the transplant. And this is why I think that for all the developments that we have in the care of the patients, that is a game changer, the cannula. Of course, we have other measures. Mr. Feldman talked about them. We have to consider everything. But the cannula for the patients is a game changer for those patients who don't have another chance. Okay, thank you. So are there any questions in the audience? Because this is what we're here for today. We are always open to discuss anything and everything with you. Ms. Sänger. Are there any parameters from the doctor's new parameters to list earlier? Looking at the professor from Berlin, do you have new parameters? Maybe you can join the panel, and we will also greet you if that's okay for you. Stanislav comes now. Yes, new parameters. That's a good question. I think now we have to look at how the centers are doing that. How do they do the follow-up? How often do they look at the patients? Is it the MRT? Is it the catheter? Is it the load? Is it the oxygen? So we more and more have to draw conclusions when it is too early, too late. And this is why the centers in Germany have to get together. So every center has their 200 to 300 patients. So I can, luckily, I can compare Berlin. But what does Gießen do? What does Siegen do? So the parameters, the standardized parameters, we don't have them. So we have to look first at the centers, at their parameters, and then compare them. And then we may reach some general parameters. So Stanislav is in favor of conditioning the patients by doing sports, for example, by movement. So how can we prolong the time, the waiting time? So on behalf of all the families, there's another question here. So this is more about listing earlier, because there are many insecurities, and what's the reference there? But I would like to give the mic to, yes. Okay, two things. As a transplant center, we would like to see the patients long before they have complications in their puberty, for example, their teenage years. So, because why? 30% here, 20% there. We've heard that. So many will go the path of heart failure. And in these centers, even when they are adults, they end up in the EMA centers that are led by the pediatricians. And the earlier we connect them, even if they are in good shape, is important, not only once they have complications. That's my personal statement. I'm not sure what the others think. So we have PLE, and then we have a loss of proteins, and then we do this, and then we have an insufficiency, heart insufficiency. That's all too late. We want to see them earlier. 2 points. First, I think that as a transplant center, we are able earlier on to be able to see which patient we can prepare for an intervention. So you can't just list any patient. You need certain criteria. And once the patients come to us, and usually they have heart insufficiency, and they have transplant ambulances, and they have contact to people with a successful transplant. So that's important too, because people think that a transplant is a horrible thing. It doesn't have to be necessarily. Yes, thank you. I think that's very important. And that's what we like to get across here. So the listing criteria and the question, when do we list, is really very difficult to answer. So we could try and standardize it, but to do a prediction when we have a need or a necessity in the patient arising. So we have to evaluate in the process as early as possible, and we have to take into account the individuality, because the individuality is very important in these cases. And I think it only works well in very few centers, because you need a certain expertise for that. And this is why we have to be interconnected. And Stanislav has come to the stage now. So Ms. Zenger is asking, what do we do apart from elaborating listing criteria? Thank you very much for your invitation and the fact that I can climb the stage immediately. There's no new parameters. We know the parameters, and we know the problems. And one of the most important problems is the high tolerance level of the patients vis-à-vis their own situation. They can still go shopping, and they don't see why they don't see how they are making a successful transplant impossible for themselves. So we are still lacking a way and means to reach the patients in this regard. So they think they're capable of making this decision, but once they are operated and they are cut open, then they are facing risks that they cannot fathom, they cannot be aware of without being instructed about them. And so what we don't have is the number of transplantees in order to point our fingers at them in a positive way and say, if you do this, if you make this step, then you will be as well off as this person and feeling as well. So to be able to prove that it is necessary to the patient, of course, a register would be helpful because then you have all these data to work with. And then we need credibility vis-à-vis the patient. Because they think, well, I can still go shopping, I can still do this, I can still function in my daily life, and I don't need a heart transplant. What are you talking about? And once they're not mobile anymore, then it's too late in many cases, as we've seen. And so this is a lack between, or a gap between us and the patient. We cannot we can only convince them once they're feeling really catastrophic. So we need, I think, different factors to work with each other. So if we could bring everything together, like a score, and then come up with some kind of score and see, oh, there's a limit or a threshold. And we see, yeah, now we have reached the limit, and even if the patient is still standing upright, but we still have reached this limit, and we can prove it to him in this way, and we can convince them, because each case is a wonderful case. It's an individual case, and if we have a successful transplant, then there's a lot to celebrate. So in comparison to the adult heart transplant cohorts, of course, we don't have too much data. Yes, I have another question too. I am a mother, and you just said that the children in puberty should go and see a doctor. So my child is doing pretty well. Our cardiologist is here. We have a good Fontan-Herz. You have seen her in the video. She has a lot of power, a lot of strength, and she's very well in spite of her disease. So would you recommend, in this state of affairs, she's 15, go to a transplant center and ask them to check her, so that once the difficulties arise, complications arise, then the center knows what she was like before. Do you go to regular? Do you as a person, do you go to treatments regularly? Yes, I do. You just said that the transplant centers would like to see the children. So our cardiologist sees her regularly. The clinic where we go regularly, but the transplant center is not on my list of. At the end of the day, this is a part of the heart transplant, because this is about risks. We need to be able to evaluate the risks. So you should connect with those people who might, in the end, have a solution for you. Because a cardiologist needs to observe your child regularly. Yes, that's one thing. But you go to a heart transplant center. They are the ones who finally are going to do the surgery. So that's you can choose a center, and you can say, yes, I want to do the heart surgery here, and then the center can offer all manner of treatments apart from the surgery, and and then you can also use the time, because the time is getting longer and longer, and then So it's important not to go to the centers at the last moment and say, my child is ill, you need to do something. There's always time, but don't use the time. Don't lose the time. So from my point of view, Freiburg, I would say yes. We are happy about every patient that we don't have to operate. And I totally agree with this procedure. So I think it's extremely important that the patients do sports, for example. And if you don't have PLE, then we're happy about that. But once you have a PLE, once the tissue is damaged, then it's even more difficult. So from our point of view, Freiburg, contacting the center once there are problems, like the liver is getting bigger, etc., these symptoms, then that would be the right moment to contact the transplant center. So that doesn't mean necessarily that you are listed immediately and get a transplant immediately. No, you will have an evaluation. You will have an evaluation, and this needs some time. And then if we can do the evaluations while the patient is still relatively well and we don't have the risk of a heart failure, then it's too late. So it's difficult to find the right moment, I agree. But yes, you should go to a heart transplant center early on. So the data you mentioned, Ms. Zenger, are not current anymore. So fact is that after transplant from Fontan, the mortality rate in the first year is a little higher in comparison to other patients, but the long time result is stable, and we have a relatively low mortality rate, and it's improving. And so we have a small, a little bit of inflammation at the beginning, but the results overall are pretty well. So I wouldn't tie it to the age. I would tie it to the symptoms. One more thing. I would like to take the fear away from you. So there's not so much the transplant centers against a normal center. So we are normal physicians, pediatrists. And we can take a look at your child. Maybe with a background, or you don't have to go to a transplant center. So we are cardiologists. We do all the usual stuff. So don't fear that if you go, you don't have to go to a transplant center, but you need to go to a center that has all the expertise. Yes, that's what I wanted to say. But after more than 30 years of a pediatric cardiology, I still don't know the right moment when to list a patient. I wish I knew. So it would be wonderful to have a score. It would give peace to our souls, knowing that this child has the score of 8 out of 10, and then now they need surgery. So this is why this hint was very valuable, and I think we are going to hear about the register. So the register is very important. So it's not only that it's not that people who turn up in a transplant center are going to be listed right away. No, simply the a transplant center has means of evaluating the patients in a different way. And they know about cardiovascular problems in children, and they have the overview of what can be done, what should be done, etc. And we need to learn from our patient data. So we need to know, for example, patients who are doing pretty well in their everyday life, but they still have some insufficiencies in their valves. And what could we do preventively, even or another surgery, or in the we are trying to find new ways in our labs. Yes. So if we say that they should contact us, it doesn't mean that we want to take the patients away from the cardiologists. We couldn't even do that if we wanted to. It's too much work. So the mother just asked, and the idea is to contact the centers in time, so there's still time to do things, so that when we can see once they are deteriorating. We don't want to have them. We just want to see them once, and then together with the cardiologists, we can decide when it is a good moment to come again. So we have guests from the US here. So patients who are listed here in Germany have a very, very long waiting time. So if you see data from the US, in the US you have different problems. So there are many donors. We don't have any donors in Germany or even in Europe. So we have 2 years waiting time. So think about what can happen in 2 years. Mr. Schubert just said it, that's the mean waiting time. The mean waiting time in his center is 1 year. And this is for children who really are in a very bad state. But in our center, they wait, in Europe, they wait 2 years, more or less. So if you send us a patient that is already developing a PLE, then you have half a year until they are listed, and then it's 2 years until the surgery date. So this is why we need them early on. Yes, hello. I work in the psychosocial team in a clinic in Hamburg. And in our classes, we sometimes counsel children or students and their parents. And so the question of the register has come up. Some don't want to be put on a register because they are tired. They don't want to make that experience and enter everything that they've gone through. So we are trying to motivate the families and the patients to participate in these registers in order to have the data ready. And what I want to say is that we need to improve access to these registers. There's one from the German Heart Center. That's a newsletter that's sent around, and many teenagers said, no, I don't want to be part of that because I don't want to confront myself with this. So if you talk about a register, also the American gentleman, so I would like to appeal to the colleagues in the psychosocial teams so that we expand our work. Yes, that's part and parcel of it. Yes, Mr. Kramer is going to talk about the register in a minute. Yes, we depend on the cooperation of the patients. And we cannot lose them between 18 and coming of age. And so because we need a continuous treatment of the patients, and the psychosocial aspect is always being considered. And we understand every patient who says that they don't want to participate, but without their help or without the help of the parents, we cannot have our registers. That's also a clear thing. I think it's time to wrap up. Yes, one more question. I work at a pediatric cardiology center, so the transplant is not the last resort. So what is the expected survival rate of the transplant? The transplanted heart. Yes, that's exactly what we have to do, because the access to the donor organs is limited, and we've seen that the survival of the organ has improved considerably. It's not 10 years; it's 15 to 20 years. And also the Americans transplant more and more because it takes a load off the patients everywhere. And so we need access, we need availability, and of course we think long and hard about is this really necessary. But if we don't see the patients for 10 years and then they come to the clinic in a really a very bad state, then we have a problem. So we need to see them in the transplant centers, and this is why we try to raise awareness here. And the patients and their parents need to be informed about this rather earlier than later, rather sooner than later.
Also sort of feel compelled to make this comment. There is a tremendous fear about transplant. You hear it from the patients, you hear it from the families, you hear it from the primary cardiologists, that they're going to lose the patient in some way. I think we're thinking about this differently. And one of the solutions that we have come up with and is growing in North America is the development of Fontan clinics. A specific group of experts or individuals, multidisciplinary, including psychosocial experts, who are focusing in on the unique problems of the Fontan patient. And as part of that group, there is general surveillance and evaluations that take place that then also make a decision, not just about transplant. Transplant is one therapy, but is pulmonary vasodilator therapy appropriate? Is psychosocial emotional health intervention necessary? Is a particular other type of medication necessary? So this is where I think the field is going right now, and sort of general cardiology, then sudden transfer to transplant is, I think, what is concerning.
Yeah, this is an excellent comment. I have to admit that we in Germany do it a little different, only because we are more the ones for everything than in the United States. I know because I was just in Denver in ISLCHRT. So we see that this cooperation part is much better developed in the United States. In our country, I would say, it's a little different. That's we are more in charge of everything, so we not have to separate. So that's why we take psychosocial in our team. We have it in our team already, so we don't have to separate especially. But I think a Fontan clinic in regard to the number of patients is most likely the way to go, definitely. So, vielen Dank. Wir müssen aufhören, glaube ich, angesichts der Zeit. Ich danke allen Podiumsdiskutanten.
We need to stop now or close here
Und ich hoffe, dass wir einen Teil anstoßen
because
konnten.
of time reasons. I hope that we could raise some interesting points for you, and thank you very much for participating.
Mr. Schubert, thank you very much for this central definition of what can bring us ahead. And Mr. Kramer, Mr. Heiner, dear Heiner, this is the continuation of the current discussion, and I hand over to you immediately. Well, dear Steffi Sänger, the mother of the German Fontan community, dear Fontan community, that means all of you, whether you are parents, affected people, doctors, carers, psychologists. Hope I didn't leave anyone out. And I'm very happy that I can talk about something that's dear to my heart. It's about the German National Fontan Register. Yesterday I thought is it my turn after all these transplant stories? Because I'm quite grateful because we could see that we have come to a point where we no longer control things. Maybe nature doesn't want us to do it, but also maybe our strategies aren't optimal. And therefore, I want to point out we applied already for a register, and Mr. Hansen was the co-author of this application. The numbers are quite substantial in Germany, 250 to 300 patients we have with a univentricular heart, and so meaning over all 3,500 to 4,000, a total number of Fontan patients. And it's not about the numbers itself, it's about the heterogeneity of the univentricular heart. And from the right heart hyperplasia to left heart, etc., everything is leads to different problems, but maybe these different heart diseases and problems can also lead to new ways of an acute treatment. These are numbers from the New Zealand Australian register. For hyperplastic left heart, the numbers seem to be quite low, but otherwise they show the heterogeneous characteristics. You cannot treat them the same, and you can see that there are differences also in the acute and also in the late mortality. If I have a very stiff left chamber, then it's a different story from other problems, and hyperplastic left heart to double outlet right ventricular. And so these are patients that went to the anatomical types of hyperplastic left heart syndrome, because these figures are quite low in every category. I can also jump over it. Mr. Kostek-Feldman also mentioned it, raising all the problems, and but he mentioned that we don't have good studies for it, and we cannot accept it, that we don't have good studies regarding this. We need research, we need science, and the picture behind me shows it. The research in the middle, only this leads to help. And we're no longer in the late 50s or early 60s, where pediatric cardiology was in its early stages. But that we are successful shows that many patients get to reach adulthood, but 30% of the patients have grave problems. We also have Super Fontaine with 18 years who are saying, what can I do? I'm doing everything, but it's about treating and recognizing the difficulties, and you can see the figures here, 1,500, 1,600 patients that entered their data in these studies. In previous times, I had to stop at 150. So this is also, we heard about the causes of Fontan failure, that the dysfunction of the singular systemic ventricle, or anatomic problems in the PLE, and this is the picture of a bronchitis fibroplastica. The end organ damage, we mentioned that too, from liver diseases that Mr. Hansen is dealing with, and kidney dysfunction and rhythm disorders. Here is the picture from the New Zealand Australian Register, published in 2019. This is the rhythm disorders, and it's not something unknown, but we also talked about thromboembolism and anticoagulation, where they did very good studies, and they did this in 2009 already, and we already said that we need better scientific studies and case numbers. This is an absolute condition, and so you can say that you cannot have all the patients in one pot, so to speak. You have to form subgroups, subcategories, and from this, whether it's anatomic or strategic or characteristic, you can draw your conclusions. That's how science works. and monocentric studies also reach their limits. Therefore, we need a multi-centric studies with a lot of data. And in order to make these data available, they have to be standardized in a register, not here a little and there a little. But what's optimal is a common approach simultaneously where the same diagnosis is being done in order to have good prospective studies. The structure is decisive, and this has to be guaranteed. So, yeah. Are there any Fontan registers aboard? There is the Australian-New Zealand study for 10 years already. The American colleagues also started a study with a really good website with a donate, 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 but that's also part of it. In Germany, we were asleep, not really, but we weren't successful. And that was really something annoying for me. That was one of my biggest failures. I tried to motivate Sven Dietrich in a meeting in 2019 about multicentric studies. I think we did this meeting in Frankfurt, and then in 2019, Mr. Wutzki is here, Mr. Jux, Jans Hansen was there as well, and from Berlin and Munich colleagues were there. We applied for financing to the German Heart Foundation, but they were not interested. Also, in the follow-up time, I was also in a working group of pediatric medicine and pediatric cardiology, and but we have to make sure that we can do something without the this financial power of the foundation. Regarding the concept for the development of the German Fontan register, the precondition is obviously that we have a national register, that we have ethical guidelines, we have summarized everything there, and we can use it, and the data are coming in a web-based form, and therefore by the individual centers. So you have to make sure that you can guarantee a high data quality. We have to do monitoring for this, and all of these questions, we have heard them before today, and I could go through them individually, but we all know that there are so many open questions that have no evidence. One has 5 to 10 cases. We do it like this, we do it like that. But what's important is we get the statements of scientific studies. We always start with ideas, but they have to be supported with good data scientifically. Otherwise, we won't be successful. I'm also not in favor of having registered data in order to let them sleep. A register is a precondition for good studies. Not first of all, you have to do it retrospectively with a lot of numbers, but in the long term, there have to be prospective studies. Mr. Schubert has the idea A, and another one in other has another idea. We have to have comparative studies in order to have a good preparation and a certain power behind it in order to get a result. And then we also have the bioregister, biodatabase, and so we also do genetic research, and we also do the phenotyping, which is very important. So these are figures that I compiled, of course, regarding the cost of such a register. Some people would laugh at these figures because it's very tight. We didn't have a lot of money. In Schleswig-Holstein, we had to turn €1 into 2, so to speak. The centers are to be paid for including the patients, including their studies. the premiums for patient inclusion, for example. But these are figures that we can use, and what's also important that the register has a long-term success and it's not ending after 2 years. So we need constancy, we need continuity of the carrier, and they are being led into from the previous sponsor, the BMBF, into the Berlin Institute of Heart, but we're not leaving everything for the Charité to do. The Berlin, the study center, the clinical study center, excuse me, has an interdisciplinary and cross-campus structure for clinical studies and is also responsible for establishing and maintaining registries. And I'm very grateful that the State Secretary built this bridge to the BIH, and we can use the infrastructure from the biodatabase. Everything is there, so we don't need to create it again. So we have the basic financing for the National Register, and which is being paid via the BIHF, and of course it has to be paid separately. How can we do it? If the Heart Foundation does not want to do it, as it seems, we have to do it ourselves. We will manage to do it. We have strong engines here. We have a strong community. We can apply to other carriers. There's crowdfunding. Well, I don't want to specify it any longer, but please, let's all make sure that we work in the same direction so we can give a better future for these patient groups. We have achieved a lot, but we haven't reached the end, and that's why we need our register. Many thanks for your attention. Dear Heiner, I'm really blown away by your engagement and your straightforward demands that you have mentioned. Is there anyone who sees it differently, or how would you be ready and prepared to support such a crowdfunding? I would stand here and say, yes, it's the only way to do it, because it's also the possibility to get a certain breadth. Can I give the microphone to you briefly? Many thanks. Just a brief comment I wanted to say. There is already 1,700 patients in a register. It's depending on how we process the data, and students are already working for it. I just wanted to remark on this, not that we think we have nothing, but also these multicentric studies. These are the epidemiological studies today, and multicentric studies, when it comes to precision of the statements, it can be just as good. But it's only about how we ask the questions and how we process the data. So, of course, Mr. Kramer, I think it's all very important, but you have to understand it. Not every multicentric study gives us an answer of the question that Mrs. Sanger had. For example, when and what can we decide? Because multicentric studies are focused on very simple questions. They give an overview on the patient cohort. So if we have a multicentric study and want to have such a precise answer, then we need a certain standard that are maintained by everyone, because otherwise we only have a number of data of a multicentric study, but they cannot be processed accordingly. I just wanted to say briefly that on behalf of all the families of all affected people in Germany, that it would be sad, or it is sad for us, that we cannot say how many Fontan patients are living in Germany. And we are clearly in favor of a Fontan register. We need it very much. And we are also looking forward to the presentation of Mr. Itzig, that, to present us the situation in the USA. But who would be against a Fontan register in this room? If I can we have 1,700 patients, as you say, that we have found, and but I don't want to prevent it. But is there any prospective randomized study in Germany? I don't know any single one. So do we have an identical storing of data? We have 1,700, but you can't just put them in one box. We can do it, but we can do better, I think. I think it is better if you work target-oriented and looking forward. The moderator wanted to make an announcement, technical announcement. We are under somewhat time pressure, and my proposal would be get a cup of coffee and please come back to your seat, and then in 10 minutes we can continue. And secondly, Mrs. Sänger is holding it up. If necessary, please use and return and use your headphones so that you can listen to the simultaneous translation. And I think this, the next presentation will start in 10 minutes. Thank you.
he will give us the American perspective in terms of the register and in terms of the diagnostics of PLE. Thank you, dear colleague. Floor is yours.
Thank you all very, very much. And thank you, Steffi, for this invitation. It was so surprising for me to get an email from this organization. I'd not heard of any of this activity previously. And it just so happens I'm in Europe for another meeting, and I thought this would be a great opportunity to spend some time here. And it's really wonderful to see this collaboration between patients, families, and providers. So what I'm going to talk about here, and I have allotted, I think, about 40 minutes, but I'm going to try and reduce this as much as I can to see if we can pick up on some time. I think the monitor here is not working, but it's working here. And so all of these complications, all of these explanations accrue as time goes on, as you go all the way from fetus to an adult. Now, modifying this also is the fact that there's tremendous variability in these patients. We don't understand what the biological mechanisms are, and we are not yet fully clear on what the genetic influences may be, both on predisposition as well as resilience to some of these morbidities and some of these stressors. So here's a model I propose to you as to how to think about the various morbidities and pathologies that we have. What are those morbidities and pathologies? There are a number of them, but I'm again going to limit this specifically to just a few of these, and in particular talk about the lymphatics first. But what many of us have come to put this together as is something we call the Fontan circulatory syndrome. It's a series of well-known, unique complications and challenges that these patients have to variable degrees. Let's talk about the lymphatics. So the lymphatic system in a Fontan circulation, there is elevated central venous pressure, obligatorily in all patients, increased lymph and tissue fluid and impediment to drainage, and then this leads to some form of lymphatic insufficiency, but not all. Why don't all Fontan patients have PLE? They don't. It's only a small percentage, about 10%. This is from work that's been done by Yoav Dori and Max Itkin, who you're going to hear from shortly, really pioneers in this world of the lymphatic circulation. And what we suspect at the moment is that the reason the lymphatics fail in about 10% is that there is exteriorization of the drainage. There's a high venous pressure, the congestion of the lymphatic system, and in some select patients, the body thinks that it's being smart. It says, oh, the lymphatics are congested, let me find a way to decompress. What are the two ways to decompress to the outside world? Through the gut, through the intestines, and through the airway. And so in a small percentage of patients, the lymphatics decompress into the gut, forming PLE, or into the airway, forming plastic bronchitis. And this, again, was work that was demonstrated by Max Itkin and Yoav Dori, showing that PLE is directly related to lymphatic connections, probably primarily from the liver, that then drain into the gut. And unfortunately, in some select individuals, there are the ravages of protein-losing enteropathy and the airway obstruction that you see here. What we also have learned is that although 10% may have this severe lymphatic insufficiency, almost everybody has some degree of lymphatic derangement. And this is work that we and others have replicated as well, where we do find evidence of lymphopenia in many of our patients. Relatively low lymphocyte levels, mild levels of hypogammaglobulinemia, of low IgG, not to the extent of causing low oncotic pressure in PLE, but enough that when you check their laboratories, you see that these patients are lymphopenic. And as a consequence of the lymphopenia and the derangement in T4 and T8 cells, we are seeing an increased frequency of atopy, which essentially are various allergies, and sometimes difficulty with warts or molluscum. So I challenge you all to examine your Fontan patients next time they come to see you in your clinic. Take a look and ask if they have warts, because many of them do have major complications with warts and molluscum, which we think is related to the mild lymphopenia. Of course, some of these complications can be much, much worse when you actually have protein-losing enteropathy. And when we look at the lymphocyte counts in our populations over time, what we see is the percentage of patients with lymphopenia, defined as an absolute lymphocyte count of less than 1,000, increases as time goes on from the Fontan procedure itself. What are some of the other consequences of having a Fontan circulation? We know that growth and development can be impaired. And so this is data from a series we published of over 200 individuals with Fontan. 180, actually about 220, 185 had no PLE, 25 had PLE. And what you see here are the Z-scores for height, the height-adjusted bone mineral density Z-score, and the lumbar spine bone mineral density Z-scores. These are values that tell you through DEXA scan assessments the degree of bone mineralization. In green, you see the non-PLE patients, in red, the PLE patients. The average for all these groups are less than 0. So that tells you something about the general population overall. Even in the non-PLE patients, the bone mineral density Z-scores are lower than normal. And certainly in our PLE patients, they're quite low, as you see in red, minus 2.4, minus 1.29. And why is this so? Why is bone mineralization a problem in these patients? Because almost all of them have some degree of risk for secondary hyperparathyroidism. So what I'm telling you here is that having a Fontan circulation alone perturbs your state of homeostasis, in particular from a bone development perspective. The percentage of patients with an abnormal parathyroid hormone in the non-PLE population was nearly a half. And in those patients with PLE, it was over 80%. And one of the things that we've also found in this population is a profound degree of vitamin D insufficiency, which can be readily remediable with supplementation. So those are the ravages of PLE. Let's get into some of the pathophysiology and some of the mechanisms, perhaps, of what we see. And this has been well known for about 20 years now, that inflammation clearly plays some role in PLE. And these are some examples from endoscopies, looking at both intestinal, colonic, stomach, and duodenal inflammation. When you begin to dive into some of the histopathology, it's also been shown that many of our patients with PLE after Fontan have a depletion of sulfated glycosaminoglycans. These are important molecules that help protect the integrity of the intestine, and these are often diminished in our patients with PLE. So if we take our current understanding a little bit broadly, it's not just about the lymphatics. From my standpoint, certainly the lymphatics play an important role here, but I think you sort of have to take a step back and look at the entire context. We know our Fontan patients have increased central venous pressure and decreased perfusion to the gut. This leads to lymphatic congestion, increased production, and lymphatic insufficiency. There's decreased mesenteric blood flow, and then inflammation as well, and then a loss of heparan sulfate from the enterocytes. And this is from a paper, a multi-center paper that was just published in 2022, which I think is a really nice summary of our current approach to PLE. So this is our current understanding of the mechanisms. What about the clinical consequences? And this, again, unfortunately, very well known to the patient population who's here today, but of course, many of us who are interested in Fontan, we've all seen patients with a number of these complications. Low serum protein, low immunoglobulins, consequential edema and ascites because of an altered oncotic pressure. Difficulties with the GI tract. Sometimes it's not always diarrhea. Sometimes it could be constipation as well. In my experience, I found that the diarrhea is something that you see in patients who've had chronic PLE because of bowel wall edema that develops and maybe a change in their microbiome. We're going to hear about microbiome shortly, but I think that probably plays an important role. Maturational delay, malnutrition is a consequence, poor growth, a risk of lymphoproliferative disease. Very sadly, I've seen this in a number of my patients who have chronic PLE, who then get Epstein-Barr virus infection, have mononucleosis, and then develop lymphoma. And this has been reported as well. And then there's an increased risk of thromboembolism when you have PLE, and unfortunately death. Have we made a difference with this condition? Well, it was first recognized, PLE was, in the early 1990s, and this is a classic curve by Luc Mertens, who was in Toronto now. He was in Europe at the time. He did a very nice multi-center study and showed essentially that by 10 years out, over 80% of patients with PLE were not alive. Where are we today? We've made important strides. We've made a major difference. And so this is from even now, maybe 10 years old already, and I think the data is even better now. But back in 2014, the graph shows that the 10-year survival is closer to 70%. So we're making progress. The concept of developing somebody with chronic PLE is becoming much, much more common. But if you look at any of our PLE patients, there are sort of 4 ways in which they manifest their clinical state. There are those who have subclinical PLE. We don't really know about them too much, but perhaps they're out there in the community. Unless you look, you're not going to find those particular patients. Then there are type B, in which some patients have one episode, often after a viral syndrome, hinting at the inflammatory component to this, and then nothing. Then their PLE resolves, and they're fine for extended periods of time. But then, of course, those patients make us worry, and we monitor them. And then there are type C and D, as you see here, where sometimes there are flares, patients are steady, flare again, patients are steady, but with a chronic increase, and then those, type D, in which there's progressive severity of the PLE until we get into a difficult situation. I would say right now, probably the largest number of patients that I see are in category C, who have flares, who are being managed in one way or another. But with the passage of time, it's not uncommon to see some individuals who've had PLE for 10 years and are still alive, but still suffering from the ravages of the disease itself. So a few points that I think hint at the mechanisms. PLE in Fontan affects less than 10% of all individuals. Why not all Fontans? Because those principles are all there, but it's only in a unique 10%. PLE in Fontan develops independent of the hemodynamics. And what I mean by that is, I'm sure folks here have also had this experience, it's not the Fontans with the worst hemodynamics. It's patients who have excellent hemodynamics. Fontan pressures of 10, good-sized pulmonary arteries, an end-diastolic pressure of 3 with good ventricular function. But simply having the Fontan and venous congestion and lymphatic congestion, they end up developing bad PLE. And then a third concept that I'd love to get some feedback from people on, and I think this is true, it's a suspicion of mine. PLE does not develop de novo in adults. I have yet to hear of a patient who was 25 years old, who didn't have any PLE before then, who then suddenly developed PLE at age 25 or 30, even with worsening hemodynamics. And what all of this suggests to me is the concept that the disease is related to an abnormal substrate, an abnormal lymphatic architecture that maybe exists in all of us, that once it's exposed to the Fontan physiology, even good Fontan physiology, leads to enteric protein leak and an early time frame, usually within the first decade after a Fontan. Now again, just to be clear, there are many 25-year-olds who do have PLE, but they've had it for 10 or 15 years. Developing it for the first time, I don't think is something that we see. So here's where we're going to save some time on the lecture here. I have a number of slides, and I'm happy to share this, but it really relates to the algorithms for treatment for these particular patients, and there is a stepwise way in which to organize how we approach this, and I'll refer you to these papers. One is from our center at CHOP, and the other is a multi-center study by Tarek Al-Said, both published in the last 2 years, and they summarize what I'm going to talk about in the next few slides. I will mention that one part of the strategy for managing these patients is using steroids, and I do want to make a few comments on that. We first reported the use of oral controlled release budesonide this is probably back in 2010. And I remember the conversation I had with a mother who was terrified of a transplant, and her son had exhausted all the options. This is before we had lymphatic interventions as an option. And the mother said, I really don't want a transplant. I want to try anything else. I have a cousin who has inflammatory bowel disease, and that cousin is on this medication. And if you think inflammation has anything to do with this, let's try this medication. So we tried it in this young man, and his PLE disappeared within 6 weeks. And then we tried it in the next few patients, and then other centers around the world started to try it again, and it worked. But here's the problem with this. So multiple centers have reported success of the use of Entocort. It's highly effective when it's initiated early on at the initial onset. So you're 6, 9, 10-year-old with PLE who has normal hemodynamics, who presents for the first time, going to a high dose of oral controlled release budesonide, Entocort, can be effective in that population. But you have to remember, it's less effective in the older patients with chronic PLE, and it's metabolized by first pass in the liver. However, we know our Fontan patients don't have normal livers. So therefore, anybody who goes on this medication, who's a Fontan, is potentially going to have Cushingoid features, and you need to be worried about that. If you don't have a response to Entocort within a 3-month limited period of time, the medication should be stopped. And what's happened, unfortunately, worldwide here is that there's a fear of proceeding to the transplant. Physicians with good intentions continue to offer steroids without benefit, but you get all the negative side effects. So that further accentuates the worsening of the state of these patients, and they don't become transplant candidates because they have wasted bones, Cushingoid features, et cetera, et cetera. So Anticort plays a role, but only in a limited number of patients. We categorize our patients at CHOP in 3 ways: those with non-sustained hyperproteinemia, sustained hyperproteinemia, and those with chronic PLE. And although this is really important, I'm sure you're going to want to see this, but for the sake of time, I'm going to just quickly go through these because you can research them on your own. We have a protocol diagnostic evaluation for how we approach these patients, and then essentially in a stepwise iterative algorithm, perform initial therapies, which relate first to diuretic use, proper anticoagulation, because these patients are at high risk for thrombosis, more than your usual Fontan patient. We are very much in favor of the use of high-dose aldosterone inhibition, so using drugs such as aldactone and such, or eplerenone play a role. And pulmonary vasodilator therapy, we believe, is helpful even when the Fontan pressures are low. That's first-line therapy. The second-line therapy would be to go towards the use of Anticort, our oral controlled-release steroid, but for a limited period of time. Very important. For a trial for 3 months, if it works, you slowly wean it and then continue maintenance doses. If it doesn't work after 3 months, you must discontinue it because it will harm the patient. And then third level are those individuals who fail the initial medical management and then would present to our lymphatic team, and you're going to hear a lot more about lymphatics in the next few lectures, and then consideration as well for heart transplantation or even a Fontan takedown. There are many, many different therapies. I've not included all of them here, but I put a few of them up there in the red, which I have to tell you we have decided has not been effective, so we have stopped using sub-Q heparin or octreotide or dopamine or midodrine. So let me shift gears from PLE to our Fontan Outcomes Network and talk for a few minutes about our registry. Because it starts really with this primary question: how do we begin to make a difference and optimize outcomes in these individuals? So we need to work towards better understanding the uniqueness of every single patient with a Fontan and take what we now know, create more effective models of care. So it relates to not waiting for a problem to develop, but being proactive as we evaluate these patients, knowing that problems potentially can develop. So awareness, screening, and surveillance, and a culture of screening and surveillance is critically important. And I have to tell you something that perhaps 10 years ago we weren't doing at all. We were so grateful that these patients were alive. They'd come to clinic, we'd give them a hug, we get a Christmas card. You know, we have such close ties to our patients who have a Fontan circulation, but we need to be much more proactive in how we approach these individuals. So I mentioned it earlier, one of the ways that we've decided to do this, and this is now catching on in North America, is to develop a dedicated program that we call our Fontan Forward program, where we focus in on these unique challenges and complications. The idea of this program is to bring people together to harness the skills and resources of subspecialists, liver doctors, psychologists, endocrinologists, immunologists, who are not reading about the Fontan, who have managed and have experience seeing Fontan patients at our clinic and are comfortable in the lingo and the language of the Fontan circulation. It gives us the opportunity to establish standards for comprehensive screening, and by cohorting patients, by bringing patients together into these clinics, we gain experience that then circles back to allow us to improve outcomes. So for our particular clinic, the word FORWARD stands for Fontan Rehabilitation, Wellness, Activity, and Resilience Development. It's a positive, optimistic outlook for what we're offering our patients. Each one of these clinics, which is held once a month, we see about 6 patients. We have a cardiologist, a hepatologist, an endocrinologist, and an immunologist meet with them. So a lot of resources, very heavy resources involved in this. And now, further, in the last 3 years, we've brought in some additional specialists. So they meet with an exercise specialist, a psychologist, a nutritionist, and we provide them an educational experience. Because honestly, I have to tell you, if you ask any of our Fontan teenagers, what's wrong with your heart, very few of them can actually explain it properly, which I think is actually our fault to a degree. This is a picture of our team at one of our clinics. We're missing a couple of individuals, but again, our liver specialist, endocrinologist, psychologist, et cetera, et cetera. Many of you are familiar with the recommendations that we came out with in our guidelines back in 2019, which provided the beginnings of a structure for how we can go ahead and proceed with performing surveillance. Again, this is just one way to approach this. We actually divided it into organ systems and 3 different ways of surveying, sort of the basic surveillance, in-depth, and then things that are investigational. But certainly for groups that are thinking of starting to develop things like this, I would refer you to this as a starting point and some recommendations. This was an international group that got together and put this together. The other beauty of a Fontan clinic is the ability to collect data and to actually learn from what you're doing. So here we have, this is actually from a couple of years ago, but here's just some simple graphs of basic assessments that we perform. So how many of these patients are on different medications? You see here, over 80% are on aspirin. Still about half were on ACE inhibitors. That number is going down. About a quarter were on Lasix, and about 10-11% or so on behavior-modifying medications and such, which we're actually promoting and advocating for those who need it with an increasing number. And you get a sense here as well as to simple things like platelet count. Platelet counts do drop in these patients as time goes on, likely related to splenic consumption from the liver disease, as well as other variables. And so in the last few slides, taking this concept of a Fontan clinic nationally is what is happening right now. And this idea started, it's taken us a while. This idea started about 6 years ago, this concept of a multi-center Fontan outcomes network, where the vision here is to improve outcomes and quality of life for all individuals with single ventricle heart disease and a Fontan circulation. It's both a learning network and a clinical registry. So what is a learning network? It's a sort of a specific way to perform quality improvement science in addition to enrolling patients in a registry. And the idea here is to build a community of patients, families, clinicians, and scientists. And let me tell you, the executive leadership team of this organization is made up equally between patients, parents, and healthcare providers. We now are fortunate enough that we actually have patients, including one pediatric cardiologist who himself has hypoplastic left heart syndrome and is a Fontan, and is an active part of our executive leadership team. What are some of the things that we plan to achieve? To discover and implement best practices through quality improvement work, to catalog the clinical course and map the trajectory, because I think as you're hearing here, there are wide variations in how patients do. Many patients are doing great, and some are not. And why is that so is something we still don't fully understand. We need to understand the contributors to this variability, and the only way to do that is to map the course of these patients over time, prospectively. We started out initially with 12 founding centers. This is 6 years ago. We now have an additional 19 centers, so there are 31 centers that are part of the Fontan Outcome Network. Now, across North America, 2 centers in Canada that have joined as well. And the idea here very much is to build community, awareness, communication, and engagement. What do our activities include? We have a twice-a-year annual meeting. We have a single ventricle patient day where we invite patients to come for educational purposes. We have case review conferences that are held monthly. So one of the benefits, of course, of COVID is the use of webinars and such. So we have any one of the 31 centers hosts a case review conference, and they share over about a 90-minute period of time their experiences and talk about various topics. And also, we've created a single ventricle connection chat where patients can actually communicate with each other. It's incredible. I mean, you probably see them here because there are many of our patients here with single ventricle, but if you ask anybody in clinics, have you ever met anyone else your age with single ventricle, 95% will say they've never met anybody. The parents will say, well, you know, we shared the room with this and this, you know, last time they were here. But this is a way for patients to actually communicate with each other and to begin to create social circles amongst individuals who have this medical problem. How are we going to collect the registry data? It's prospective enrollment with an informed consent of all ages of patients living with a Fontan circulation. There's a central IRB, so there are some regulatory issues that are specific to us in the United States. The central IRB is out of Cincinnati Children's. Enrollment takes place through each of the participating care centers. So it's not the patients that are adding the data to the registry, it's the centers that are doing this. And the registry just launched with a collection of data in 2023. Our goal at the end of this year is to have 1,000 patients, and over 3 years to have 10,000 patients enrolled in the registry. Data will be uploaded into the central repository. For the sake of time, I'm not going to go through each one of these, but there are a number of different data modules that we have that relate to different collections of data that we're putting together for each one of our patients, including heart failure and transplant. So what can we conclude? A pathway for survival does exist for those patients with single ventricle congenital heart disease, but we know it's full of challenges and hurdles. The Fontan circulatory syndrome is not just a cardiovascular phenomenon, not just something to be cared for by cardiologists, but it demands a multidisciplinary approach because it involves multiple organ systems, PLE being, of course, one of the most challenging. As more individuals do survive, we're going to be having more conferences like this. There are more and more patients that are surviving, and that's a consequence of the surgical skill set and such. But we have to understand why there is so much variability in outcome and whether any of the variables are modifiable that will then allow us to change course. If we can identify through a score or through some system that somebody is heading towards development of PLE in 5 or 10 years, then maybe there's something we can do at the time of the Fontan to change that, either medically, surgically, through some intervention. So it's not just transplant or no transplant. There's a lot that can be done and a lot of new things that are being developed along the way as well. I finished my cardiology fellowship in 1991, so I put this graph up here. From 1992 until last year, here's the PubMed search if you search the word Fontan for any publication. So the amount of knowledge that we're gaining is increasing, but I anticipate this will increase even more as time goes on in the coming years because our patient population is increasing. And here's just a number of pictures of some of my patients who are actually doing quite well, some of whom have had PLE and have survived and doing well. So I want to end with this and thank you for your attention.
And probably be able to collect from each other's knowledge. Gibt es Fragen, Überlegungen, Hinweise dazu? Ich gehe hier ein bisschen auf die Seite, weil ich, wenn ich da stehe, nichts sehe, wer hier sagt.
Yeah, thank you very much, Anselm Übing from Kiel. Very impressive presentation, and this model of prospectively collecting data obviously is compelling and fits very nicely with what Heiner Kramer just alluded to. My question would be not thinking about data protection issues and things like this, which you have all sorted out for your US and Canada network. Could you imagine this network opening up internationally to other countries, such as Germany? I mean, anybody could participate principally.
Yeah, so the question relates to whether this could open to German centers and such. At the moment, I don't see immediately why not, except looking at the entire system that exists that's different. So we included some Canadian systems who are somewhat similar to the way we function. But let me mention to you, because I didn't, the other person earlier was kind enough to show the money slide. And I didn't show you our money slide because the entire concept is very different. So we have centers pay to be a member of the Fontan Outcomes Network. So each center, each one of the 31 centers, initial fee is $10,000, then it goes to $15,000 a year to participate. Now you may say, why would centers be paying to do this? It's a different culture, it's a different setup. So each center wants to be motivated to be a part of this network. Why? Because it will lift all boats by having more population, more centers involved. Each center then can have the opportunity to take ownership of the collective data. So even a small center who joins can't have access to the 10,000 patients we hope at the end of 3 years. And some of their trainees and fellows may be able to do research projects and such. And so there's an entire sort of different philosophy to how we're doing this. Now, we need to create value for that $15,000 a year that centers are going to be contributing. We think that we can, because the model for this exists in other diseases. But it's the centers that are contributing. Parents are involved. Parents and families are pressuring centers to participate. So when you talk about, crowdfunding and such, the way it works for us is that we are telling the families, go to your cardiologist to tell the division chief they need to participate in the Fontan Outcomes Network, because if they're excluded, then they're not going to be up to date with what's going on. So it's a little bit of a different approach, but I think that's what's essential. Fundamentally and theoretically, I would love to be able to share what we do. We have to be able to share what we do worldwide. So I think as these different registries around the world begin to emerge, yes, we will need to be able to share data, because the strength of all of these is in the number of patients we enroll. The more numbers, the better the data.
Thank you.
Yeah, thank you. I found two things very remarkable on your presentation. The first thing is that you do not only have the medical aspects in your registry, but also the emotional aspects and aspects of quality of life. So this I found very amazing. And the second thing is that you bring the professional doctors things, what we have in doctor associations here, together what we have in the patient groups, obviously. So that you do not have a border between these things and a cooperation. It's just one thing. I think this perhaps can also be an impulse here from today. I think this is really great. And from the centers contributing, so they don't feel a competition amongst each others? Is that an issue for you sometimes?
There will always be competition. There's no question. But what's interesting is the competition has become between my center and other major centers wanting to participate because they know we are participating. So each thinks, nobody wants to be excluded. Nobody should be excluded from this, because there is a worldwide concern, tremendously increasing number of resources that are being applied towards these patients. And the argument that I use with our hospital administrators is to say, we have to contribute the $15,000 now, otherwise it's going to cost us millions of dollars in the next 10 years as we try to manage these patients with long hospitalizations, with transplants, with VADs. We need to be able to do better to improve the quality for these patients, and also to be cost-saving by doing that. So I think that's a compelling argument, if it's well formulated, to not just the doctors, but to the hospital administrators, to say it's an investment. It is cost up front, but it's an investment in what is a growing need.
Wenn jetzt keine weiteren Fragen sind, dann thank you very much indeed, Richard. Ich würde jetzt Herrn Kollegen Kalil.
No. I would like to ask Markus Kalil to talk about intestinal microbiome and Fontan. Dear Mrs. Sänger, ladies and gentlemen, thanks for the invitation. I'm very happy to be here. And I was asked to talk about our research project, intestinal microbiome in Fontan, which I'm carrying out with in Gießen with the Clinic for Pediatric Cardiology, Professor Hein, the head of the Microbiological Institute, and within this presentation, I would also show you some results, some preliminary results. I'm pediatric cardiologist, not just, but also a science fiction fan. And yes, I found this title, We Are Not Alone. This is true, we are not alone, but it shouldn't say signals from the ether, but it should be signals from the intestine, because from the gut, because ladies and gentlemen, we have a lot of inhabitants, so to speak, 30 trillion bacteria. More than half of the cells that we have are not human, so to speak. And these bacteria are responsible for 2 to 3 million genes. So there are so many signals that are being coded. So you ask yourself, who controls it? Is it us or our gut? But the gut, so much we know, the microbiome signals have many functions in our human body. And we also know that many diseases have their cause in a wrong composition of the microbiome. And the microbiome and also in the metabolics, and microbiome develops during the birth, and it develops 2 to 3 years until it reaches the multitude of functions. And these first 1,000 days, these are enormously important for our patients because therefore they have a long, intensive care time, and a lot of them have to be treated with antibiotics. And microbiome is influenced by many factors. It starts with the birth mode, whether we are being breastfed or not, our genetic composition, where we live, who we live with, whether we have pets or do we live on a farm, do we take drugs, and also our food. And that is a very important, our diet is a very important part of the microbiome. The functions of the microbiome are multiple, and it's a very complex, for example, when it comes to the degradation of hard-to-digest carbohydrates and dietary fibers. And these are very important for as an energy source and regeneration, but also as the butyrat is an anti-inflammatory. And of course, the microbiome is also important for other metabolic aspects, especially for the mucosa immune system. And we know that an imbalance of the microbiome has a share in many different diseases, but we are just starting to understand it. And we know that more and more neuronal diseases are due to the imbalance of the microbiome. We have a intestine pulmonary axis, so to speak, and diabetes and other diseases have to do with dysbiosis and an imbalance in the microbiome, and also the heart. And why are we so much interested in the intestine, in the gut? Of course, we have the heavy complication of the protein loss. I don't think I have to say very much about it. It's a heavy complication. It's very difficult to treat. And it's very clear that our imagination is probably too simple and is insufficient to to understand this complication, this complex complication, and yeah, it's also quite interesting what we can see with many PLE patients and in Fontan patients, that there is an episode of PLE starts after an inflammation, for example, of gastroenteritis. There's an interesting paper here that was published in 2015, and you can see here that after one episode of a gastroenteritis, in this case, it was a tuberculosis, and the mucosals were influenced heavily. We talk about scarring here, and so the authors postulate then in predisposed individuals an infection is sufficient to have an influence on the balance of the mucosa, and it's due to protect the internal body sphere, and has a big share in our immune system. For example, you can imagine if you see that we have the healthy state here, and we have a Fontan patient with a higher predisposition for PLE, then gastroenteritis can be enough to move to the state of an illness, and it takes a lot of energy to get back to the healthy state. But patients with a lower predisposition have a higher border, a higher threshold, and the ball would roll back much easier. So what are the mechanisms that lead to this? And it was said that inflammation seems to be playing a big role. And we are talking about a multifactorial pathogenesis. We heard about the lymph system and the liver damage, tissue damage, and also the inflammation of the gut. And I think the inflammation of the gut is also in the center of the disease. If we talk about the heart insufficiency that leads to a worsened hemodynamics, then you have the bacterial translocation, you have the inflammation can be increased, and that also goes for the heart insufficiency. So it's a self-strengthening loop, so to speak. And this is also the gut hypothesis of heart failure that includes the microbiome, and with the three pillars, so to speak: barrier, and dislocation and inflammation that leads to the imbalance of the microbiome. And if we look at the picture, then when it comes to heart insufficiency, we have a barrier translocation that can lead to an inflammation and dysbiosis, and we can then have increased inflammation causes, and from a heart insufficiency, it's associated with high inflammation markers, and it was always tried to block them selectively, but it wasn't very successful. Maybe that also due to the fact that we have alternative ways for these inflammation markers, but also that we have an inflammation in the gut that keeps the whole thing alive. And so what does it look like for our patient? Yes, if we look at the study that was carried out with 41 patients, and if you try to compare the PLE patients with Fontan patients, and here we looked at the calprotectin values, which is a marker for a gut inflammation. You can see here clearly with PLE, they have an inflammation of the gut in contrary to the people without PLE. That was already known, but we could also prove it, and by looking, we also have a higher number of people as subclinical patients that have probably a higher risk. One patient in this group, unfortunately, also developed a PLE. Another aspect here is the intestinal barrier problem and the translocation. This is where we have a study with 68 patients, 14 had PLE, 54 didn't, and after that we looked at the intestinal barrier, and we looked also at the bacterial translocation, and here we could see clearly that PLE patients had a intestinal barrier disorder and also a bacterial translocation. So this confirms the theory. And then we looked at this data in somewhat more detail. They have just been compiled by a friend of mine and analyzed, and he sent this 1 week ago. And so what if the system ventriculus is a right one and compared to the left ones? And here also we can see a intestinal barrier disorder, and with the hypoplastic left hearts, we can also see an intestinal barrier disorder, and but no bacterial translocation yet, but a disorder in the intestinal, and so we can assume a predisposition here. And how about the microbiome? We have the first 30 patients included, and these are the results from 2 weeks ago. You can see per patient the top 50 genera by mean relative abundance all over all samples. And these are enormous amounts of data, and with the help of informatics we could evaluate them. And then we look for common aspects, commonalities. And this is a so-called principal component analysis, a chart where you can see where are the similarities. And here with the first 30 patients, you can see 3 clusters. And if you look at these, then you can see that this cluster that is corresponding to this one, and it has the lowest diversity, meaning it points to a pathology, and these patients were all patients with PLE. So what about the controls? Well, for every patient, we have a control from the same household. The microbiome is, of course, depending on the diet, on the household. And here you can see in green the control of the household. These were cis siblings. And when there were no cis siblings, then parents who volunteered. And here you can see in this cloud, the patients and controls are no different. And here with the heavy diseases, then you can see a clear difference, and we must have another look and evaluate this group. But there seem to be patients that have a stronger heart insufficiency. And here we have another control. If you look at the 3-dimensional view, then you can see that this point is further away from the cluster. So I have to say about this is a work in progress, and now we have evaluated 30 patients regarding the microbiome. Our target is 50. With all the patients, we want to want to look at the measurement of the barrier disruption and bacterial translocation, but also high sensitivity CAP and inflammation markers, and we also measure the metabolomy, and 20 to 30% of the production of the metabolism is the metaboloma. The analysis gives us further information about the microbiome, what it's doing. And this is ongoing at the moment. And I can say that Fontan patients and PLE show a gut inflammation, but PLE is associated with a barrier disruption and bacterial translocation, and it seems that it's influenced by a systemic ventricle, and the enteral symptom with systematic patients seems to be different from a healthy patient, but these are very few data as we have, and we cannot say that there is a trend you can see at an early stage, and of course we need it to involve a lot more patients. We have a very heterogeneous group, and with the bacterial planning, we want to extend the study multicentrically, and of course, please give us your support so that we can reach a higher level, and with at least 200 patients, and the microbiome can be influenced. We can also think about intervention studies. It can be influenced via the diet, firstly, also by the lifestyle. There are probiotics that can have an influence, and antibiotics, and and other things, but we haven't come very far. We're still superficial, but there are things that fatty acids that we have to look at, and the intestinal inflammation certainly has a big share in the pathology. Everything is only possible with good partners here. My colleague in Nijmegen in Holland, he is the father of this project. He's supporting us from Holland, and is coordinating the analyses as well. Professor Jan de Lee, he is a pediatric cardiologist, and Mr. Hein, a microbiologist and metabolemia expert, and of course the pediatric clinic in Gießen. And it's a very complex topic. I want to point it out again. It can only be worked on if you have different perspectives and different expertise that you bring together. And especially, well, I just talked to Mr. Laser. He will talk about the metabolema in the liver metabolism, and also this meeting has already led to success in some way. And I would also mention the Foundation Children's Heart that is financing the project. Many thanks. Mr. Khalil, many thanks that you are obviously and understandably confirming that it's a good idea to meet here. Do you have any questions, Mrs. Sänger? Yes, it works. Well, we could hear that it was said in the US that it should be administered, the medication should be administered early on, and I would like to find out about your experience, and then I would like to say on behalf of the families that the diagnosis with bronchitis plastica, that families have to fight for it, that this diagnosis gets started in time, and so that you have the chance to achieve things. And it would be quite important here to find out about it. Of course, we looked at the calprotectin values and also cortisone that can be administered, and it normalized promptly, and but we didn't use it with asymptomatic patients. It was said if you administer it in time, then you have the chance. If it doesn't help, then you should stop it immediately. So we did it very intuitively with our daughter, and because she was a little bit older and the diagnosis was in place for much longer. So I want to say as well that it's very important that the resident cardiologists and the centers have to cooperate together. And if there's any sign of inflammation and anything that becomes obvious, and also the gut values that people that don't really have PLE, and I'm very happy here to find that there are new networks that are coming into being, and also greetings from Flores, who couldn't come today, and yes, many thanks to you. Many thanks.
Have a higher alpha-1 antitrypsin in the stool, and then if once you have the disbalance, because the liver is already producing an unbalanced in an unbalanced way, then we have the problem. And in severe cases, significant losses of albumin and immunoglobulin G, among others. So sometimes the albumin has to be substituted depending on the clinical symptoms. So if the LEG levels are low, an attempt at LEG substitution should definitely be tried, subcutaneous and intravenous, to avoid infectious complications. With some patients, it works pretty well subcutaneously if you apply it not every day, but once a week, for example. So if you have a low IgG, so we don't want anyone to die just because we didn't try to substitute it. In terms of the pathogenesis of the liver damage, we have a chronic development. So I would recommend to look closely at the liver without having any symptoms necessarily, because the liver is damaged very slowly. So you don't have any markers. So you should have a scan, or you should have a hepatologist looking at it. So if the liver then gives up, let's say, then it's too late. In literature, it's very clear. We can read that the liver involvement after surgery, that liver involvement after Fontan surgery is very high. So we have a hepatopathy, hepatopathy, and we also have the development of a carcinoma. And this is why we demand a register and a interdisciplinary cooperation. Then we have another publication that says that 100%, nearly 100% have a fibrosis. Liver involvement with itching and increased bile acids in the serum. This is something that many develop. And this is my main message. So ask for the itching and measure the bile acids. I will explain why this is so important. In chronic liver failure, children and adolescents sooner or later develop liver-related pruritus due to high levels of serum bile acids. Can be so horrible that the quality of life drops down to zero, and they itch themselves, they scratch themselves until they bleed. And I see so many children that have such an itching pain. And in the last 20 or 30 years, we couldn't give them any drugs. And then some children had to have a liver transplant just because of the itching. And this is, of course, this is something that bothers not only the children, but also is very painful for the parents. So far, it has not been possible to treat this itching satisfactorily with medication. So we have another game changer, a very new substance group, the odevixibate and maralixibate. So bile acids are bad. So they take away everything that the liver produces, all the toxins that accumulate in the liver. So if they can't do that, then the liver gets a problem. And we see how the inhibitors work. We have a enterohepatic circulation. All the toxins go into the intestine, and then they are carried out. And then if this doesn't work, if this circuit doesn't work, then we have a problem. This is a case. On the left hand, you see the bile acids at 200. So normally we have -10. So if you have 100, then you have an itching reflex. And so this is a PFIC patient, not a Fontan patient. And so I was able to give the first prescription in Europe. And because it's so expensive, we had to give low doses. And this is why you see the curve there. But it's a good development, and the child didn't have any more itching, and it was basically healed. So that's a wonderful development in this child. So then we have the peripheral. Here we had a child with a very high measures, and within a few days the child didn't have any itching anymore. There are no side effects basically, and the parents were really very happy about that. So, and this will also be an option for your Fontan patients. I treated the first Fontan patient with this substance group, and I asked for using it with this patient. There was an excruciating itching and poor quality of life. You could see the marks on the skin. It was an off-label use for odevixibat. It was confirmed by health insurance within 2 weeks. The first patient treated worldwide, and after 2 days, the mother reported that the child doesn't need to wear any gloves anymore. That a few days later, it started playing again, and this was a significant improvement. And of course, now pharma wants to do a study because it's a giant market. If this is a medication that you can, another medication that you can offer the Fontan patients. And here on the left-hand side, you can actually see how quickly the acid dropped. And this is the second wonderful thing with this medication, that after a few months, the other markers also stabilize. So the toxic acids that we take out of the liver also improve other markers of the liver. Take-home messages. As a hepatologist, I would wish that in all children after Fontan surgery, enteral protein loss should be monitored, ATM in stool, albumin, and LGG in serum. Interventional procedures in the lymphatic system are promising. We will later hear something about them. If the serum LGG value is significantly lower, an attempt at substitution should definitely be considered also for forensic reasons. In case of relevant liver involvement, pruritus, elevated bile acids, GOT and GPD elevation, and off-label application for odevixibat should be made. And go to a liver specialist, hepatologist, and I'm happy to help you to ask the health insurance for approval. And children after Fontan's surgery should also be connected to pediatric hepatology and gastroenterology. And we are at your total disposal in this regard. So I would also wish for this relatively new format. We will have the liver included, and I'm very happy that I could give you an overview. Thank you very much for this very straightforward and very convincing presentation. Let me not say anything wrong. Presentation.
Connecting to the intestine.
I think I didn't get you. So patients with PLE not having Fontan operation.
Yeah, patients without a heart problem, who you see with a PLE problem.
Yeah, we do have some patients of them, yes.
Yeah. Do you then see anomalous lymphatic connections between the liver and the gut?
They are not as sick as the Fontan patients, so we don't have to treat them, but we just monitor the PLE and that's it. Actually, I only have one or two of them.
Okay, thank you.
Just briefly, Professor Gancho, gastroenterologists do know about Fontan circulation because there's a rumor that gastroenterologists don't know anything about Fontan. So that's the message. He's not an exception.
So metabolic and regulatory factors of liver metabolism in Fontan patients. That's the topic of the next presentation. Yes, dear Mrs. Sänger, Mr. Professor Gabitz, ladies and gentlemen, many thanks for the invitation to be here again. It's very nice for me. And I'm also very happy to have projects from different clinics and that they are being heard here. And I think it's very good for the patients also to see how things are going ahead. And I think it's work that we are doing together with the uni in Innsbruck, Mr. Professor Scholl-Bürgli, who are metabolism experts. And what is it about now? This is what it's about, sorry. And yes. So metabolomics, and it's about investigation of small organic molecules, including their synthesis and degradation in the liver. And the aim is somewhat to look for new biomarkers, maybe for determining heart failure better, in addition to natriuretic peptides and troponins. With these metabolomics, what you do is a metabolite profiling, and you look for many parameters and to understand the body's adaptation to pathophysiological processes, and that includes metabolites of sugar, amino acid, and lipid metabolism. But there's also been things that have been published within CHD with cardiac arrhythmias as well as heart failure. So metabolism changes from a fatty acid metabolism to a sugar metabolism, and so we know also that in this situation we can also have relationships with abnormalities known for patients with CAD. This is about the so-called periportal fields due to the high venous pressure. You get cell damage and cell death, and then a certain cascade starts, which leads to a fibrotic change of the liver. And if you think further, then the natural history of chronic liver disease would mean that inflammatory processes get started, fibrosis is being built, and in principle, then the liver transforms into a fibrosis state, but then also in a cirrhosis state, and with the final state that the liver develops a carcinoma, and in worst case, it has to be transplanted. And for chronic liver diseases, we now have therapy approaches, but they couldn't be adapted to Fontan patients. But this is the macroscopic cascade. And if you look at a molecular perspective, then you have a signaling cascade that starts. It goes all the way to a liver disease and damage, and macrophages and star cells are being transformed and lead to and contribute to fibrosis. Certain biomarkers are being put out, and then they lead to an interaction with the immune cells, and neutrophils are being started, and we see a fibrosis. But what about the change in the metabolism in Fontan patients? We have a first selection where we have thought that, well, we look at relatively healthy Fontan patients with a left system ventricular and a systemic ventricle, and so we started with 20 ultimately as a relatively good group, and then we compared it with the control group, and there were only significant differences when with the height and body mass index, but they were relatively similar, the groups, and the patients underwent in different investigations, laboratory parameters, anamnesis, and the lab values were correlated, and spiroergometric data were included, blood pressure measurement, etc. You can see the Fontan patients could not be stressed as much. They had very a lower oxygen saturation, and when the HDL cholesterol was different, triglycerides and creatinine and caspilipobine, and with the transaminases, you could see that ALT was different and the gamma GT. Other than that, there were differences with the HB and hematocrit. And well, how did we carry it out? We had clinical data, including the patient's story, medication, echocardiography, spiroergometry. We did a blood test, and the serum was a centrifuged and frozen at -80, and then investigated, analyzed with a method that let us use mass spectrometry. You can see a kind of heat map on the left-hand side that shows the different areas where in red, for example, there was a group that builds more, and the blue group has a lower production of a metabolite, and so we had 23 acyl carcinoids, and for amino acids 29, and the results, you can say, first of all, what we found is that the concentration of phospholipids was lower in Fontan patients, and the acylcarnitines were increased. There was an increased concentration. There is a different interpretation in literature. A lot speaks for an altered cell metabolism as a possible indicator for heart failure. There's also then evidence of chronic inflammation, and also changes in functional or structural properties or lymphatic and blood vessels. So this is where the singolipids are standing for, that among others in the cell membrane they are structural molecules, and of these individual metabolisms, of course, you cannot really differentiate between a healthy and a sick patients, but it's all about getting profiles in order to then see what the changes are all about. These are the results regarding the amino acids, and we have a asymmetric trimethyl, and also the increased in concentration of methionine sulfur oxide, and overall you can interpret it in a direction of a changed energy metabolism and an altered energy metabolism, probably an increased protein turnover. Oxidative stress is probably one thing that you find, and also the endothelial dysfunction. ultimately, you can extend it as well even by looking at bigger molecules. Here, for example, we looked at proteins, and you can also differentiate with healthy and Fontan patients. You can see the different distribution of proteins. And you can show it, and ultimately there is something that is relatively new as a result, and until now we haven't had a good interpretation for this on how to interpret these values, and overall you can say that the liver metabolism on a molecular level is certainly a new starting point to better understand how Fontan has an influence on the liver metabolism. Here we can see changes between the healthy and ill fat metabolites and amino acids and proteins show different clusters and profiles. This is about amino acids, the energy metabolism, protein turnover, oxidative stress, and endothelial dysfunction, whereas with the lipids, cell metabolism, heart failure, inflammation, structural vascular changes. And what's important here, as before mentioned, the interdisciplinary collaboration and the pooling of different expertise is important because the interpretation of these profiles that you find is not that easy, and therefore we have to carry out further investigations. But the results have been made available. We started with 20 patients, and then we extended it to 50. We are starting now with the analysis of the 50 patients. We have to now see if there is a differentiation, and we're using anamnesis for it. We also used imaging data and in order to correlate it, and so if necessary you can find out whether there is an influence on the collateral flow or whether the collateral flow has an influence on the liver synthesis, and that could be that if the structural lipids in different concentrations exist, that could mean that the collateral creation via the liver is generated more or less with certain patients, and we can also see whether see anything via the Glenn hemodynamics, and we also would like to see whether the data with the plastic bronchitis plastica and PLE interact. So this is certainly something where we are waiting on the first results. Thank you for your attention.
Thank you very much. Classical work in progress, full Monty. So thank you very much for giving us the intermediate steps, because that's exactly what we have to be very careful with. Exactly. We are at the beginning, but we have to start somewhere. And unless we start, we don't have any results. So I didn't want to interrupt this. So yes, give him a hand by all means. Any questions? I'm sure that we will meet again in 2 years' time. And then I'm very curious to see how it all evolved. Anselm Übing, what can we do in order to avoid complications? This seems to be the best place to be. Thank you very much, Ms. Sänger, for this very friendly invitation and for the organization of this impressive event. My topic is strategies for the prevention of complications of the Fontan circulation in 10 minutes, and that's pretty difficult. So many things have already been said, so I'm sure that I can skip maybe some of the slides. I hope that I can mention some things that haven't been mentioned yet. So the Fontan circulation is a pathological situation. There's no Fontan presentation without this chart about the pressures in the circulation. We've already heard that the Fontan circulation, through the Fontan circulation, we have created a syndrome of different symptoms. We've already heard about that. And if we look at where we come from, of course, the Fontan circulation is a story of success. We have a survival curve. We have created a survival curve for our Fontan patients over the last 20, 30 years that we didn't initially expect for the first 2 to 3 decades of a mortality of 80 to 90%. So we have arrhythmia, we have strokes, we have tachycardia, we have pacemaker implantation, and then the much feared Fontan failure and everything that that means, and of course also death and PLE and BP. If we look at the strategies that we can develop in order to avoid complications of this kind, we have to think of what influences the blood flow in a Fontan circulation, what is necessary so that the system works. And there are certain things that can modify the muscle pump, the pulmonary vessels. We've heard about that. That is necessary in order to get the blood in the thorax, and we need a healthy lung and a healthy pump with a rhythm which must be able to eject and draw blood into the atrium. So let's start with the necessity of the muscles and the muscle structure, and let's talk about sports. So we're all aware of the number of steps we need to take every day so that we don't die soon or young. And we have some data for Fontan patients. This is from Australia. A study with relatively few patients, which is a usual thing in our cohort. But the result was that we have a muscle mass increases, we have oxygen uptake increases, and stroke volume increases as a Fontan patients in the legs and in the rest of the body, and this heightens the body performance. This is better than any medication. And we have the oxygen pulse, which increases or improves. So the blood flow in the Fontan circulation can be improved when the patients are encouraged to do some sports, to do some exercise. Then we have the respiratory training or muscle training for 6 weeks. And we have an improvement of the lung function, maximum inspiratory pressure increases, and exercise. So doing exercise is a strategy for prevention of complications of the Fontan circulation. Very closely linked is weighing too much, obesity. I think we all are dealing in some way or the other with this problem. There are studies saying that Fontan patients do struggle with obesity, and that they gain weight relatively quickly and easily, and more than the other population, the normal population. So I read in Kiel, in our local newspaper, that the overweight rate in the general public among children is of 4%, which is a lot to say. So avoid overweight. Overweight has adverse effects on the muscles, on the tissues, on it can lead to sleep apnea. It can have other effects. It can be also lead to problems with the liver. So we have data from San Francisco in this case, which were published relatively recently. So these are the standard deviations BMI contextualized with the performance and the pressure and a diastolic pressure increase. So the pressure in the veins. So this is the post-capillary pressure in the lung and in the ventricle. So it has, overweight has adverse effects, which also are reflected in the morbidity rate. So if you have an BMI over 25, then you have a higher rate of hospitalization. And this is a relatively small study with only a few patients, but we also have cirrhosis, a risk of cirrhosis, etc. So, and PLE. So overweight is a problem for Fontan patients. So you should avoid overweight. So that's a strategy to avoid complications. Then to treat residual lesions aggressively. That's how I put it. So if we look at the registers, then we see a satisfactory long-time survival rates. We've seen this already. In some cases or some groups, 35 years. Of course, we also have a Fontan failure. So in nearly all cases, except one of these patients, of those who died here after failure, Fontan failure, we have had at least one other pathology, of, an obstruction in the Fontan tunnel, for example, an aortic arch stenosis, a PA stenosis. We see it here on the left-hand side. And this is a AV valve insufficiency. Pathologies. And to give you another example is the example of the sensitivity of the ventricles, here especially the right one after HLHS, examination of afterload, systolic function and diastolic function, and how we can connect these three, the afterload, the systolic function, and the diastolic function. And what we see is here that with these patients, in the patients with HLS after the aortic reconstruction, we have a higher afterload, an aortic reconstruction. We have a higher afterload, and we have a worse diastolic function. So the afterload is higher in these patients, and the diastolic function is deteriorating. So this is the relation between afterload and the diastolic dysfunction. And what is important here is that patients with hypoplastic left heart syndrome, after successful treatment of ISTA, the diastolic dysfunction remains. And years after this therapy, they still have a worse ventricle function. So the ventricle has some kind of memory. So we have to treat this aggressively. So if we look at the influence maybe of an anormal anatomy on the heart function, we look at the anatomical orientation of the aorta. So if it is very winded, so if what we see here, and this is from Dominic Gubbert from our working group, that these patients here with the hypoplastic left heart syndrome, they don't have a stenosis, but we have a twisted flow pattern, and in comparison to a here constructed normal flow. So what we showed here was with patients with this twist, these patients have a right ventricular hypertrophy. So if we here have a change of the flow, then we have a diastolic function. So to give you a feedback of the hyperdynamic consequences, that also is a strategy in order to avoid complications, to avoid the anormal anatomies. And then, of course, a careful diagnostics and an individualized therapy. So let's talk about the problem of the pulmonary flow reserve. So here, what is it? Is it the flow characteristics of the ventricle, or is it something else? So these are players in the determination of the blood flow of the lungs, and we know, and we have good data from the Mayo Clinic that the diastolic function of the lungs is pathological. So a Fontan patient as a patient of a heart insufficiency. So if you increase the heart output, then the diastolic pressure goes up, increases. So we have a decreased pulmonary flow rate, but not all patients. It's not good for. It doesn't help all of the patients. So what do we do to help patients? These patients, so both lungs and hearts affect pulmonary blood flow reserve. How easy is it to get blood flow through the lungs? How much does the CVP increase when more blood needs to pass through the lungs? That's the question. So we have to look at what the increase of the vein pressure. So if we connect this with these results that show that those patients who have a very strong increase in the venous pressure, that those are the patients that have adverse signs like a stiffness of the liver, then a renal dysfunction, a volume overload, etc., in comparison to the patients with less pressure. So we can differentiate between those who have different markers. And maybe we also have a place for SGLT2 inhibitors. And their effects have been described for HEF patients because they have a different pathology. Careful diagnostics and individualized therapy is definitely important for our patients. And now, to conclude, we need a structured and specialized and multidisciplinary care model. This is a patient that has been transplanted at the age of 20. He suffers from PLA since 10 years old. He has a ventricle function that is not altogether dysfunctional, but here we have the growth rate of this patient, and he has reached a height that it does not correspond to his age. And of course, we try to take a holistic approach to this patient and try to adapt our indications. So we need a structured and specialized multidisciplinary care model, and we also need follow-up, an according follow-up.
Yes, many thanks. It's a summarization from a different perspective, and it confirms our common perspective. In the meantime, are there any remarks or questions from your side? I'm always looking into the light. It's a bit difficult for me to see. Yes, Mr. Sänger. Thank you very much. Well, I am affected myself, so I have a question regarding sport, because you said we should strengthen our muscle groups, and for example, I started to do with power sports, and so that wasn't really that good. So what should I do? Should I go jogging or step up? I did weight training, and it didn't really work for me. Well, of course, it's an experimental muscle training where in very short time you try to reach some training effect with the patient in order to see some physiological results. But I think the take-home effect is that, lifting heavy weights is certainly not something that you would recommend, but any dynamic sports and is quite good, and the message would be sports is not dangerous, and we also don't consult against it, and there's data for Fontan patients, and it shows that it doesn't mean that they fall to the floor and don't survive it. But many thanks. Yes, one more question. I will then pass my microphone. Well, the problem is also, if I may comment, that healthy people, but also affected patients, overload themselves with this sort of weight training, meaning that you have to lift heavy weights, but the physiologists say that for healthy people and for heart patients, it's useful to use weights, but you have to do it repetitively. It's better to do it 20 times with 1 kilo than the other way around. So the same topic from the perspective of the clinic school, from the wards. I am always in favor that our children get exempt, will be set free to do sports, and it's of course necessary for a certain time, but also maybe we need a little bit longer when we write the referrals in order to differentiate how long is it really necessary to do sports and what kind of sport should the patient, the student do in order so for the teacher at the schools know exactly how to reintegrate the patients, the students into the sports education, what can be done over the short, medium and long term. Many thanks.
And patients, and lower limb exercise with weights is the best, but any kind of sport is good. So they ended up saying that in a project setting, you can have people do lower limb exercise with weights, but it may not be the best thing for the individual patient in the long term, because if they don't like to do it, it's better just to do any kind of sport that they really like to do. But if you're looking for the best, it's lower leg.
Many thanks. A final comment, maybe? Well, from my point of view, there's a comment regarding the exemptions for sports, and there are different exemptions, and if you want to say very specifically what the patients can do and what not, then you have a kind of resistance from the schools, and so it's always a kind of balance that has to be found, and sometimes it's also good where you just say, okay, you have to, well, find your own load, and because it's always better to do something than nothing at all. So I can say something about this, Steffi. We have this wonderful school flyer here, this kindergarten, school and education, where we as parents group set together and we listed on what's important to know for the institutions. And with us, you can say, my daughter, for example, has been exempted from the grade, not from the complete grade, but only from when she is not being measured. You know, she's not getting a grade for running fast and so on and so on, but she gets graded for the other things she does. So you know, the children wouldn't like when there wouldn't be a grade, but they are exempt from the performance grading. So yes, I can say something here. Of course, participation in school sports is also important for social reasons. And we also used the flyer, and my son got an excellent grading and in sports. Thank you very much. Now we change the topic again. And I would like to ask Mr. Itkin to talk about the lymphatic intervention in the interdisciplinary setting in the US, please. Yeah, vielen Dank.
Was 1.5 year ago, so I feel at home. I also see a lot of familiar faces and patients, parents, colleagues, and that's warming my heart. I've been in the area of rare diseases for 22 years, and I know how important the involvement of patients in this area. Recently, Lymphatic Research and Education Network was a patient-supported organization, lobby Congress, 2 months ago actually, to create a special commission for lymphatic disorders in USA. So I'm part of this commission, and it's, of course, I'm humbling to be there. Also, they lobbied Congress to get $800 million to tunnel into the lymphatic research. So, Steffi, thank you very much. You did absolutely amazing work and will be successful. So it takes a village to solve this lymphatic problem. We work very, very closely as interventional radiologists with cardiology, of course, gastroenterology, we do endoscopic intervention, pulmonology, plastic bronchitis, and of course, our closest friends right now, plastic surgery for thoracic duct venous anastomosis. So again, I'm doing the lymphatic intervention for 22 years, and at the beginning we knew nothing because we didn't have any imaging. I do not only cardiac lymphatic procedures, but also not cardiac. So we probably 10% of my practice is cardiac, and the rest is non-cardiac. So we do 3, 4, 5 cases a week. And over years, using these techniques, imaging techniques that you can see here, intranodal lymphangiography, MR lymphangiography, liver, and so on, we started to discover stuff. And I don't want to talk about these techniques, just this is the one, CT lymphangiography, and it's very impressive. So One of the main reasons why lymphatic became such a prominent field right now in medicine is because we started to see stuff. We started to understand that there's a system that we totally missed before. And what did we learn over last 10 years is that the most of the lymphatic disorders are lymphatic obstruction. It always starts with some type of mechanical lymphatic obstruction that result in development of collaterals, and these collaterals started to leak or create congestion or create abdominal pain or different scenarios. Why the lymphatic system and obstructed? And specifically, I will talk about thoracic duct obstruction, right? Because it's the easiest for us to treat, easiest for us to understand, but there's multiple obstructions. It could be congenital stenosis, debris, a venous occlusion, exactly where the lymphatic thoracic duct drains into subclavian vein because of pacemaker wire, catheters, central venous catheters, and of course iatrogenic injury. This is an example of not cardiac patient, but example of the congenital stenosis in patient with severe chylous ascites. This is example of patient with protein-losing enteropathy, and you can see here, if it plays, yeah, here we go, that obstruction of the, or thrombosis of the left subclavian vein cause obstruction of the thoracic duct and severe protein-losing enteropathy. Again, it's not cardiac patient, but the same idea. His albumin was undetectable when he came to us. And this is something that we started to see more and more. This is a patient with severe abdominal pain, but if you can see, totally obstructed thoracic duct by what? By debris. And we don't understand what kind of debris is it, but we see it all the time. This type of accumulation of the debris at the end of the thoracic duct. So let's go back to the heart failure. What the lymphatic problem in heart failure? First, physiologically, heart failed. That result in increased venous pressure. This increased venous pressure causes both increase in lymphatic production, but also obstruction of the lymphatic flow, because the lymphatic flow have to go through the vein that under pressure. It results, of course, tissue congestion and symptoms. So, in one of the questions what we struggle for years is what is more dominant? Is it more dominant obstruction by increased lymphatic flow, or it's more dominant production? And we didn't know for years. Because the only way people in the past measure flow in the thoracic duct in heart failure on animal models or in humans by draining the thoracic duct outside. And they reported, yeah, we did 10, 20 liters a day of the lymphatic fluid. So fortunately for us, I have a partner at the University of San Diego where we decided to do this study. We put a sensor on the thoracic duct to measure the flow on this pig model. And then we created the tricuspid insufficiency. And immediately what we saw is that the flow in the thoracic duct in the closed system increased 2.5 times, but then 4 days later, it increases 10 times. So who wins? Production. What does that mean? That means that even smallest obstruction of the lymphatic flow, especially in the patient with heart failure, cause significant problems. So, and again, to the same idea, in the presence of increased lymphatic flow, lymphatic obstruction causes significant back pressure and tissue congestion, of course, lymphatic leaks, PLE, plastic bronchitis, and this is the same idea. What are the lymphatic complications of Fontan that we know right now? Maybe there will be more. We discovered postsurgical calothorax, I understand that, plastic bronchitis, and PLE. And again, it's because of the obstruction of the lymphatic system that result in the collateral. So let's talk about plastic bronchitis. Everybody knows what it is. And this is, of course, we start with MR lymphangiography or CT lymphangiography right now to understand the anatomy. Here's multiple collaterals on the neck. Why are there? Because of obstruction. And you can see this obstruction on the same patient when we inject thoracic duct. You can see that, of course, there's a reflux of the flow into lung parenchyma, but also minimal progress of the contrast through the thoracic duct venous junction. This is just schematic representation. How we treat it, For years, what we used to do, we used to do embolization because that's what we knew how to do. And we still do embolization. This is how we access. We do the lymphangiography. We access the thoracic duct wire, put a catheter, inject contrast, and then we evaluate the anatomy. And again, you can see here, this is obstruction of the lymphatic system. Contrast or obstruction of stenosis, the same. Contrast does not go into the vein, and there's a reflux of a contrast inside the lung parenchyma. And of course, this primarily to impress, but we also sometimes use it for diagnosis. We do this bronchoscopy, inject blue dye to show that there's a submucosal perfusion of the lymphatic vessels. Primarily we did it to show the pathophysiological mechanism, but sometimes we use it. And then we do embolization. And we have a big series of patients, and I embolized maybe 2,000 thoracic duct in my life, and we have a very, very good follow-up. We actually published one paper follow-up, we published another paper follow-up, non-cardiac patient, and they are doing quite well. But from the other hand, the paradox is that my major work right now, treating protein-losing enteropathy, not Fontan, Callas ascites, and chronic abdominal pain, is by angioplasty and bypassing thoracic duct. So in certain patients can tolerate very, very well this obstruction, but certain patients cannot. So we try right now to preserve as much as we can thoracic duct, especially in every patient, but especially in a patient with Fontan. And here you can see there's obstruction of the thoracic duct, and there's a small branch go all the way down to the mediastinum. So we selectively catheterize this branch, and this is injection of a contrast, and then we inject glue. Usually we put a second catheter to pressurize thoracic duct to prevent reflux, and then at the end of the procedure we embolize this branch. Still thoracic duct obstructed, but it's patent, and this patient right now is scheduled for thoracic duct venous bypass because again we feel it's important. So for imaging of a lymphatic system, we often use Lapidol, and it's oil-based contrast. Recently, we figured out how to do it without Lapidol, but it's extraordinarily important to make sure that all right to event shunts, such as fenestration or venous collaterals, are under control. You can put a balloon across fenestration, and of course you can embolize the venous collaterals. This is our study that 18 patient, original one, many years by now, that we showed that we can achieve quite significant improvement of symptoms. 94% right now, I think we reached 99%, and we can control plastic bronchitis practically in all patients. So the long term, good. Disease doesn't occur. However, and I cannot give you numbers, I believe it's probably 15–20% of the patient develop protein-losing enteropathy. And it's kind of in the area of 10–12% of the natural development of protein-losing enteropathy, but we don't like it. So we'll try to maintain patency of thoracic duct as possible, as much as possible, and of course, new territory for us to create lymphovenous anastomosis. Sometimes it's impossible to do preserved thoracic duct. You can see there's absolutely no thoracic duct here. And what we start to see more and more is another pathophysiological mechanism of protein-losing enteropathy. Remember the original number was 94, not 100. Why it's 94 and 100? Because it's turned out that in some patients there's an additional mechanism. And here there's a patient with Fontan, clearly obstructed thoracic duct, but we don't see any abnormal flow going through thoracic duct into lung parenchyma. When we review MR lymphangiography, you can see this funny look, sorry, it's a T2 imaging, not MR lymphangiography. T2 imaging, it's a water, pretty much you see all vessels will fill with water. You can see it to the right of the thoracic duct, and clearly lymphatic because of tortuosity. So we did do liver lymphangiography, and we inject, and indeed we can see that there is a lymphatic duct that communicates directly with bronchial tree. How do we know? Of course, we do bronchoscopy and inject blue dye. So, and it's exactly the same vessel that we see MRI. By now, we have 5 patients like that, and it's maybe close with 6% untreatable. So let's move to the next one, protein-losing enteropathy. I don't want to talk about that, but talk about symptoms. You already heard about that. So why, when people assume that it's lymphatic? For two reasons. Number one, when they scope the patient, when they saw lymphangiectasia, right? Then, when you think about that, where most albumins lives, proteins lives, they don't live in interstitial tissue. Interstitial tissue, by definition, almost free of proteins. Why? Because lymphatic system, the function of lymphatic system pick it up. So it's not interstitial. Is it plasma? Doubtly, because plasma will be kind of blood. It's not bloody. So the other two structures in the body, or two fluids in the body that have a highest concentration of proteins and albumin, are liver lymph. That it's 90% of the level of the plasma. Plasma is 100%. If somebody gives you a result of albumin 5 or like 50 here in US, and in the blood 3, that means that TPN leaking somewhere in the pleural cavity, right? It's the plasma. Many years ago, there was a German physiologist, and I forgot his name, and Starling. We have a big fight and discussion: is albumin excreted or filtrated? And eventually, they came to the conclusion that all albumin in the body, in the vessels, especially in the interstitial tissue and then in lymphatic, filtrated from plasma. So plasma always 100%. By the way, we use albumin right now more than anything else to diagnose the different fluids from different compartments. So liver lymph 90%. Why? Because the way liver lymph is generated is in sinusoid, and sinusoid is a fenestrated capillary. So it's a big holes there. So albumin goes freely. And intestinal lymph, 60% of a blood level. Soft tissue, only 30%. So we assume that it's supposed to come from intestinal or from the liver lymphatics. So when we faced this question, we said, okay, let's do liver lymphangiography. We know how to do it and see what happened. And sure enough, we did it, and immediately we saw the leak. And how do we do liver lymphangiography? We put a needle very close to the portal vein. Whereas like white stuff, if your radiologist would tell there's a periportal thickening or periportal edema, what is that? It's distension of the periportal lymphatics. That's a reason why it's relatively easy to do in a patient with heart failure, because we distend it, and it's very difficult to do with patients that don't have liver congestion. So again, we did this liver lymphangiography, saw the leak. Does that mean that the leak happened from the liver lymph? Yes, but it's also the only way we can actually see access to lymphatics. I will show in a second that actually we've started to see that lymph coming not only from the liver, but from intestine as well. So you can see on the right, this is liver lymphangiography, where liver clearly leaking into the duodenum. And here's, we love to do this trick of injecting blue dye, because everybody can argue with x-rays. Nobody can argue with blue fluid coming out of the wall of the intestine. So here's we do the liver lymphangiography with endoscopy, and then we injected glue to glue these lymphatics, right? And it kind of worked. And this is just schematic representation of the idea. And the question why most of the time we see the leakage in duodenum. Because of that. This is Dr. Deki, who dissected pancreatic lymphatics, primarily for the pancreatic surgery from Japan. And of course, as Japanese, he does excellent, very meticulous job. And the upper part of the abdomen, it's a Rome of all empire, lymphatic empire. Everything goes there. Liver lymphatics goes, mesenteric lymphatic come, intestinal, spleen, probably kidney. We don't know that much about kidney lymphatics, but everything meets here. So it's an enormous amount of network in the upper abdomen. And that's what Dr. Deke showed, how complicated the system is. So, okay, we can embolize, we can glue from the liver side, we maybe can access some mesenteric lymph nodes. Is it working? Yes, it's working. You know, it's definitely takes few hours. There's problem with this procedure. There's no end point. The more you inject glue, the open more glue channels opens up. Number one. Number two, kids become very sick after the procedure. They can go to ICU because of this reaction. But because of the glue cause some type of inflammatory reaction. And of course, there's a risk for strokes or for bleeding. Response, let's say 70%, that we actually immediately after procedure can cure, and there's a high recurrence of PLE. However, we started to pay attention that every time we manage to inject glue, the way it goes through the lymphangiectasia into the intestinal wall, we actually have a good results. That's a reason why I decided to switch our technique by doing endoscopic glue injection. We do the same thing, liver lymphangiography, sometimes mesenteric, but most of the time liver lymphangiography, inject blue dye to see where is the leaking, and then we, this is schematic representation of the idea, and then we use endoscope and in collaboration with our endoscopist, and that's a key. You absolutely have to have excellent endoscopist, and unfortunately, in pediatric world, it's not very common to see very skillful interventionals because there's not that many procedures. But in adult world, the patient can do 50 endoscopies a day, and it happens in the US, can do excellent job. Sometimes we do with CT lymphangiography to show the communication, but not necessarily necessary. So here we go. Again, you can see the leakages. Sometimes you are lucky, you can just see one spot, sometimes it's 2, 3, 4 spots. And the next step, we take this long needle, mixed glue with Lapidol, and inject into the leaking spot. And again, this is a skill of the endoscopy to position you perfectly in front of the leakage point. And of course, monitor this. Monitor the injection under fluoroscopy because we would like to see where this contrast goes. But surely enough, sometimes we don't see the blue dye, or we see blue dye in one spot, but suddenly we see the chyle, and because the mesenteric lymphatic congested as well and connected to the same network, so sometimes they leak. So we use this chyle leakages as a point of injection, and every patient right now fed day before up till midnight with enormous amount of fats. So we're still very young here. We did only 18. We did more patients, but 18 we know we relatively well follow. Some patients disappear. So meanwhile, I present this 18 patient. It's still preliminary data. It's unfortunately people coming from all different places of the world. It's not easy to get follow-up data, but that's what we have for now. We'll get maybe more precise in a few weeks. So primarily male. And it's surprising because most of the lymphatic problems we see with female. Age between 7 and 37, so we have some very old Fontan. Per procedure, albumin was 2.5 average. And average follow-up year, and in some cases we have 3 years. So most of them Fontan, some of them not. The first patient was actually cardiomyopathy liver heart transplant, sorry. It's at the bottom. And okay, we do procedure. How would you find success? And I have a fortune to talk to Dr. Rychik about that. and there's multiple ways to define success. Start with technical. Can we see the leak even? Second, clinical success. Are the patient getting better? Should we focus on albumin or laboratory success, increase albumin and decrease alpha antitrypsin? So we split it in all these 3 different directions. Number one, initial success. Out of 18, in 16 we can see the leak. In 2 patients we cannot. And everybody we saw the leak in glue clinically improved. Some people significantly, almost based to the normal. Some improves slightly. For example, they don't need albumin infusion, or maybe somebody could argue it's a big deal. But maybe the albumin stays the same, and maybe the activity got a little bit better. So plasma albumin. Normalization, when I talk about normalization, it's no more around about 3. It's not 3, 4, or 5. We have a lot of patients with 4 albumin, but some of them 3.2. So we put them in this group, 14 patients. So it's a 90. In 2 patients, we have some improvement. So albumin went from 1.5 to 2.2, 2.3, symptoms improve. And by the way, in some patients, we did 2 procedures back to back. For example, we will do 1 and wait a week and see if there's absolutely no effect, then we repeat the procedure. So it's down in yellow. Recurrence, significant. And again, it's getting smaller because we get more experience, but 57% recurrence. Time to recurrence between average 3 months, but it could be up to almost 1 year, and minimum 55 days. So if PLE recurs, so what should we do? Should we repeat procedure? Sure, we did. We repeat procedure, did a second embolization in 4 patients. In 2 of them, there's a recurrence of the PLE, 6 months and 2 months after second procedure, and sustained in 2 patients, 2 years and 2 months. We just did this patient recently. And these 2 patients, albumin about 4. So initial response good. So we're in a good direction. Recurrence significant. We need to do a better job. We can figure out better how to better embolize it. And we're thinking about that. We're trying to bring ultrasound, endoscopic ultrasound. So sustained improvement after second procedure, 50%. So combined improve around 60% of the procedure. Is it better than, is it excellent? Not, but it's better than 0. And improvement of clinical symptoms, we see some degree in almost all patients. But what's the enormous upside of this procedure? It's very easy. And it could be very short if you have good endoscopies. Shortest procedures I did was 15-20 minutes. The minimal complication rate, it's just upper GI endoscopy. None of these patients go to ICU. In some other countries I did, we send patient home, or they admit overnight, or maybe sometimes 2 nights if some abdominal pain happens. And we only have 2 self-limiting bleeding, one from tracheal tube and one GI bleeding that the patient didn't need even transfusion. So we can do better. What's better? Let's go to the beginning of the presentation. Obstruction of the or dysplasia of thoracic duct we observe in all these patients. So, and again, as we said, conventional wisdom was that we need to reconnect thoracic duct. So reconnection of the thoracic duct is not efficient because there's an increased venous pressure. And we don't think so. There's at least it's just a beginning. Maybe we're absolutely wrong. But we strongly feel that just reconnect thoracic duct to the vein, because the thoracic duct obstructed in almost all of his patients, can solve the problem. And maybe this is, to the Dr. Rajcik point, what differentiate all these people with lymphatic problems and the people that don't have lymphatic problems. Because, of course, we know, Dr. Rajcik just said that, that there is absolutely no correlation between heart failure, degree of the heart failure, degree of Fontan severity, and heart failure severity, sorry, and presence of the lymphatic diseases. And of course, I already mentioned our study where we showed the thoracic duct flow elevated. So for that reason, we have by now 2 patients. This is one of them in a group of slight improvement. The patient is 18-year-old. The Fontan pressure significant, 24. Severe protein losing enteropathy improved. He doesn't have to be admitted every week to the hospital, but still albumin around 2.4 to 5. And the most bothersome for him is severe ascites. So we decided, this is on the right, you can see MRI, clearly obstruction of the thoracic duct. On the right, on the left, sorry. On the right, we inject thoracic duct, obstructed. We do then, together with our surgeons, thoracic duct venous surgery. Usually they do it, it's an old slide. They do it with Coupler. Dr. Lindblad probably will be interesting to hear about that. Again, on the right, on the left, obstruction. Oops. On the left, obstruction. In the middle, what you see is actually the way we guide procedures. Every thoracic duct venous anastomosis, and we do those a lot on non-cardiac patients. Approximately at the rate relatively a lot, twice a month. So right now we have 7 patients scheduled. We always put a catheter to guide the surgeon where to go. And you can see in the middle, that's exactly what's happening. The surgeon takes the hemostat or forceps and trying to navigate in the wound where we injecting catheters and show them where's the obstruction. And on the right, you see the final outcome. And it doesn't look amazing, but it does its job. And it's amazing to, every time we do that, and the surgeon creates 3-4 millimeter connection between the thoracic duct and vein, and next day we come into the patient, let's say the adult patient, and how do you feel? I don't know what happened, but I feel much better. Something right with me right now. We don't know. And then a few days later, we start to see reduction of edema or increased albumin and so on. So, and that's what happened to this kid, that DNR, he refuses heart transplant. Eventually, his albumin went up to 3, and abdominal girth decreased quite significantly, and lost some weight, and he feels much better. So, by all means, obstruction of the lymphatic system is a main problem of all lymphatic disorders. Can we employ steel? And all our efforts right now in my institution is how we can decompress it. Can we do balloons? We can, doesn't work, holds 2-3 weeks. Can we do stents? Does not work. They immediately obstructed. There are some reports out there. So right now we went to the went back and decided to stent thoracic duct of the pigs. And didn't understand how lymphatic system reacted to that. We already did 3, so maybe another year or 2 will give you some information. But absolutely, we need to develop better technique to decompress thoracic duct. Surgical, absolutely phenomenal. Unfortunately, it requires both interventional radiology and extraordinarily skillful plastic surgeon or surgeon to do that. It's hard to scale it. And of course, we will try to selectively embolize plastic bronchitis as if it's technically possible. Potential of the selective embolization is, of course, recurrence rate. We saw only 1 patient. And protein lymphangiopathy, of course, the way we do it right now works. We do have to do better job, and of course combine it with decompression. And this is a group of people I work. They're all amazing, and they absolutely supportive. It's interventional radiology, Debbie Rabinovich, Wolfgang Radke, interventional cardiology, Fernando Dallas from gastroenterology, 2 amazing plastic surgeons, Dr. Kovac and J.K. Estrang, I think. Sorry. And the rest of the cardiology pulmonary team. Thank you very much.
When I started, are there any questions from the audience right now? Frau Sänger, noch mal ganz kurz. Die Frage, die Sie stellen wollten, war: Online-Session machen mit Fragen Betroffener oder möglicherweise Betroffener? Okay. Okay, okay. Yeah. Frau Sänger has asked whether it will be possible at all to do a kind of online session from your place, answering questions from abroad, plus having the chance from some colleagues who could possibly watch and see and look at one of those procedures kind of online.
online it's a little bit different, difficult because it does require some
techniques.
Yeah, it's technology. But we record it a lot. So there's actually YouTube videos where we go step by step explaining everything. I can definitely send you pictures. There's a big meeting at CSI, cardiology meeting in Frankfurt. Usually, this is second year we're doing that. We're presenting kind of live cases, but it's actually not real live. We actually record and
semi-live.
Semi-live, yeah.
Semi-live.
Live, we can look into that, but it's kind of, it's long. Some could be long, complicated. It's better just to show a video. And we actually have virtual reality videos. You can actually put in the glasses and you can be in the room and see exactly what's going on.
And we want to go for the second time to Professor Aitken in the USA.
Bitte.
Chris Hart from Bonn. Thank you very much for your
sharing your thoughts and data with us. I have a question. You were talking about the problem of lymphatic congestion is the increase of production in the Fontan patient or in the heart failure patient. So wouldn't it be better to reduce the amount of lymphatic production instead of getting a better flow?
Of course. So we published this paper at JAC with Dan Burkhoff probably 2 years ago talking about heart failure and lymphatics. And we even redefined the lymphatic, the heart failure as a failure of lymphatic system to remove the fluid from the tissue because it's the only system that fight the congestion. But we didn't have an answer why some people with HFpA, for example, have edema, right? Significant edema. And that's a major question, a lack of correlation between ejection fraction, and symptoms. And we said that's lymphatic system. And 3 potential mechanisms. One is very easy to us to figure out, obstruction of the thoracic duct, right? Or some other lymphatic obstruction. Number 2, lymphatic vessels doesn't contract well, and we have talked about that. Or maybe the microcirculation is too leaky. That means glycocalyx doesn't present in this patient, and there's too much fluid coming into the tissues, and the lymphatic system cannot combat it, remove it. So if you'll figure out how to do, even to understand,
why?
To start with, even though we don't have a mechanism to understand how the plasma filtrates into the interstitial space, right? Whereas 3 weeks ago there was a heart failure meeting where they presented few potential devices measure interstitial pressure. It's still a startup company, right? We make some progress there, but we still don't understand how to measure the flow from the capillary into tissues. Plethysmography is the only one that exists for 100 years, but still nobody knows exactly what it's measuring.
Thank you. A lot to do still. Ich würde gerne jetzt Frau Dautz aufrufen.
Now I would like to ask Andrea
Wie
Dautz.
gesagt, ich kämpfe mit dem Licht. Bitte. Ich habe nichts verstanden. Einmal bitte noch das Mikrofon.
She's talking without a microphone, so it's difficult to understand. I just wanted to know one thing. The health insurance don't like to pay, so we could save us the cost of flying, and maybe something like that is being planned in Germany.
Auditorium.
Yes, I've passed this question on.
Nochmal Chris Hart aus Bonn.
Again, Chris Hartmann. Yes, lymph interventions. We do offer them, especially in the context of the Fontan circulation. So we have a cooperation with the Professor Schill in Bonn, but not in connection with children with heart disease. That's something that is coming up. That is being prepared.
What? The question was, is there anybody right here in Central Europe right now attempting to do something like you did so far?
For sure. Dr. Bonn.
Bonn is doing the same thing as we do.
Pieper.
Dr. Pieper.
Dr. Pieper right now, probably the main person. Leuven, by all means, Goetmelu is Netherlands, unfortunately, he just retired, Leo Schulz, and Norway, Pargetron, they do. And there's many more, for sure. But just the one that coming to my mind, by all means.
So there is eine gute Perspektive absehbar. Und das ist gut so. Jetzt, neuer Anlauf. Frau Bautz, bitte, entschuldigen Sie.
Now, Ms. Doubts. Sorry for the interruption. I'm Andrea Doubts. I'm the mother of Louis, 5 years, and I would like to say thank you to Steffi that I may represent the Fontan-Herzen here. I would like to take you into an everyday situation that could have happened these last days between two worlds. In the early evening, I set off on my bicycle to the clinic to relieve my husband at Louis's bedside. I ride from the normal world into another world. No one can imagine this world who has not had to experience it themselves, a world in which normal everyday problems with children are smiled at and sometimes even longed for. The day depends on how the child is doing and what the physician's plan for the child is. So after my bicycle ride, I chain the bicycle in front of the clinic just as I chain my normal life there. Once I come here, everything is different. I see the first familiar parents carrying backpacks similar to ours. I'm there. I feel understood. Nevertheless, I'm exposed to the everyday life, which is determined for me and my child. Louis is 5 years old. He has a hypoplastic left heart syndrome with restrictive forms of AL. Since the Norwood surgery, he has been accompanied by a left-sided gout high and a right and a diaphragmatic paresis. Since September 21, after Fontan surgery, he and we have been plagued by unstopped PLE with albumin levels far from normal. In all 3 operations, Louis had to deal with complications such as chylothorax effusions and wound infection. Here we ask ourselves as parents whether it would have been important to show or exclude possible congenital lymphatic anomalies or to know the individual course of the lymphatic vessels before heart surgery in order to exclude or minimize possible lymphatic injuries during one of the 3 heart operations in advance. As you can see in the photo, Louis has an incredibly expansive belly. Some days it is so hard to have to see this in your child. It tears your heart apart, breaks your heart. The PLE has made every life so much harder. Louis's motor skills are limited by his belly. He sleeps restlessly and sometimes needs support when turning over in bed. Likewise, as edema increases, his already low satiety level decreases, and Luis needs nighttime oxygen. He often no longer enjoys eating due to his MCT diet, and his susceptibility to infections has kept him out of kindergarten for more than half a year. All these components put an enormous strain on the psyche and strength of our whole family. Our 8-year-old daughter also suffers a lot from this absolutely unplannable life and the many worries. It is very stressful for her to have to exchange the nice things in life again and again for the separation of the family through hospital stays. At the beginning of our journey alongside Louis, we thought that a team of cardiologists and cardiosurgeons would be enough to feel at least a hint of security. Unfortunately, 1.5 years after the diagnosis of PLE, we know that this cannot be enough. The complex system of Fontan circulation with the terrible complications of PLE and BP needs more than just heart experts. We need signposts in many places for us parents on the way with our children. We need doctors from different specialities who exchange information and thus walk a path together with our children and with us. We need a team around us, which together with us as parents finds answers to all the unanswered questions. And even if only slowly light comes into the darkness of this complex system, we ask you to join so many wonderful fighters and their parents on the way. In the near future, we hope to have 3 to 4 interdisciplinary Fontan centers in Germany with nursing staff, doctors and therapists of different specialities. We would like to see German doctors exchanging ideas with international doctors who have also already gained experience in the field of lymphatic treatment. We parents need your professional support and information, especially in such emotional phases, for example, where even you still lack answers. We need support on the way to possible treatment approaches, such as interventions in the lymphatic system or on the way to transplant. We need all your knowledge to be able to walk this rocky road with our children. As described at the beginning, in your hand lies the only security we have as parents at the side of our children. It is so valuable for us as parents to have interdisciplinary guides and thus to be able to give us a piece of our responsibility and burden. It's worth it. Please share and fight with us. Thank you for your attention. Thank you very much, Ms. Deutz, for this appeal that gives us a different perspective and points into the right direction. We're pressed for time, but I suggest a biopause, bio break for 5 minutes. Have a coffee or grab a coffee, and then we will continue. And I'm sure that these 5 to 10 minutes are different than the other ones, the earlier ones.
Seid ihr alle da?
Ladies and gentlemen, after a little here and there, we're going to continue. But this is relative because there are nice people in the world that have put a lot of effort and enthusiasm in all this. And now I would like to give the microphone to my neighbor who is going to continue about this. Thank you. Now I would like to ask Steffi Sänger to come up on stage. Dear Steffi, this is my first time because 2 years ago I wasn't here. And I must say, I'm very impressed. I know the last weeks you've been very busy, but you always have an open ear for everyone. And this is why we, on behalf of the board of managers and the advisory board and all families in the association, I want to say thank you. Without you, this association and this meeting of all these people who are going to join us in our vision for the future. Thank you very much. Thank you. Thank you. That was spontaneous. Thank you very much. Now we're going to continue with spontaneous changes of the program. I was asked to anticipate to make a slight change and to anticipate now the talk of Stanislas Osrotsky about the Fontan network for aftercare following a complete cardiopulmonary anastomosis, standardized or individuated. Thank you very much for the invitation. I have some problems with going back home, and this is why I asked you to anticipate my talk. So I modified the title. So we are going to talk about the network for the aftercare after a TCPC, standardized or individual. And now these are the words of Professor Radzik that I wanted to include in my talk. So now we have 50 years of the follow-up, and this is about the fact that 40 years of the Fontan operation, it's a failed strategy. But now we shouldn't... but now people survive more than 30 years, and but still we should continue to try that this is not enough. So this is something that we cannot win 100%. And then I think that we should more or less do the same thing. So the aftercare is all the same. And then I'm going to talk about the soul of Fontan. This is the summary of 3 publications It's about the circulation according to follow-up, according to the operation. We always have failures. So a long time follow-up is always a long time follow-up. If we wait long enough, then we see what happens after the intervention. So the probability to die in Fontan patients is 20 times higher than with all other heart patients. So 1 is normal, and Fontan is 20 times higher. And the third graph shows that the Fontan patients that reach 40 years of age have a higher risk of mortality, 20% higher than everybody else, even higher than people with difficult disorders. So that's a little disappointing. There's more disappointment in store. These are the projections. First, we have a register from Australia in 2045. If I'm not wrong, 2045 there will be twice as many patients as at the beginning of the register. So we started with 2,000 and some, and here we have and that we will have more and more patients in the next 20 years. And this is a huge work. So 2030, we will have 50,000 Fontan patients. So these are the centers, 11 of them. And here we see that the age of the patients rises and that the number of the patients will also increase. So this is a so something we do right if people get older with Fontan, that's for sure. And this is a wave that can kill us in Berlin too. We see that we have 151 patients, and most of them are adolescents and children, and we see that we will have more and more. So that we have interventions, we have MRT, we have aftercare, and everything that we need to do, because we can only do this in teamwork. So a Fontan team is an interdisciplinary team, and you have to know when you do what. These are the special aftercare program. So it's a clinical cooperation with other institutes. We think that we know everything, but we don't. The pediatric cardiologists know something too, and then we need to focus also on national projects. It's not that complicated because we are very well interconnected. So we have 550 patients. They are taken care of in the clinic, and the Fontan patients have certain treatments, and then here we have the number of the patients. Are they in-house or out-house patients? So the physicians cannot send everyone to the clinic. That would totally congest the clinic. So we trust the physicians out there. So we can we should introduce certain slots. So we need to coordinate that. For the coordination, we need a certain database. So we need to include the data in the database. Who came, who had invasive or non-invasive treatments. And then we look at what happened in the year or do we say bye-bye, see you next year? So this is something that we need the database for, because of the traditional data or the tools that we use in the clinic, we will not be able to generate a summary or an overview such as this. So when do we do what? In the aftercare, I forgot something here. So we have standard treatments, catheter 3 to 5. Then we take blood samples. Then we have certain hygienic treatments. Then we have a a treatment of the liver and of the kidneys. Then we also have a special program for recreational exercises in order to also get some joy out of life. So some are more frequent, some are not as frequent. And in order to develop a aftercare program, we need to cooperate with all the different departments for the visceral surgery, the children's department, neurology, radiology, also the sport medicine in the Charité. And we also need to be able to evaluate all these data. So we have also a hemodynamic evaluation and an Erdogan evaluation. This is Niagara waterfall. So if you turn it upside down, then whatever you expect to happen does not happen. Same happens with Fontan. You think that everything's well in the circulation. We know we can measure something, and we can do all sorts of things, and all this is in the hands of the clinic. Also, the MRI measurements, then the flows. This is what we know, more or less. But then we have the situations where we can't do anything. For example, changes in the myoarchitecture and connective tissue. These are old studies. Yen Ho and Anderson from '99. These are very small children. We can see that this is not a normal heart. And this is a left ventricle. And the Fontan circulation needs 5 liters in adult patients in order for the kidneys to work. We cannot do that because the Fontan output works, and that's why we have kidney disorders or problems with the kidney. Here you have the vessel. We have a neurosclerosis. That's all a matter of time. That's one of the points we cannot we have no control over. Then we know that the Fontan circulation is bad for the liver too. We know that. So up to liver fibrosis, everything can happen. And with damage, cellular damages. So all these things we cannot control. we cannot control the heart. We cannot undo the liver stagnation. So we have to monitor everything. We have hemodynamic studies and hepatic and hemodynamic aftercare for 100 Fontan patients in this study. So we had a heart catheter, then laboratory testing, liver ultrasound, and transient elastography. So very simple example. So you measure a lot. So we have 8 Pascal normally, but this patient group had 25 Pascal. So these are things that we can only accompany, but we can monitor the changes. So if we have more congestion, then the density is higher. And then you have the FALT score, laboratory testing, the transient elastography, and the liver ultrasound. So I'm not going to go into the detail of this. So we have seen that most of the Fontan patients in this group were in the moderate to severe category. So we can use this as a marker to see how well the patient is. So this means the liver examinations can be used in the clinical day-to-day in order to optimize our treatment. And the same goes with patients with severe FALT. So the CPET tests are bad. So we have a congestion of the liver and a Fontan circulation. And here also the invasive pressure measurement. Correlates with the severity of the liver disease. So this is part of our day-to-day, and we observe this as a marker so that we do that just to make sure. So what we also have seen is in this group, so we had 25.6 milliliter per minute, which was really good. But the longer it took, the worse was this. So if we take all these FALT parameters together, then we have a sensitivity within the fold area, and that's why. But what we've also seen is that we shouldn't only rely on the imagery. We also have other options where we can examine the liver functions. For example, the functional hepatic deterioration determined by C-methacetin breath test associated with impaired hemodynamics and late Fontan failure in adults. And this correlates with the patients with a high pulmonary pressure. So these are different parameters. So here the liver examination is also a very important test, a very important tool also in order to decide whether we need a heart transplant or a heart liver transplant with the Fontan patients. So if we summarize all this, so there's a study with 15 different parameters that speak in favor of a Fontan failure, and then we talked about how many of these patients have these or show these parameters. This was tested last year, and then we saw in these patients how many of those didn't have any 1, 2, 3 up to 11, 12 risk parameters. And then there's a very clear correlation. The more symptoms we have, the higher is the probability of a failure of a Fontan failure. So this is something that we can adapt. We can tell the patient that maybe they are already in a risk area. This is something that we discussed this morning. So when would be the right moment to tell the patient to list him, etc. To list them. So this is the Fontan failure score. So we can mark it, and we don't have any false assumptions either, because it's all specified in order to ask for help in time. Then we have a late Fontan failure in adult patients, which is associated with deteriorating ventricular function and not with increasing PVR. So what we've always seen is that the resistance doesn't change. So the problem is here and here. Not necessarily that the resistance of the Fontan process is limited. So here we have a limitation. So they can't endure so long. And here also the ventricular function. So it's a ventricular problem that you have to postulate, because at the beginning of the follow-up, most of the patients had a protected ventricular function. At the end, most of the patients had diastolic and systolic functions with the Fontan patients. I'm sure that you talked a lot about this, the extrinsic system, the blood flow through the lung, how well are the lung vessels working, and how is this developing? How is the blood flowing through the vessels? So we have resistance reducing medication, so more with children than with adults, interestingly. So maybe a part of the patients among these are those that just came out of surgery, and these are maybe the ones who are running around and nobody has ever examined them or tested them. So so this is the last question, a positive outlook. We just talked about this. Exercise is good, also for Fontan patients. You have to be careful, low to moderate. But if we look at it, what does low to moderate mean? To play billiard, to walk, but no, more won't be possible. Even riding a bike is a static load for the upper body. So this is a Fontan patient. So I know him very well. He lives in the Ukraine at the moment, and he's fighting in the front. He is 28 years old, and this is what he recorded a few years ago for me. I don't think that many Fontan patients can do that. I think he's the only one, but he's also the only Fontan patient who's fighting in a real war. Many students of his peer group have already deceased. So we thought, what can we do? And we asked our patient cohort. Sorry, you can't really see that. So we asked whether they wanted to exercise, and here we see why they don't do exercise. Fontan patients. So the requirements are too hard. No time. What are they doing all day if they don't have any time? Don't have time for sports? So they are not interested. So we need to educate them. We need to tell them why they should find the time, why they should be interested in doing sports, because it's good for them. Here we see that these are young adults, and they are interested in guided sports, let's say. So should they go to go swimming or tennis or what? They can't do that. So we have initiated a cooperation in order to bring the exercise to the homes of the Fontan patients. So we brought them an ergometer, an ergometer, and we developed tests where they should exercise for 2 years, not 2 weeks, not 2 months, 22 months. And I distributed these bicycles up to Hamburg. Most of them are in Berlin. Out of 22 patients, 18 managed to carry out. So that's a very high compliance rate. So we had a follow-up. So in Corona, during COVID, we couldn't do anything. And we are very proud that the patients complied and that they did this and over time improved their health. And we published this. So this is only 10 months in total. We have an improvement, and we have more inspiratory pressure in the lung. And we even won a prize. One of them even won a prize. I think it's a good thing to be able to do this on a large scale. Because from my point of view, this doesn't only mean treatment, and it's also a social component there. They don't feel left out, and they can do something at home, and you can do competitions, etc. And this is a very interesting publication from 22. This is exercise training for people living with Fontan circulation and underutilized intervention, because the best effect have those patients in comparison to other patients. Those who have trained, have done their exercise every day, Fontan training. So if it's good for us, why shouldn't it be good for them? And I would like to inspire you, even if this could be the result. Thank you very much. Thank you very much. The motivation and the fish and learning to fish, that's maybe an interesting concept that we could use in other parts too. So are there any questions? Everybody's welcome. Are there any comments? That's not the case. Ms. Singer, I have a question. Could singing be a good exercise for the respiratory muscles? Yes. Maybe that's the case, but I don't have any data. We could have a choir of Fontan patients. So maybe we find a doctor who will take care of us, and then we can send people home just with the bicycles, because exercise and singing, it's good for the lungs. Maybe that's a good idea to think about. Maybe we will find something. Yes, after riding the bike, we can sing together. It's good to know what you train, and it's good to know what the patients think, because when you sing, sometimes you have to breathe in a different way, than you normally breathe during exercise. But I'm all for singing, of course. It's a nice idea to sing while you ride your bicycle. I have a question. So you do that in Berlin with your patients, right? Or Hamburg? You brought the bicycles to Hamburg? Yeah, in the clinic, yes. Yes, the clinic takes care of the patients. It's interesting because I know you from before, because my daughter was born in Berlin and you treated her. But finding out, we still have 10 bicycles. So will you give this information also to other clinics? It would be nice. Yeah, I just did that. 10 bicycles. I take one. I had 22 patients who did their 2 years, and 10 of them dropped out. So we have 10 spare bicycles, and we welcome other athletes. So now the next step would be to have a, let's say, a monitored exercise program at home. And you can do that with your cardiologist too. We want to communicate, we want to ask for the data. It's not a study as such. So how do I find out what my child can do? Yes, there's a program. That's the supported, or the guided exercise program. So who should? Yeah, you can call me or write an email to me, and then I will answer you, or whatever. So you need the data of the last tests, so we know where we are. So we need some data, but we can actually recommend this to everyone. So when you ride your bicycle, then you have no static load of your hands, and you can just ride your bicycle. Thank you. Thank you. Now we're going to talk about plastic surgery, and I'm very happy to ask Ms. Grünherz to the stage, and I really am very happy about this, because we have now reached the whole range of what we're dealing with today, and I'm very interested to know what superlatives in the operating theater are. I'm very happy that I have been given the opportunity to share
Sehr geehrte
my
Vorsitzende des Fontan-Herz-Symposiums, liebe Frau Sänger, sehr geehrte Teilnehmende, liebe Patienten, liebe Eltern. Ich danke Ihnen herzlich für die Einladung zum zweiten Fontan-Herz-Symposium und die Möglichkeit, unsere Ergebnisse bezüglich der mikrochirurgischen Rekonstruktion des zentralen Lymphsystems vorstellen zu können. Wir haben die erste Ductus thoracicus Venenanastomose bei einem Patienten mit Hylosleckage am Hals erfolgreich im Jahre 2018 operiert und seitdem die zentrale Lymphchirurgie in der Klinik für plastische Chirurgie am Universitätsspital Zürich etabliert. Es besteht eine enge Kooperation mit Professor Müller und Privatdozent Pieper vom Zentrum für seltene angeborene Lymphgefäßerkrankungen an der Universitätsklinik in Bonn. Neben Patienten mit Verletzungen des Ductus thoracicus und angeborenen Fehlbildungen des Lymphsystems kann die zentrale Lymphchirurgie auch bei Fontan-Patienten Anwendung finden. Ich werde regelmäßig von Eltern betroffener Kinder und erwachsenen Fontan-Patienten kontaktiert, bei denen es zu einem bedrohlichen Eiweißverlust über den Darm gekommen ist oder Lymphflüssigkeit chronisch in dem Brust- oder Bauchraum zurückstaut. Wie wir an den vielen Vorträgen bei diesem Symposium sehen, ist die Situation bezüglich des Lymphabflusses bei Fontan-Patienten komplex und häufig durch einen generell erhöhten venösen Druck bedingt. Die mikrochirurgische Rekonstruktion kommt jedoch zunehmend zum Einsatz, zum Beispiel, wenn kein wesentlich erhöhter Druck im Fontan-Kreislauf besteht und die Diagnostik zeigt, dass der Ductus thoracicus im Bauch- oder Brustraum abbricht, was zum Beispiel auf eine Unterbindung während einer der vielen Herzoperationen hinweisen kann. Hier kann die mikrochirurgische Wiederherstellung des Lymphabflusses an spezialisierten Zentren den Rückstau verbessern und sollte neben allen anderen zur Verfügung stehenden Therapiemöglichkeiten auch evaluiert werden. Frau Dr. Grünherz wird Ihnen nun unsere Ergebnisse und Behandlungskonzepte aus Zürich vorstellen und ich wünsche Ihnen allen ein interessantes und erfolgreiches Symposium.
I'm sorry, Miss Lindblad cannot hear me here, so that's why I'm here. So to give an overview, we are going to talk about the reconstructive lymphatic surgery. I'm going to explain the surgical techniques, then the pathologies of the central lymphatic system, thoracic duct vein anastomosis, challenges and outlook summary. So we distinguish in the reconstructive lymphatic surgery between the central lymphatic system, especially the ductus thoracicus, and the peripheral lymphatic system in the extremes in patients with lymph edema. Surgical techniques. The goal is always the restoration of the lymphatic drainage, and the method that is being used most frequently is the LVE. Here we have the example of an arm. Here we can see the drainage in the periphery. And the other possibility is the LLA. That's a connection between two lymphatic vessels. And the third option for patients with lymphatic edema is the VLNT, where we take out a part of the tissue, and then we have a connection there. So if we look at the central lymph system, then so let me give you a few examples. Here we have a patient with a lymphatic edema in the left arm. Here we see the different. So she had suffered some radiation therapy, and here on top, you see the preparation of the subcutaneous vessels under the microscope that are being disconnected. And here we see that the anastomoses are patent and that there's a drainage into the veins, and we can see that the edema could be reduced. We can also carry out lympholymphatic anastomoses. So here we can identify the leakage, and under the microscope we can see the severed lymphatic vessels, and then finally that is also reestablishing the lymphatic drainage and supports the healing of the wound. And the third technique is the free microvascular lymphatic tissue transfer. This is a patient with a lymphatic edema in the right leg. Here we see the pictures from the laparoscopy. Here we have the lymphatic node, and we have the veins that you can see here in the picture, and we see lymphatic angiogenesis here, and then we also reestablish the drainage. And we saw some improvements in the first follow-up tests. So now I would like to talk about the pathologies of the central lymphatic system, which are very rare, and they are much more complex to treat. They also required an interdisciplinary treatment. We have, for example, latrogenic lesions and congenital lymphatic anomalies. The treatment range has changed in recent years. In former times, the ductus was closed, which can lead to other complications. Here you see the first patient, which we operated 2018. He had a It's a 52-year-old patient with discharge of chyle after a radical neck dissection for hypopharyngeal carcinoma. There was an unsuccessful conservative and interventional therapy. We had a surgical revision with anastomosis between thoracic duct and jugular vein interna, and then we had an inconspicuous post-operative course. And as I said, we had a healing of the situation, and the post-operative course was inconspicuous. Then in Zurich, we also treat a few congenital lymphatic anomalies. But here we have to say that these disorders are much more complex, and we have lymphatic vascular lesions in various tissues, multifocal. Then we also have a pathological peristalsis of the lymphatic vessels. We have permanent protein and fluid loss. We have a high mortality, and of course a very severe disease, so very complex to treat. The conservative and traditional treatment is the first one. Then we treat them via the radiologist, and then we have a few cases where we have a surgery. So I'm happy to show you some examples. A 52-year-old female patient with a lymphatic drainage disorder, spontaneous bilateral thorax for 1 year. And here you see very impressive the pictures we had a discharge disturbance of the thoracic duct with a reflux in the abdomen and thorax. The fear was that if we embolize the leakages, then that would lead to a deterioration in other parts. So we looked at the ductus thoracicus, and we the patient does not have any symptoms anymore, and she is basically healed. Then we have a 34-year-old patient with a central lymphatic drainage disorder. He had a chyloscus and a chylothorax for 3 years. We could see a stenosis of the thoracic duct at the venous angle with massive dilation and backwater. And conservative therapy, conventional lymph angiography and interventional recanalization was unsuccessful. We decided in favor of a operation of the ductus thoracicus vein anastomosis. We can only talk about a partial remission. So we had a significant improvement of the chyloscus, 750 milliliters per day. The additional therapy with medication needed to be continued. Today we are talking more about young patients, so that's why I would like to give you 2 more examples. A 6-month-old infant with a central lymphatic drainage disorder. The patient had a chylothorax, a chyloscus, and an anasca and a PLE. There was multiple thromboses, and we had a pronounced venous collaterals and no coagulation disorder, inconspicuous genetic screening, and we could not extubate this baby. Here you see the missing drainage and the reflux. This young patient was discussed internationally, and we thought very hard, very long about whether we should do surgery, and we decided in favor of the surgery because there were no other options in the end. And here you see the preparation of the ductus thoracicus, and here we had multiple lymphovenous anastomosis in order to improve the situation. In 2 weeks post-operatively, we had a normalization of the PLE, and but 6 weeks afterwards, there were thrombosis again, and the baby deceased, unfortunately. But also we have better news. This is a 2.5-year-old boy with Noonan syndrome, with congenital chylothorax and chyloscus, with recurrent pulmonary infections. Here you see the pictures of the lymphography, and here you see in the image that there we had a congestion, and this patient, together with Professor Lindemann, was operated in Greece. These are the images from the operation. Here we have the blue loop where you have the ductus thoracicus, and what we could see here was that there was an occlusion, maybe even an atresia, and this we needed to be differentiated, and then the ductus thoraticus was dilated. So in the end, the ductus thoraticus was convoluted, and here you have the arch, and the ductus was externalized to the veins, and then we had a decrease of the edema on the thorax and abdomen, spontaneous breathing via tracheostomy, and a visible regurgitation of the pleural effusions. I would like to present another case of a 19-year-old patient. I can't tell you a lot about this person, but I would like to present her anyway. The patient has had a lot of operations already, and now the anastomosis is being evaluated because we could see that the ductus thoraticus was broken, and maybe here we have the solution to bypass, to make a bypass here, and to improve the PLE, but we don't have any concrete results yet. Here you see our treatment algorithm. So I don't have a lot more time, so I won't go into details. So first of all, we need to find out, we should do a lymphography, and then try conventional therapies, and then try interventional radiology as a treatment. The patients that are evaluated for surgery are patients where we see in the imagery that we have a singular lesion, and where we bypass the ductus in a very directed way, directly to a vein. That's where we see the chances of a success, much higher success. Zurich currently is the only center in Europe to offer central lymphatic surgery. That's why you need to apply for cost coverage to the health insurance fund by treating by the treating clinic. But of course, you can pay the costs yourself, and then apply for a repayment. So the challenges and outlook is the complex pathophysiology of congenital lymphatic malformations with multiple lesions, altered peristalsis. Then we have the pressure ratios. We need to think about that. Then surgery is often only discussed in advanced stages, and the ductus thoraticus is very difficult to access. And we hope that with our robots, we can access here in a better way. Here we see how Professor Lindenblatt is guiding the joysticks, and the movement is transferred to the needles. And this is how we train that. So these this surgery robot has been used since 2020 in patients for anastomosis. Here on the left-hand side, you see a robot assisting, and on the right-hand side, you see the manual anastomosis. And we do a lot of research in this regard, in this area. And we have a learning curve on the left-hand side. You see that we still need much longer with a robot than by hand. But here we can see that with a lot of training, we can handle the micro-surgical robot just as well as if we do the surgery by hand. We also try to maximize and optimize everything. We operate in parallel. Here you can see the example of a patient where we do a lymphatic surgery and the robot is teleoperated. So that's how we save space at the in the operating theater. So now, in conclusion, my summary, expanding the treatment options for central lymphatic lesions, anomalies through reconstructive lymphatic surgery. Of course, this affects rare diseases that we discuss internationally. We have a cooperation with Philadelphia, and we need an interdisciplinary management of the patients, and we will apply micro surgery robots, especially for children, so that we have smaller scars, for example. Thank you.
Dear colleague, I'm very fascinated by these transmission or transferal of these big movements onto these small robots. So my compliments. That would be my comment, but do you have any other? Yes, can I start? I have a question. I know that some Fontan patients are standing in line, waiting in line, so to speak, because to get treatment in Europe via the healthcare providers, it's somewhat easier. But my question is about anesthetics with Fontan patients. We know when it comes to the anesthetics, it's not that easy. Are you in preparation with your anesthetist that they get further training for pediatric cardiology, or do you plan to have anesthetists who are experienced with Fontan patients? Well, I can only talk about the 6-month-old baby who was sent from Bonn, from neonatal clinic there, and it was in a pediatric clinic, and they also provided the anesthetics. And so I'm sure that these anesthetist experts had the right training, but of course we would clarify it beforehand. Perhaps I can say something because several patients are discussing with Zurich. Zurich has a pediatric cardiology and has the equipment for anesthetics and a pediatric cardiologist who we are in discussion with. Many thanks. Many thanks also to come this long way. Thank you. Mr. Professor Dieterle, please. The lymphatic system and the heart speak with each other. I'm very excited to find out about this. Mrs. Sänger, Mr. Grawitz, dear ladies and gentlemen, first of all, I want to thank you very much for the invitation as an adult cardiologist to be among so many pediatric surgeons, plastic surgeons, etc. I have no, how can I say, no impressive pictures that I can show you. I will take you to the everyday business of the cardiologic business, but maybe I can also give some impulses from this area that I was occupied with for the last 26 to 27 years. We tried to find solutions to improve the heart and circulatory movement of our patients. My interest, conflicts of interest. When we talk about lymphology and cardiology, you have to come to the level of the vessels and where the metabolism takes place, the CO2 and oxygen exchange, and meaning in the capillary vessel, we find them in the muscles, we find them in the organs, we find them everywhere. So we also have to think about, lastly, that has also implications for therapy and the further therapeutical development, the lymphatic edema and how lymphatic fluid is created. And I wanted to mention also the Starling concept on the arterial side of the capillary picture. You can see due to the high liquid pressure, it comes to the filtration of blood plasma. And vis-a-vis is the so-called oncotic pressure due to the solution of fixed matter and the pressure during the capillary flow. It decreases. On the left, you can see it's down to 10 millimeter Hg, and then the oncotic pressure takes over and pulls the liquid back into the lymphatic vessel, and so 100% that is being filtrated, 90% roughly in healthy patients is resorbed, and the 10% remaining are flowing out via the lymphatic system. And we assume that about 8-liter tissue liquid is being filtrated in 24 hours. And if you look at it, if we didn't have this lymphatic system, we would just blow up. And the lymphatic capillaries have so-called pre-collectors and collectors that then in the lower extremity flow together via the ductus steraticus. We heard a lot about the surgery of ductus steraticus, and so it's then led up to the venal system. The lymphatic vessels have a very interesting construction, and it's worth looking at them. They are vessels with muscle cells that are bordered by lymphangion, and these lymphangion have characteristics similar to the ventricular of a heart, and we can also describe them with the same parameters, with so-called pressure volume curves, and we have similar behavior and characteristics when we look at ventricular and fill it with lymphatic liquid, then the contractility is reducing. So this contractility, which leads to the contributes to the lymphatic transport, has to work optimally, but these muscle cells can be influenced as well, and therefore we know this about side effects of medication that lead to reduced contractivity. And if we look at the heart itself, then we see a lymphatic network, and the lymphatic the lymphatic flows from inside to the out, and then along the sulcus from the right ventricular to the left one. Venal angle and from the left ventricle to the right via the bronchial lymph nodes. So that's quite important because from this you can deduce therapeutic implications. And we know that along the capillary muscles there is a tight lymphatic networks, and we know from experiments with animals that the lymphatic blockage leads to heart rhythm defects. We also know that valve dysfunctions due to lymph blockages can come about in the system, and that's something that should give us some more ideas. But if the cardiac lymphatic system is at the drainage system, so to speak, of the heart, it's not really the case, as we know from studies, and there was a lot of research being done in the last couple of years, and further developments into new molecular methods, and that not only led us to a recreating of the lymphatic system, but we also know better how to understand it. We can then transfer it to the animal models, and there are the so-called zebrafish models, and then we have also new imaging methods. We have seen it several times today, lymphangiography with we can see here a patient with a malformation in the neck and heart areas, and the lymph scintigraphy that we always use when we don't know why a manual lymphatic drainage doesn't work. And then we also use the so-called near-infrared fluorescence imaging in indocyanine green that is being injected in the tissue and is collected in the lymphatic vessels and is being transported on. And then we can see the flow of the lymphatic vessels and its functions, and that we can also do it well with animals. It doesn't work well with humans. This is a mouse, and the red dot is the heart with their lymphatic systems. And then the optical coherence tomography is quite new as an imaging method. Here we have three-dimensional imaging, and that contributed a lot to the understanding of lymphatic systems. And we cannot forget that it's not just a drainage system, the lymphatic system, but also the whole immunological antigen presentations, immunological functions is based on a well-working lymphatic systems. Fatty acids and so on are being transported via the lymphatic system, and also the tissue of toxic substances is being drained. And so the lymphatic system in Fontan patients, you've heard it many times today. So I don't want to go into detail in this case. You will also hear another presentation on this. And I'd just like to point out that with the Fontan circulation, we are looking at a high venal pressure from the foot to the neck. It has to be transported and then led back, so we can calculate that it needs a pressure of 90 millimeters Hg in order to do it. And so if the inlet pressure is increased, then we need even more pressure So that leads to an overload of the pumping system of the lymphatic system. And pleural effusions, chylothorax, all these things you know about, that your children, you as parents, have to fight with every day. And this is the direct connection to lymphology. But it's not all, and I want to take a step back here and from the perspective of the preventive cardiologies, and I want to shine a light on the lymphatic system and where it plays an important role in the pathogenesis of vascular diseases. And for this, we have to look at the epidemiology. The cardiovascular diseases are the #1 killer worldwide. 50% of the mortal cardiovascular cases are due to heart diseases and heart attacks and heart insufficiency. And so that's only the tip of the iceberg, because below the water we have 2 billion affected patients that are affected by risk factors, hypothermia, smoking, diabetes, the new epidemic, overweight, lack of movement, etc. All of this, the last OEC study said it leads to 18 million deaths annually worldwide. So where does the lymphatic system play a role in this? Very new data show that the skin plays an important role in the pathogenesis of the hypothermia. And we know that the kidney can lead to a high blood pressure, but we also know that 50% of the can reduce the pressure via reducing the natrium input, and the skin can store the common salt and sodium, and so if it's not the case, then it contributes to hypothermia. Adipositas, the adipositas leads as such to a vascular inflammation, to underregulation of TC cells, and decrease the pump function, and also a decreased number of lymphatic vessels. So it leads directly to a lymphatic dysfunction, and vice versa, it leads to an accumulation of fatty cells, and that is a devil's circle, so to speak, and leads to a negative influence on adipositas. So diabetes, we need insulin in order to for the lipid synthesis, and for the lipolysis, and we need it also for a functioning lymphatic system. Lymphatic dysfunction leads via a dysfunctional signaling to the decreased NO production, to mitochondrial function, and a worsening energy balance, and but also to an expression of pro-inflammatory molecules. And last but not least, and here we have the so-called crosstalk, where the lymphatic and heart system are very closely connected. The transport of fat, of lipids, connected to the cholesterol. This is where we need a properly working lymphatic system, and so sometimes these plaques can lead to a situation that cholesterol is being transported via the lymphatic vessels and can be then drained via the bile. And so if all of these factor controls haven't helped, then we can see that the lymphatic system in the healing process has to play an important role, meaning after a heart attack, there is an increased number of lymphatic capillaries and a decrease of the collectors, meaning there is also a blockage of inflammatory cells and an inflammatory reaction. If we would manage to recreate and correct the lymph system and support the tracking, then we could assume that the danger of heart attacks is reduced. That was also shown in a experiment. So we could see that there is an increased functioning and changes that help the healing after a heart attack. The big epidemics in cardiology is heart insufficiency, heart failure, and we have about the 5-year survival rate is about 50%. Even though we try to help with therapies, and maybe the lymphatic system can help us, because here we have directly a proof that as a follow-up to a lymphatic drainage blockage, the myocardial oxygen consumption is increased, and myocardial fibrosis is indicated. And then I come to the end. I hope I could show you that the lymphatic vessel system plays a important role in the lymphatic vascular central system, and the interaction of the lymphatic vascular and the heart is central to the understanding of a cardiovascular disease. And of course, we hope if we have a better understanding, then we can also develop new therapies from this, and not just for treatment of the risk factors of not only when the baby has fallen into the well, but also in the sense of new drug delivery system, new therapeutical approaches, and therefore I hope that I could show that cardiology and lymphology, pediatric cardiology and lymphology, are very closely connected. Thank you very much.
Thank you very much. I must admit that a lot of what you've just presented was something that I was not aware of. Thank you very much. Any questions? That's not the case. Then I would like to continue So this is a comparison between the lymphatic system in healthy people and patients with a univentricular circulation. And this is why I give the floor to Ms. Vibeke Elisabeth Hjortdal from Denmark.
And talk about the lymphatic system, and I will move on quickly and say that this is the reason why I'm here, and this is the reason why I'm talking about the lymphatic system. This is a patient that I took through the Norwood operation when he was newborn, and then when he grew up, he got severe protein-losing enteropathy. So that was a main reason for me to dive into the lymphatic system and try to understand what it's all about. Another patient is this patient. He's an adult who has plastic bronchitis. I met him a couple of years ago, and he has been through a lot of investigations in his life because nobody could find out what he was, why he was sick, but he was coughing up these strange things that some people thought were thrombus material, and he was investigated for a lot of different things. Those two patients we treated in Copenhagen, where I work as a pediatric heart surgeon. We treated them a couple of years ago with great help from the lymphatic team in Philadelphia. We had Dr. Johadori and his team coming over and help us treat these patients. And since then we have elaborated on that collaboration, and we have treated more patients, and we are going to treat more patients here in June together with our colleagues from Philadelphia. So before I tell you how we treated those two patients, I would like to take you through the things that we think we know now about the lymphatic system. So I would try to tell you a little bit about what happens in the microcirculation, how we can measure the lymphatic system in the arms and the legs, the impact of using a mechanical ventilator, and a bit about how the system works in general. You've seen this figure before. This is the normal circulation. Remember, the lymphatic system enters here into the venous system at a place where you have a pressure around 6 millimeters of mercury. In the Fontan circulation, it's different. We have a higher pressure, and we heard that several times today. That's a problem for the lymphatic system. It has to work uphill. It has to work against an increased pressure. So this is the illustrations that are made by Dr. Johadori from CHOP Hospital in Philadelphia. And I think it very nicely explains what happens when the lymph has to go up against this higher pressure in the venous system. There's stasis. It's difficult for the lymph to come back. If we look at the microcirculation where the lymph is generated, we learned previously that the majority of the fluid that came out here from the arterial end of the capillaries was reabsorbed in the venous end. We know now that that's not true. More than 90% of the fluid has to be reabsorbed in the lymphatic system. So most of the fluid that enters from our capillaries into the interstitial tissue has to be reabsorbed by the lymphatic system. The way the lymph is transporting the fluid back here to the blood circulation is through these vessels here, the lymphatic vessels, and they're very unique when you think about it because they have power. They have muscle cells in the wall that contracts and propel the fluid forward. And you can also see that there are valves in here that ensures that it's only running one way. So these are two lymphatic vessels. I've taken them out from a patient, not a Fontan patient, but a patient who underwent an operation for adipositas, so bariatric surgery. So we took these lymphatic vessels out, mounted them in our laboratory. You can see these small vessels, they're about less than half a millimeter in diameter. You can see how they contract. You can see how forcefully they contract. They squeeze the lymph forward. The one in the middle is the normal circulation. The one you have, the one you have here on the right side is a vessel where we have made it difficult for the fluid to pass by. We have increased the pressure that this vessel has to pump against. So that's basically what it looks like in the Fontan circulation. You can see the vessel is dilated compared to this one. It's much wider, and it finds it more difficult to contract. We have taken these small vessels to try to establish how they work and mounted them in different settings in our laboratory, and we have found out that they contract spontaneously. They can actually contract up to 24 hours after we have taken them out of the patient. They contract if we take the thoracic duct 1 to 2 times per minute. In the acute situation that we expose them to, they can generate a pressure of 50 to 60 millimeters of mercury. I don't think it can remain that ability to contract if we expose it to that challenge for a long time. But in the acute phase, they can generate a high pressure. They can, in the mesenteric lymphatic vessels, they contract a bit quicker, but less forcefully. And we have also discovered that between the muscle cells in the lymphatic vessels, you can find some cells that look like pacemaker cells. So we think those are the ones who start the contraction of each of the lymphatic contractions. We know that they are innervated. We also know now from these investigations that these small vessels, they react to different channels. They're dependent on different channels from potassium, sodium, chloride, calcium. They're also depending on the level of the pH. The reason why I tell you that is because the fact that they can react and the contraction force and frequency can be changed by different components give us a hope that we at some time in the future will find medication who can increase the function of our lymphatic vessels so that they can overcome the extra challenge we see in our Fontan patients. Right now, we do not have that medication, but hopefully we'll get it in the future. So if we then take patients or normal people who are not having a Fontan circulation and look at their lymphatic system, then if I take one of you, place you on a bed and measure the contraction in your lymphatic vessels in your lower legs, you will find that they will contract about 0.5 times per minute. So every 2 minutes there will be a contraction. It's a very slowly working system. Then if I ask you to stand up, your contraction frequency will increase as a response to the change in gravity. That's a normal reaction in a normal human being. So we have tried in our research lab with different drugs, and as I said, we do not have the right drug yet. But at some point we were very happy because we saw that octreotide was actually increasing the contraction frequency when we applied to these vessels we had taken out from the patients. So that gave us hope that maybe that would be a drug we could use in the future. So unfortunately, when we tested it in our living normal people, it did not increase the lymphatic contraction rate. It did change the pressure the lymph vessel could generate, which may have an impact in the future, but it's something we need to study much better in order to give a clear answer to that. But as I say, there is hope forward that we will find some drugs that will make it work better. So now I've told you something about the normal lymphatic system. Now I'm going to talk to you about how the Fontan system works. And this is a study we did on patients with a Fontan circulation. And then we compared them with some controls you can see here. You can see if you are a normal human being, you have a contraction rate around the 0.5. If you're Fontan with a good function, well-functioning Fontans who do not have PLE, who do not have plastic bronchitis, who do not have ascites or chylothorax, then you can have a higher contraction rate. We see that as a sign of these patients being able to respond to the challenge they live with the increased pressure, so they can increase the rate to overcome the challenge. And the reason why we think that is because when we look at patients who have complications like PLE or edema, then they do not increase their contraction frequency. It looks like you could say like the normal control person. We also can see that if we stress our Fontan patients by exposing them to heat, we know from us, if we know, those of us who do not have a Fontan circulation, if we expose us to heat, we will increase our contraction frequency as a response to the heat. If you have a Fontan circulation, you do not have that capacity to increase your contraction frequency. And again, we think this is a sign of the Fontan circulation being challenged and stressed to a degree where the Fontan patients have no longer the ability to further increase their response rate. So they are already, you could say, at the limit of their Fontan capacity. So this is the part that belongs to the fact that we see the elevated central venous pressure. As we've heard earlier today, it's much, much more complicated than just an increased pressure. It is also to do with inflammation and a lot of other things. But for this, I have only talked about the increased central venous pressure right now. The next thing I would like to make you aware of is the fact that it's not without impact what we do to our patients. So when you think of putting a patient or connecting a patient to a ventilator, you have to be aware of the fact that when we use a ventilator, we blow air down into the thoracic cavity. By doing so, we increase the pressure in the thoracic cavity, and that can have an impact on our patients. In Philadelphia, in Dr. Dory's group, together we have looked at patients who were on a ventilator, and Dr. Dory has measured the pressure inside the thoracic duct. Here you can see a curve here with pretty flat, so there's no contractions in the thoracic duct when the patient was connected to the ventilator. During a short period of disconnecting the ventilator, you can see these nice curves here that generate pressures of 7 to 10 millimeters of mercury, which is enough to overcome the normal pressure you will find in most veins in these patients. So the ventilator, the mechanical ventilator, can be a problem if you have too high inspiratory pressure. So something we should be aware of. So that was a little bit about the physiology and the pathophysiology. Now let's go back to our two patients and see how we treated those two patients and made them do much better. So the first one, the PLE patient. This is again one of the very beautiful illustrations from Philadelphia. You can see here how the lymphatic fluid is running into the intestinal system, into the duodenum. Here you see an MR scan showing a lot of fluid in wrong places where it shouldn't be. That's lymphatic fluid that's not in the lymphatic cavities, not in the and fluid not in the blood vessels, but outside in the abdomen, in the thoracic duct. We can also see there are many more lymphatic vessels here. In this drawing, you can see what happens is that the lymphatic fluid is running out into the peritoneum and it's running out into the gut. So again, with help from the group in Philadelphia, we had Dr. Dory and his team coming over, and by using a technique where they inject the inguinal lymph nodes and a direct hepatic lymphatic investigation, they can illustrate the lymphatic system inside the body. And here you have a very nice, where you see the thoracic duct here. And what you see here is some vessels running from the liver to the duodenum. And the large white thing you can see here is the gut that's filled with lymph flowing right into the gut. So you can see this patient is losing a lot of fluid into the intestinal system. Here you can see some of the lymphatic vessels that are connecting the liver to the duodenum. And on the next slide, you will see here you can see a needle inside that's illustrating some of these lymphatic vessels. And by gluing those vessels with glue, you can stop the outflow of lymph from the liver to the duodenum. This one is a gastroscope that's inside the intestinal tract to make sure that it's the right place we place the glue and not in the other important structures. And here you can see, you've also seen this picture before, you can see the inside of the gut where you can see the lymph that has been colored with a green dye. You can see it running out into the intestinal lumen. So after having done the embolization, we wait a few days and then we decompress. We make sure that the central venous pressure becomes lower at the place where the lymphatic system is going to run into the veins. And in this particular case, we did it surgically. So we did a surgical procedure where we moved this part of the venous system to an area with a lower pressure in order to decompress the lymphatic system. So this young boy is now doing much better. These pictures are taken 2 months after, but now he's a couple of years out after his procedure, and he's still doing very nicely. He is eating, he's growing, he's well, he doesn't have pain any longer. His albumin level is not completely normalized, but become much, much better. And basically, he's doing much, much better. This is not a cure for many, many, many years. We don't think that. We think we may have to do something again at a later stage, but for now, it has definitely changed his life enormously. The other young man who had the plastic bronchitis, we also treated him. Here you can see the way it looks. You have the lymph, instead of running up here, some of it is running backwards into the lung parenchyma and into the airways. Here you can see it in the lung parenchyma. Here you can see it in the airways. And this lymph in the airways is what's causing these plastic-looking casts that they cough up these patients. When we did MR scan on this young man, you can see here that his MR scan is full of these white areas that are not normal. These areas are because of the lymphatic fluid that's present in his parenchyma and his lymph vessels that are far too many here in this area. And on this side here you can see some black stuff, and that's lymphatic vessels who are anomalous. They're not supposed to be there. Here you can see in a lymphangiogram where you can see contrast with glue placed inside this anomalous lymphatic vessel here, or vessels, there are many of them. And by gluing this patient was cured for his problem with coughing up these casts, and he's also being well now, almost 2 years since we did the first procedure. Since then we have done some other procedures on Danish patient and Norwegian patient, and next month we are going to do another couple of Danish patients and 2 Dutch patients who have protein-losing enteropathy, again in a very, very nice collaboration with the group from Philadelphia. So with that, I would like to say thank you and say now you heard a little bit about the normal lymphatic system, the lymphatic system in the Fontan, and how there is great hope for the future in terms of treating them with interventional procedures and also surgical procedures. I can say that we have only done one of the surgical decompressions, because since then the group in Philadelphia have developed a way of doing the decompression percutaneously. So now the patients are done completely percutaneously, embolization and percutaneous decompression. So it's a field that's advancing very quickly, and I think there's a lot of potential and a lot of hope for the future. So with that, I would like to say thank you for your attention.
Vielen, vielen herzlichen Dank, Frau Dr. Wiebeke. Vielen Dank, dass Sie aus Dänemark hierher gekommen sind. Ich freue mich, dass ich nächste Woche nach Dänemark fahre. Ehrlicherweise aber nicht beruflich, sondern im Urlaub. Entschuldigung, dass ich da meine positiven Gedanken an Sie bringe auf diese Art und Weise. Vielen, vielen herzlichen Dank. Gibt es noch Kommentare, Hinweise?
Any comments?
Ja, bitte.
Yes, my question is whether with your patients that you see every day, you see a correlation, whether in your patients you see a correlation between
Diaphragma. Okay. Diaphragm palsy. No, okay. No, for sure not. Herr Hart.
Which one do you think was a game changer? The thoracic duct decompression or the lymphatic vessel closure?
I think in some patients we need to do both to achieve a result. Yeah, I think in some patients we definitely need to do both procedures to achieve a result. We can gain an immediate result by just closing the anomalous vessel, embolization, but then they will come back if we do not do the decompression. So the first patient I presented needed both procedures. The second patient, where there was congenital anomalous lymphatic vessels but no high pressure, we can do with just the embolization. And a few of our Fontan patients where we do not have the high central venous pressure, but where we have the anomalous vessels, we would need to do the embolization only.
Thank you.
Thank you. I have a question. I'm over here.
Sorry. Sorry.
I found your results on octreotide very interesting, and I wonder if you can comment on systemic application in Fontan patients, because I remember in liver patients it is used in portal hypertension. So, do you aware of use in Fontan patients to treat protein-losing enteropathy?
So, as far as I understand, you're asking about the octreotide? Yes. Yeah. I think you're all aware of the literature with conflicting results, that case reports of effect of octreotide, but also a lot of cases where it does not work. What we could see from our in vitro studies were that there was a very clear dose response curve with a maximum where it was working, but if you gave too little or too much, it wouldn't work, and it was quite a narrow treatment window. When we did our clinical investigation, which was in normal young people, of course we aimed at getting the right therapeutic window, but yet we did not find a very significant effect of the octreotide on the contraction rate. I think we still would need to, first of all, try to treat some patients and see if we treat them with the right doses. Will it have an effect then? That's one thing. And then I think we also need to see if we treat it over a long time. This was just like an acute experiment. So if we treat it longer time, if it has an effect. But it's not like it's a very clear effect you will find from the octreotide. But there may be a little benefit from it. But as I said, we haven't investigated that in depth.
Jetzt habe ich keinen mehr übersehen. Vielen Dank, Frau Kollegin.
Many thanks, dear colleague. And before we continue, just a quick reminder, whoever needs any further information, please think that the participation, the list for the participating in further training is outside, and you can enter your details now. Mrs. Venegas, please, your turn. Dear ladies and gentlemen, dear colleagues, I'm a mother of 3 sons, aged 12 to 18, and work as a specialist in gynecology and obstetrics in a practice in Cologne. My middle son, Joshua, is 15 years old. In summary, he has a Fontan circuit basis on congenitality with TGA, pulmonary artesia, with ventricular septal effect. Already in August, after Fontan completion, Fontan failed with PLE, so that a resection of the atrial septum with fenestration was performed. There was a clinical improvement with a stable course in November 2017. An LPR stent was placed. In the course of 2020, clear clinical PLE symptoms appeared again, and in September 2020, cardiac catheterization with stent dilation followed. January 21, an implantation of a CRT pacemaker and medication with budesonide and with a statical clinical laboratory deterioration. An attempt at therapy with sildenafil and bosentan had to be stopped, and as Joshua's clinical situation was steadily deteriorating and he was no longer fit for school, and his albumin level dropped to 1.8 gram, and I applied for reimbursement for lymphatic intervention at the Nemours Children's Hospital in the USA. In August 21, which unfortunately was rejected. At the same time, I was advised to list Joshua for heart transplant. However, it was still, and it's still difficult for me to take this step because a transplantation is for me a last resort. According to a statement by the German Children's Heart Foundation, the 10-year post-transplant survival rate for children with Fontan-Herz and PLE, bronchitis plastica, is well below 50%, normally 80%. Even the expert of the MDK makes a following statement in the Social Medical Contradiction Report of 23rd September 21. I quote, "The available literature suggests early planning or consideration of transplantation according to the ST2K guideline for therapy-resistant PLE in order to have the best possible chances of finding a donor organ and a better outcome. But this option does not represent a direct treatment alternative from a socio-medical point, if only because of the non-immediate availability of a suitable donor organ and the statistically proven risk for complication associated with transplantation." End quote. Nevertheless, the health insurance company again refused to pay for the treatment, but we could do some fundraising, and Joshua could fly to the US in October 21 and 1410 and 2810. A total of 7 holes were transduodenally glued on the 11th of November 21. The albumin value was 3.5 G at deciliter. Previous value 1.9. Clinically, Joshua was also much better. Unfortunately, in March 22, the albumin level dropped to 2.1, so I agreed with the doctors at Nemours Children's Hospital to repeat the lymphatic intervention. Fortunately, the remaining donations were enough for a re-intervention. This took place in April 22. 4 lymphatic leaks were again exposed transduodenally and glued. The following day, Joshua was already able to play billiards at the Ronald McDonald House. He recovered very quickly. The albumin value rose 3.2 already 8 days post-operatively, and the alpha-1 antitrypsin fell from 1,125 micrograms per gram below the detection limit. For 7 months, Joshua was doing great. He was resilient, happy, and grew 4 centimeters, even though there was initially temporary deeper deterioration after his first corona infection in September 22. Since January 23, Joshua's albumin value has unfortunately been falling. I filed a complaint with the Cologne Social Court against the refusal of the health insurance fund to cover the cost. The proceedings are still ongoing. So far, the lymphatic intervention by Dr. Itkin's team does not aim to cure PLE, but as you can see on the photos, it does significantly improve the quality of life and save time. This is also the opinion of Joshua's long-standing pediatric cardiologist, Dr. Koch from Cologne. I would like to gain this time and quality of life for my son and delay a possibly necessary transplantation as long as possible, as I have the greatest respect for the risk of the heart transplant itself, as well as for the circumstances associated with this, and in order to perhaps be able to fall back on alternatives that you, as our children's doctors, will find out and develop. I cannot imagine how it would be possible for me, for example, for family and existential reasons alone, to spend the waiting time for a suitable donor heart with Joshua in a clinic that might be far away, since I am single, and on the one hand, I still have to look after his brothers who have to take a backseat for far too often, and on the other hand, my professional and thus our family financial existence would be at risk. If I could, I would immediately fly to the USA with my son. Unfortunately, this is no longer possible for me for financial reasons alone. So I promised Joshua that I would continue to look for solutions for him and never let him down. Giving up is not an option. Thank you for your attention.
Thank you very much for your perspective. Professor Herbeck, an open dialogue. This is about prenatal education, something that is not only happening at Fontan centers, but it's everyday life everywhere, and where we again and again have ambivalent, ambiguous situations. I'm looking forward to your talk. Thank you very much. Thank you very much for this, for the invitation. It's really very bright here. I can't, can't see anything. So the objective here is to initiate an interdisciplinary work and to involve the families. and the patients. So I'm happy to be able to talk with Ms. Venegas and with Ms. Vogt about the topic of the information that parents need when they expect a child with an univentricular heart. The prenatal diagnostic hits the family without any expectation, and in the suddenly you have this diagnostic, and it's clear that there's an univentricular heart, and the pregnant woman and the family are shocked and totally unprepared. They have the diagnosis, they have anxiety, they are stressed, and they look for information. So what does our counseling or consulting look like? What we normally do is that we inform the families from the prenatal situation up till the moment where the patients are adolescents or adults. We talk about the heart defect, prenatal diagnostics, and therapy. We talk about the postnatal therapy concept. We inform about the operations and about the outcome of the child. Then we talk about the survival, about the neurological results, cardiac catheter, maybe less. But sometimes we're not precise enough when we say that your child will not will not run marathons, and then the parents say, well, we want our child to have a normal life. And then we're very vague about the future in 30 years. What does it mean for an affected person? Will they be able to have a family, a profession? Are we talking about the heart transplant and about the future? So we have a study here which is 10 years old, but nevertheless very interesting, where they asked what do the physicians tell the patients when, or the families when they have a univentricular baby. So here you see, so the dark color is what you never talk about, and we see that in the first counseling we're not talking about complications, about the PLE, for example, about growth inhibition or other complications. But what do parents want to know? They want to see the big picture. Will my child be able to lead a self-determined life? What quality of life will they have? What limitations do we have in everyday life? There's a fear, there's an anxiety about what it all means, and sometimes they're siblings. So what does it mean for the whole family, for the siblings? So parents want clear information for decision making. Ms. Venegas wanted to know the unvarnished truth. So if I have a patient with a univentricular heart, so palliation, it's a seriously ill child and will be a chronically ill adult. Parents want to know the realistic number of OPs, of catheters, of hospital stays. They want to know the spectrum from the uncomplicated course up to complications until death. And an honest answer that there are problems for which there is no solution. So the counseling should be empathetic, and it should have a simple language, and there should be an exchange with other affected people, for the self-help group, for example. And here I would like to point to an interesting study in the German-speaking world. We have dealt with this area, and Alexandra Kovacevic made this study in Heidelberg, and she talked with parents after the birth with a congenital heart failure, heart disease, and she interviewed the parents after the birth of the child. And here you see the significant parameters that were decisive for the parents to rate this prenatal counseling as effective. So the statistically relevant was the parameter of support and empathy. So Ms. Vogt talked about this. When parents decide, then the physicians should say that we go this, we do this together. You're not alone. The language should be simple and understandable, because that conveys safety. And that means that you can make decisions. And ideally, the counseling should take place immediately after a first diagnosis. Because if you hear something, it doesn't necessarily mean that you understand it. Also, because you are excited, you didn't understand everything. So it's good to be able to read something. Also, it makes sense to give people addresses to make possible an exchange with other people who are also affected. So the study shows that these interviews should be uninterrupted in a separate room. And if parents, even if they understand the language, sometimes they may need an interpreter or a translator. So what does the ideal counseling look like? You need the big picture, not the details yet. And you should be honest about being insecure. People tend to think that physicians know everything, and we know that we don't. The counseling should be free of judgment. It should take into account the quality of life, and a visit on in the unit, the hospital unit, should be made possible, so that they know what an intensive care unit looks like. And this young lady here, do you see on the picture on the right? It's the mother is the one with the univentricular heart, and she is mother of a child. So we need to be able to identify the needs. We have to continue to investigate, research. We need training and feedback in order to do a good counseling, and in order to satisfy the needs of the parents. Thank you very much, especially Christine Venegas, Ms. Vogt, and Frau Dautz, and all the families and colleagues with whom I have already talked. And I am happy to give you some literature if you are interested. Thank you very much for your attention.
Yeah, many thanks. The motivation and the target group, the size, is extremely understandable. But if I look at my last consultation in the last month, then I have to admit the biggest problem was the language barrier, and there are not too many possibilities to communicate something. Maybe it has also something to do with the background of the families consulted. So the target size is very convincing. But the everyday problems can be far beyond it. Is that the right summary? Yes, sometimes I think the cultural circle is also decisive. Mr. Kovacevic could not prove it in his study, and he looked for it. And if you have a cultural circle where it's clear that there is no termination of pregnancy and so on, then it's very difficult, and it's difficult to communicate with people if we don't know what's going on there. Can I ask something very briefly, and then I can see you? Do you have any information, the parents who managed to end up in your consultation, the parents that were in gynecological consultation and had made negative experiences? And this is what happened with us, and the people were almost ready to terminate the pregnancy. And I think I could mention 10 families in my private sphere alone, and people who have children now, and they're very happy about it, even though it was difficult. But do you have any information? Do you have contact to people affected? And it's something that it's not really happening. There is no study from the German-speaking area from 2013, 2012. There is a study that looked into it and could see when the pediatric cardiologist consulted, then the tendencies to terminate was lower by then compared to the consultation with a gynecologist. So we also had thought that maybe when it comes to these gynecological directives, these guidelines, that we can establish the, contacts and that the situation of the child with heart problems is reflected. Well, I don't know if it can be done in the sort of legal directives, but Mrs. Venegas mentioned it too, that maybe you can do create a booklet and provide it to the doctor surgeries and give information to the people. That would be one option, and to have this in prenatal surgeries, etc. And that I think they do a good consultation, the prenatal surgeries, also if it's resident prenatal surgeries. But my personal opinion and experience is somewhat different. But I think the commitment for us can be given also that we will be available and wherever we can help and fulfill these building blocks. And yeah, that's great. I'm looking forward to it. Thank you. We need a microphone. Many thanks, Ulrike, for your presentation. You mentioned one point, the value-free consultation. Well, I think it's difficult, I think, because I think we all have our values, and even unconsciously we'll pass them on. So what would you say if somebody asks you, what would you do? The parents always ask it, and I say, half of the parents ask it, and then I say, I'm a pediatric cardiologist, and you can believe that I, in my role as pediatric cardiologist, that also have a lot to do with patients after the birth, and that I have an idea of what it can be like, and and I give you my honest opinion, but I cannot give you an advice for you as a family. You have to know yourself on how you will decide. and how you come to the decision. And I can only help you with it by informing you as well as possible. So you can see that I'm, as a pediatric cardiologist, I cannot think differently. I have to do it per patient, per child, and of course, for me, my task is to give objective consultation and help the parents to make their own decision in the context of the family, in the doability of the family, and also that reflects their ethical ideas and thinking. I think you're absolutely right, but I don't think that we cannot give a value-free consultation, because we always have values and that we should think about, and that should also be part of our consultation. But it would be more neutral to say, with an open result, with an open end. This is what we do on a daily basis. I come from Hanover. I do consult in a university clinic and also in a prenatal surgery, where we try to do as much as possible. But I think it's also it's difficult, because you know the whole situation. You know good Fontan and families who have problems. But I think also we as a or you as a pediatric cardiologist have a different approach, and you love the work you do. And in consultation, I think you have to be open and be transparent. And if we as a team want to go this way, this route together, and we want to find out what is the best for you and your family. And we will accompany you in good times and in bad. And there were a lot of families that come, and I wanted to have a second opinion, because the gynecologist say we have to terminate the pregnancy, etc., etc. And then, well, I think you have to be open and transparent, but also support the family in the way they want to take, the route they want to embark on. And so if they decide actively to have a child, and they say we'll do it, and then or we offer compassionate care, and that's important, that you then support the families as best as you can. Mrs. Herberg, many, many thanks. I'm asking Mr. Rickers to come to the front here, and the topic is myocardial perfusion structure and hypoplastic left heart syndrome in the Fontan circulation stage. Mrs. Sänger, thanks for the invitation. Good evening, ladies and gentlemen, dear colleagues. Well, after the previous topics, in the next 10 minutes, I want to take you into the world of the microcirculation, and I hope that you can still be attentive, because alcohol also increases the microcirculation, so it should be positive. And it's myocardial perfusion and structure in the hypoplastic left heart syndrome. And we heard that Fontan is a big group. There are a lot of different diseases. Even the hypoplastic left heart syndrome is not unique, it's not uniform. There are 4 main subtypes, and they are characterized by the aorta valve being either open or closed, and the mitral atresia, and that is a rudimentary left ventricle still existing. We can see the 4 types in pictures here, and you can see that that on the left-hand side there is a somewhat different, and I want to present to you a study from my time in Kiel with MRT. We looked at the coronary microcirculation in HLHS that is largely unknown. We know from pathological reports that are 20 years old that we in a Fontan situation, and even before in all those cases, the coronary arteries are perfused mainly retrograde through the native aorta, and it can also come to a situation where the microvascular control is affected, and we looked at several MRT methods that I only want to mention briefly. Here we looked at the blood flow and also the structure and the tissue vitality, and we looked at a big group of 119 hypoplasmas and additional controls from America. And what you can see here, that half of it, about 40%, is not a left heart syndrome, and the other groups, the other three groups fall under rudimentary LV cavum, and well, the one on the left is a no LV cavum. And so the left ventricle, you can do it very well with MR, and maybe the children have undergone MRI, and you can measure and do. Here we have exemplary pictures, and you can see in these diameters that there are different types, and you can see on the left, even as a layman, you can see that there's no left ventricle, and on the right you do have it. This is with an MR first pass perfusion imaging, and under pharmacological stress measure, you can measure the blood flow. You can see that it's light, becoming light in the ventricle, and then it gets dark again. That's something that is noticeable, and these areas then can be looked at in the so-called post-processing. And here in the ventricle we have it as divided into 4 segments, usually 17 segments, but it's not doable with the right ventricle. And so anatomically and physiologically we carried it out, looked at the septum at one part and the rest in 3 different sequences, and with a quantification of the myocardial perfusion, then you can also measure the blood flow, and in a common stress situation, and that has been developed already a couple of years ago. Another important method in MRI diagnosis is the solid fibrosis imaging, and you can see, if you wait a little bit and the contrast liquid, then it shows where there is scar tissue, and then sometimes it also shines, and it's a little bit like an indication that is similar to a heart attack. That is shown by the contrast agent. The results showed that the blood clots on the left compared to the controls, they are not really different from the silent situation. We compared it to the rate, stress perfusion is quite different. It's very significant here that the myocardial flow is quite different. And you look at the individual subtypes, then you can see on the left that is the aorta atrophy, and which is quite higher than the second group, and those are the patients where the blood is flowing into the left ventricle, but it cannot flow any further. So these are also seen as the most difficult patients in the surgical reports. And then we also had a certain percentage, 14%. They had small scar areas in the myocard. It's difficult to say. We have to speculate where they're coming from. If you then look at it, then you can see as well that with those patients with fibrosis, even though it wasn't measured, but the overall results are quite reduced. And if you look at all segments, I said we looked at 4 segments altogether. The individual analysis, I don't want to go into detail here, but if you look at all the segments and the baseline research and follow-up research, and then you could see that the right ventricular function with the stress perfusion is correlating, so that's very significant. And then it was quite interesting I was surprised really that on the left graph we can see the silence of perfusion compared to the age of the patient at the Fontan surgery. He left the silent and on the right hand the stress perfusion, and you can see that there is a peak at 3.5 years, and then the perfusion is a lot lower, and also the variance is tighter. The intervals are closer together. So this could be an indicator that this is correct after all. And if you look at the right ventricular function, and it is also goes for the glumina, then you see bulimina, then you see that similar result with higher age. It goes down, and the probability in the right graph that you will find scar tissue with higher age, it's also increased with PCT. So now I'm done with my 10 minutes in microperfusion, and well, you could see that children with HLHS syndrome, they have in Fontan circulation have reduced the myocardial perfusion reserve, and that the aortic atresia subtypes, the presence of the mitral stenosis and LGE, diastolic dysfunction, and older age at DCPC are risk factors for impaired microcirculation. So these conclusions, findings, they could point out that there was a microsectional one-point study, so to speak, and so the removing of cyanosis that is still existing until you can do a Fontan surgery. It's interesting to find out how far the cyanosis has an effect. And well, I thank you for your attention and also for the team that are still working in various centers. Yes, many thanks for your attention. Well, thank you very much, Mr. Rickers. Any remarks, any comments?
Maybe 2 or 3 cases, and those were excluded, by the way. But when you see them later in MRI, of course, they have a little scar tissue in this region. No? Yeah.
Any other remarks? No? Then, okay, thank you very much. First of all, many thanks for the invitation to speak to you, also as an exotic human genetic expert, and we actually look mostly in to the genotype, but I want to talk about the consequence of the genotype, meaning the phenotype. So, yes, and I will present a procedure on the lymphatic anatomy, and if we look at when we have a patient with a lymphovascular disease, then you can ask, are they all similar, or we don't really know, but what could be the causes, and how could be you would probably look at a biopsy, and due to this biopsy, you would do the classic hypsodysy that you look know from university, and you'll take a sample that's being colored and etc. And then you have these 2D cuts that are being interpreted by the pathologist, by the scientist, and then you carry out a diagnosis and to understand better. And if you do it for such a patient with a lymphatic vessels, and you see a thickening epidermis, and you see the structures that are probably vessels. And if you then take it one step further and look at the lymphatic vessels and color them, you can see that the blood vessels, the lymph vessels exist, and that they are luminized. And if you look at the luminized lymphatic vessels, you ask yourself, would you do the same? Would you expect the same in healthy samples? Yeah, the answer is very difficult to say. What's the phenotype? What is the reason? What's the cause for these phenomena? What can be the causes? And we look at the lymphatic vessels. We have capillaries, and we have valves. We have for the unidirectional flow. And what could be the cause? We have no valves. That's a classic example, but then you can also look at these small lymphatic vessels that they are blocked and maybe there is a different cause. There is a disrupted vessel and that it's cannot allow the flow of the lymphatic and it's based on 2D histology, and with this example we can only understand it very with a lot of difficulties, and it's a bit like a water hose, to make it simple. So you can close the controls. There can be it can be a disruption, there can be a hole or an obstruction. These are the different possibilities, and in that case we have to answer it. And yeah, if we think about this technology, the classic two-dimensional histology, is it sufficient for a complex tissue structure and to show it in its complete context? And I can show it on these slides. If we want to understand the vessels and have these 2D cuts at the above, the information that we get is not sufficient in order to understand a complete network and the tissue architecture. It could be that we are now interested in some cells, then in this case, based on the 2D histology, the green and orange are equally represented, but the reality is completely different. Or if we look at rare cells, for example, hematoma, then these cannot be found with this classical histological procedure. But Virchow was a smart man, and he said, it is that our views advance as much as our ability to see has been extended by the microscope. So the tissue autonomy, you need microscopy, and we knew different technologies, and it's a 3D technology. It's a bit like the introduction of the CT in radiology. It's a kind of tissue CD, and we use fluorescence measures instead of laser. And so we then color the sample, but we don't cut it in thin slices. We leave it as a whole, and then we color in the structures that we are interested in, and then we use an optical imaging similar to CD in very many thousand levels, and then we can have a 3D reconstruction in order to understand the vessel anatomics. And this is a let's go one step back. Yes. Okay. So this is an advertising of ZEISS, but it demonstrates very well how it works. We have a sample chamber with incubation and agarose embedded live zebrafish embryo in the capillary, and then we place it in the right position in the CT, and as soon as it's in the sample is in the right positioning, then we get our first results. And then we use we go through the entire sample, and we create 1,000 different optical levels. And you can see here the fast volumetric imaging, and this is the zebrafish embryo 3D view at single time point. And so you can see the epidermis here, and then the blood vessels, and then in red you can see the lymphatic vessels, and this 3D is much easier to understand what the structure looks like. And we used it for controls, and then we said, what does it look like in other diseases? For example, with the lymphedema and lymphatic edema. So we can see that there are vessels and they're luminous, and but these vessels are disrupted. They're not connected. And then we can imagine disrupted vessels. They don't allow an outflow of liquid, and the same can be done with a lymphatic malformation. And we have now different genotypes that we visualized in this way, and now we can describe them better and differentiate them better. So yes, and then we could show that we can differentiate. We must differentiate what kind of phenotype exists. If you have this data, you just don't want them to analyze them, but you want to, analyze them quantitatively, and then can segment the data and visualize the parameters that you are interested in, the networking of the vessels, etc., whether they're straight or crooked. And then these are 2D data. We also have 3D data, and most of them were pictures of the skin and epidermis. And yeah, we can use it for all kinds of tissue samples. And for example, this is a lung sample where we can see the 2D level, and then in the middle, the picture, it's color adjusted in HE, and we can go through the lung biopsies, and it's a very detailed description. Alternatively, you can then also have a visualization in 3D of fluorescent intestinal biopsy, and we can go into the sample and then look at all the details in the intestine. And for example, if we would do it for blood vessels or lymphatic vessels, we could see in our patients that the lacteal is normally built up, and are there any changes, and we can also have a view of the pathogenesis. And well, that is almost the end of my presentation, my last slide. And I could make up some time, and I thank you for the attention, and I'm looking forward to your questions. Mr. Egerling, that is fascinating for me, I must say, because there are different malformations, and I would like to see with the patients we had in the last 2 years, which ones I could introduce to you. This would be my spontaneous reaction. And I move out of the light so I can see who's got a question. Well, yes. First of all, I had a question asking, could you offer to the clinics that that they would have a tissue sample from transplanted hearts, maybe the affected Fontan patients, the young people say. I would like to see more research so that other young people would be spared. So can these tissue samples be submitted to you? And maybe we could also do an online consultation, a seminar, where you introduce yourself to the families, what you do, and where families can participate in the research in the lymphatic system, that you present it, not individually for every family, but the families who are interested could participate and also send blood samples and tissue samples. Yes, in principle it's possible, and we would also be interested in collecting the samples, but You also mentioned a project with the cardiological colleagues at the Charité, where we do biopsies and we want to do some endological results to better understand the anatomics. Yes, another remarks. We have still 3 presentations. Thank you very much, first of all. And so now we continue with colleagues from Bonn.
Dr. Müller and Dr. Hertel. So it's flying high with half a heart, long distance flights and mountain stays. Yes, thank you. Mr. Hertel is still in Bonn. Thank you very much for your invitation. It's surprising that you're still here. So we're all still awake. I would like to take you to a small journey to the mountains and into the air. We've heard a lot about what is possible, what's not possible, and I would like to talk about what is possible. We made a study, conducted a study, so what does one thing have to do with the other? So the connection is the air. So the effective oxygen content in these 2 atmospheres in the cabin of a flight. It's more or less like on a mountain in 2000, in the height of 2,000 meters. So this is what you deal with and that we have to deal with every day. So what do we do with this? Is it a problem? Can we fly without children? Can we go up? And the young people sit there and say, yes, I want to go to America or to Australia. I want to go to the mountains, go skiing with my friends. So this is what we try to look at. And I would just like to give you a few impressions. So I just sit back and enjoy our hypophone study. This is a combination between hypo and Fontan. So what do we need? We need a team. We need cooperation partners. And we also had some funding. So we had a lot of support in the conducting of this study. And then we have a very large team behind us. And if we think of it, so what do we need in a study like that if we go up to 2,500 meters? So so we simulated this. So there's no pressure chamber where you have to go up and down and wait for a long time. And that's why we said that we wanted to look at it. So we worked with nitrogen. We needed a lot of nitrogen. And we had an atmosphere with 2.5% of oxygen in the air, which is more or less what you have in 2,000 meters of height on the mountain. So we need willing subjects, Fontan patients, who said that they would like to do this. So we spent 4 days with them. So they had to take 4 days of vacation to participate. At the beginning, we had normal air, also as a control, and sometimes we just sat outside. So then we needed the rooms. We found an institute of the DLR in Cologne, and we could go in there for 4 weeks and try out with and make the study with different groups of patients. Matthias Maurer is one of our more famous neighbors, and he just came back from some trip and sometimes said good morning. Apparently he's an astronaut. And all that is interesting, something that you don't get to know every day. And our groups were very happy about this. So 36 hours of sitting in a chamber can be quite boring. So we had some bread rolls in heart shape. And then we need people who are willing to do some scientific camping for 4 weeks. And I spent the night outside in a bus so that we could intervene anytime it was necessary. And then we needed people who were willing to do this test and to have some fun doing it. This is a short video. That's the module. It's like a big flat. It's like a shared flat. So we can do anything with this module. That's Mr. Hattel, who's not here today. That's the preparations. Here we had different measuring instruments. We had a big kitchen. We had very good food. So we spent 36 hours with these test persons in there and made different tests together and looked at different things. This is the team, and these are all the people who do the preparatory work. So we had a team of more than 20 people that dealing with 3 patients in the end, because we said it has to be safe. Nothing can happen. And we made lots of tests. So this is the MRT. And Mr. Maurer, this is where Mr. Maurer lived. So in the end, we had 18 patients at the age of 16 to 39, and we lived with them, or 3 people. More wouldn't have been possible, but we said day 0. So we made an MRT under normal conditions, an echo, EKG, and a polysomnography, testing the sleep pattern. And then the first night came, and that was a PIC line that we needed to put in order to measure the pressure values. So we could see exactly what pressures we had and to see the value that we've always wanted to see. What happens in the Fontan circulation under these conditions. Then we made a bicycle test. We spent every night with the polysomnography, and then we went up in the third night. And we went up to 2,500 meters. And most of the test persons said, when does it happen? And they weren't aware that we're actually there. And then it was, then the interesting part started. We did an echo bicycle test. And on day 3, after a night in the height, we had another day which was really very compact with lots of tests. And we made another MRT. We had a bicycle test. And then afterwards, the patients could go back into the 21%. So this is a day plan. We really had a lot to do, and more than 3 test persons were impossible. So this is every quarter of an hour. And this shows how well you have to be organized to do this sort of thing. And we had the support by people who did some NASA studies. So we generated, over the 4 days, we generated lots of data. We looked at the basic data, the normoxia, monomoxia, and the hypoxia, and the difference, the mean of difference. And you see that the saturation here, because of the height, goes down. Those who were locked had 90% as an initial value, because we said we want to make sure that we can make it. So those who had an initial saturation of under 90 are not included here. Now, if we look at it now, this is something that we see in the height. This is the breathing and the volume. What we see is normal and mountain, so not a lot is happening. So they compensate by a deeper breathing. We all do that, no matter if we have a basic disorder or not. Then we have the heart rate, heart frequency. It's not relevant. You can see here a little increase, but not much. So all these are and now the important thing is this is a catheter that we placed under sterile conditions. That's one that we can leave for 30 days. If we look at it, we can see that that's a monitor where we had some activity, breathing activity. So we have an undulation there. That's only a mean value, though. And then we told them to put some pressure on it, and it goes up and down. And so we have good values, and we see values that we can compare. And here we see the distribution. That's norm oxide. and nothing much is happening. So the pulmonary pressure that we are afraid of in the height, because of various reasons. In our Fontan patients, it doesn't seem to increase significantly, and that's very good news and very important news. That tells us that it's not a big problem. At rest, though, at rest. It was a good time, so we spent a lot of time together, too. There was some kind of mask, and went to the MRT. That was the only test that we did outside. So they needed to wear a mask during the MRT, and MRT is one thing, and MRT with a mask is a different kind of animal altogether. And they were really very brave. We looked at the pulmonary blood flow, and so here we see that there is no significant or relevant inhibition of the pulmonary blood flow. And the data is really made us very happy. Then the polysomnography. Why that? Well, we know from healthy test persons that we have a change of the sleeping pattern and of the breathing during sleep. So we were afraid of the nocturnal breathing. We will have less saturation, and then different breathing patterns and a change. So some patients have different. So it did work. It looks strange, but it did work somehow. So we see a decrease of the saturation. So the data as such is very complex. So we have normoxia and hypoxia. And yes, there is a change, and it might be relevant when we say we don't want to go to Mallorca, but to New Zealand, for example, where we have to sleep. And it does make a difference, and more than the usual day data. There are patients who touch the 75, and I spent many nights in front of these monitors to see whether it works or not. But last but not least, we said it worked with all of them. So concluding, we can say that everyone tolerated the hypoxia well, very well, more than 24 hours. Some of them even 30 hours in the module, and there was many tests. We didn't have to take anyone out. Nobody dropped out either. So they really were game. So we have normal response of heart rate, blood pressure, and respiration. Then we have a relative drop in the saturation during the night by 6%. That was to be expected. Also, comparing it to data of people with a biventricular heart, and at rest, we have no significant increase in PAP and pulmonary blood flow. And this makes us very hopeful and very happy. And we can say that this is something where we don't have to control ourselves. So, but this is not a general affidavit for everyone. And it doesn't matter, and everyone can go to Australia now. No. It's an individual decision. You have to look at the values. You have to be very careful and consult your physician. And you also have to look at the saturation very carefully. So we cannot say that everybody can go to Australia. But if the values are good, then we don't see why they shouldn't go somewhere. And I'm happy to tell you more, but I leave it at that. It's very late. And thank you to everyone who was involved in this, and especially to the families and the patients who were willing to play the game and be part of this experiment. And of course, people learned a lot about themselves and about their bodies. And it was a good experience for them. It was very good. Thank you. Thank you. Especially because this is a project, a research project that is linked directly with quality of life. Even if you can't say that yes, not go to Australia. So you really, it's as I said, it's an individual decision, and you have to look at the saturation and so 4 hours were okay, for example. Within Europe. Stay within Europe.
Well, good evening, Mr. Sanger. Thanks for the invitation. All of you, I come from the southern part of the Republic in Bavaria. I want to talk about the interdisciplinary Fontan consultation beyond the heart. The holistic approach has arrived in Bavaria as well. So for us, it's very decisive. Quality of life is something that ultimately is very decisive for our patients. The hemodynamics and the complications have to be treated, but we have to make sure that they have a very good quality of life. The concept of quality of life as a multimodal concept is not new. We had the first times it was mentioned in 1989, and in research it has been focused on, and the hemodynamics has a very big influence on the drug and interventional therapies, and also again on the life quality and the healthcare system and the resources that we are using or we cannot use. because it's not being approved, and these therapies and by the healthcare providers. And this slide has been featured in previous presentations, and Fontan has a lot of influencing factors. Two things I want to mention: movement and activity from very young years play a very big role, and we only do referrals so for patients who do sports and not for non-sports. And the second thing that was mentioned here, the psychosocial support of the families also has to be improved in this area. So what does it mean? Of course, we have a pediatric treatment system with cardiologists, and also in adult medical treatment we lose patients who haven't been treated for longer periods, and then they come back when they have complications. Therefore, in order to use these systems better, very important factor is the family, the support of family, friends, and self-help groups. In our own studies, this is a study we presented in Hamburg, we could see that the complex heart failures and people who have more than had done more than 2 surgeries, of course, it's an influence on to the detriment on the life quality. But the support of the parents is very important for the quality of life for the children. And of course, the personality plays a big role when it comes to resilience. That means in Erlangen, we've had very dedicated diagnostics for the Fontan treatment and Fontan consultation. We want to use new methods, and of course, after the Glenn operation, after the Glenn surgery, this is a further MRI, and after the Fontan, 6 months after. And we also do one before Fontan, and this catheter check, and but optional also as for some patients who do a fenestration, there is a heart catheter, and then we also collect the data in order to do risk stratification. And as a rule, we do data collection regarding the surgery, and also the participations of the parents in the Fontan studies. It all flows into these data collection, and we do it as a rule according to after the diagnostics and surgeries. Our consultation works as follows. We see the people about every 2.5 years for a whole day. They come to the clinic to us, and we have a very competent network of resident cardiologists. 1 week after the Norwood surgery, we accompany the patients, and then we see them every 6 to 12 months, and every 5 years we do an imaging plus or minus a catheter, and so the average age is listed when the patients come to us, so that we have a certain structure and the patients know when to come to our centers. Then, as shown before from the US and in Berlin, you need an interdisciplinary system. You need psychology, gastroenterology, sports medicine, radiology, pediatric and cardiology experts, also for social medicine and nutritional counseling. Of course, it's nothing new, but lastly, the interdisciplinary aspect, including psychology, gastroenterology, is very decisive. Then what do we do with the findings? the Fontan board meets once a month with all the disciplines involved, and we collect the findings and deduce a concept from it. And sometimes we only see the parents after 2.5 years again. We also have a video consultations with the parents that has the advantage that only in the video consultation both parents can be present. They have, interestingly, a lot of questions, and sometimes it's 30 to 60 minutes we speak to them. Also, we want to include the resident pediatric cardiologist, and it's always a question of time, and it's not always easy. But one focus point that we have is the movement, activity, and sports. And we did a study with young people and children who move regularly. They have better value also in the endocrine status. And the serial research, of course, you can have very good predictors when there is a worsening. It comes to a problem. But what we always see as well, that it shows the parents as well that when the parents see what the child can perform, and that also changes the stance of the parents when it comes to sports and movement. So we always encourage to start as early as possible. There are some studies in Australia, Fontan fitness trial, fitness intervention trial, and this is accompanied via the telemedicine, and they want to see what is the result and the impact on quality of life. Sport is certainly something that is positive, that has been shown in many investigations. And analog to the Berlin colleagues, we devise a training plan for about 6 weeks in total. But it's for patients with a VT1 heart frequency. They can start with a brisk walk for 30 minutes at VT1 and then have interval training for 5 minutes brisk walk VT1. As I said, it's about for 6 weeks, and then we accompany it with the video consultations, and then we do a control investigation after 6 to 12 weeks in order to continue. So the conclusion, ultimately, it's very important. It's been published in many guidelines. The regular assessment of patients. We need, in routine settings, we need simple but good tools, especially when it comes to the heart function, but also spiroergometry, advanced imaging, MRI, lymph MRI, cardiac catheterization. But what's always important for me, if the clinic is good and the values are good, then when it comes to the frequency and the invasive investigation, you have to see that they are not seen as a chronic patients, but they can feel as a normal person. And an adult Fontan patient that participated in a study in Bonn, he was very excited about this high chamber. He said it was very difficult and weird to find as a patient again. But it's something that surprised me as well as a feedback. So with pathological test results, we have to do further investigation. But the goal should be to improve the quality of life for the patients so that they can participate in life and have fun with sports, etc. You can see also a 6-year-old has a lot of fun on the running track. And yes, that was my presentation for today. Thank you.
Thank you. So now we need a method to see how we can distribute this method, this evenly in all of Germany. Do you have any questions or comments? Thank you. Now we have another topic talking about complications that we haven't heard about yet. So thank you, Mr. Gebauer, for talking about arrhythmia in Fontan. Everybody, I don't see so much from here, but I know there's still people. I've never spoken later, but we can talk about all kinds of arrhythmia, tachycardy. So let's talk about the complications of the Fontan circulations. Here we see the different complications of the Fontan surgery, how they evolved. We see this when we look at the picture. So if we don't have any problems in the atrium, then we don't generally have any problems. So the factors that lead to arrhythmia in our patients, and this in general, but especially in Fontan patients, they come pre-surgery, so these patients have lots of problems, and post-surgery we have the scarring. I really like to show this. So this is the correlation between the arrhythmia and heart insufficiency, and one conditions the other, and all the general risk factors for cardiovascular diseases are also true for our patients, and more so as that. So we have to look at that and consider that, and the data reflect that. We've seen this study today already from Australia, New Zealand, a study published 4 years ago, 500 patients, the classic Fontan, then lateral tunnel, 41%. And if we look at the incidence, incidence of arrhythmia, then with the classical Fontan, 65% of the patients deal with that, and we don't see the difference between the extra lateral tunnel and the lateral tunnel and the extracardial conduit. We do know that this is dangerous for these patients. So there's a symbolic risk, of course, and it's hemodynamically, it is not. It's the patients are young, and what we already also know is that the treatment, the medical, medication treatment of arrhythmias is very risky. We have to consider that many of these patients are not very fast. So if they don't have a pacemaker, then we don't have so many treatment options. Just to demonstrate that this is to demonstrate that the antiarrhythmic treatment is not very successful. So after so it doesn't work very well, and that's not the right way to treat these patients. So we have to say 80% of the classic Fontan patients, and those were the ones with the most frequent arrhythmia. So if we decide in favor of the ablation, we have to consider many things if you think about it. So there are risks associated with the anesthesia and the sedation. You see it here, suspected arrhythmia, and we also have to look at the conduction system injury. All these considerations we should make beforehand, before we decide in favor of a surgery. We don't want to be in the surgery, so we need we have to be quick in the surgery. We have to look at other conditions of the patient, so they're not always healthy in other regards. So we have to know exactly what heart disease the patient suffers from. So many of our patients have know about the operations from 30 years ago. So 3D mapping systems before the procedure. We also have imagery. We have to know how to get access. So the surgeon needs a very precise instructions. So this looks like some kind of broom, and this is like the thing you kill the flies with. These are the instruments. So we need to understand the rhythm substrate. We need to know how to access the substrate, and we have to be able to modify the substrate and to verify that the substrate modification will lead to a healing of the arrhythmia. So these are data from Boston. 50 patients, most of them lateral conduits, aged between 18 and 11. Most of them have so we have an acute success rate of 76%, but no recurrence in 50%. So if half of them come back. Another study from Australia, 40 patients, the classic Fontan. Here you can see where we can see the substrates, or where they could see the substrate. This is the triatomy. Here we have the scar. This is these are the places where you can look for the arrhythmias. And but many patients come back. But still, it's better than to do nothing. Only one of the tachycardies was in 25% of the cases were ablated. So the success of the ablation was measured with a arrhythmia score. And here you see the arrhythmia. It's a scoring system based on the question, was it and then the patients were evaluated. Blue is before the ablation, red is 6 months afterwards, and green 12 months afterwards. So you can see that the patients have profited from the ablation, and everything that was inducible, and also in the group where there was one ablation. So it is an effective therapy. Now, one case, one of the patients that we treated in recent years with an HLHS, so we have a 16 millimeter conduit, a reduced RV function, and what we always do is to do a procedural imaging. You can see that on the right-hand side. And then you have the system circulation on the left-hand side. And this is the only one that I'm going to show you. You can see that the patient is not healthy. And what you do, you have to induce the arrhythmia. So we initiate the arrhythmia. You can see that here. And you can see that the cycle length was not regular. That's not a good mapping for us. We need a regular mapping in order to be able to do the surgery. And if you have the tachy, then you have to make it TA control. It's challenging because thanks to this patient group, we decided in favor of using these kinds of accesses. If you look at the other side, if you access the other side, you can make maps such as these. That's a fusioned preoperative MRT. This is the atrium. Here you have the high density mapping catheter. And you see the 3D point. You see the time and the voltage, and you see where the scar is and where the healthy tissue is. And you have the colored coding. So here you have the focal arrhythmia that comes from the lateral point of the right atrium. And here you have an ablation, and you have the arrhythmia, which was terminated successfully, and the patient was healed. So this is a voltage map. So you don't have a big scar here where the ablation took place. This is scar tissue, and you don't see a big scar, but nevertheless, the arrhythmia could was ablated successfully. So a year later, the patient was cathetered, and after the punction, you can see that there are no traces left. So that was one of the hypotheses, that something was left. So the way there is pretty easy, because during the ablation there is a congestion, and we use a tool that a special tool. So if you take it out, you never know if it's blood. If it bleeds, it never bleeds. I was surprised at the beginning. So we wait half an hour to see whether the patient is stable. So in summary, the catheter ablation is only one causal therapies of arrhythmias in ACHD patients, and we always have to weigh risks and benefits. We need procedural preparation. That's essential. And we have ICE, TEE control of the tunnel puncture. And we also need 3D mapping systems and irrigated catheters. The cooled catheter means that the tip is being cooled during the intervention, and you do that in order to be able to have a deeper lesion. So if the tip is too hot, then the energy is switched off. So this is why the catheter is being cooled. And there are pathological studies that show that. What is the future then? We have the so-called PFA, past field ablation. So if this is mature, then we will take it over. We always wait for the adults to make their decisions, and then we decide what is good for us. So I'm sure it might be good for some patients of ours. Thank you.
Mr. Gebauer, many thanks. Of course, there's arrhythmic defaults are everywhere, and if I understood correctly, during the decades, then we get to a region where we are at 90%. But for this area, you have a causal therapy, and not always many come back, but it's a therapy that gives a patient space where they have no heart rhythm failures. If there are no questions, many thanks for staying with us so long, that we were staying so long and lasted so long. I thank you very much, and I hand the floor to Fontan-Herzen EV and Mrs. Sänger. And independent of what is still coming, I wish you a safe journey home. I do away, due to the late time and our delay, or slight delay, do away with the summarization, but I want to, for those who are still here, I want to say just how much I enjoyed this long day in this wonderful location, and I hope that you enjoyed the location as much as I did, because I think our Johannes Church in Magdeburg really brings you down to earth, and it gives our symposium the atmosphere that it deserves. And I would like to thank you. I would like to very briefly also use the opportunity and thank our moderator, Professor Grawitz. And then all of you that you accepted our invitation. It's not something that is very usual for us, but for us it's a appreciation of our work and what we are doing, and experiencing together with our families and children. I want to thank the Friede Springer Foundation that is supporting us, and said, Mrs. Sänger, we can see what Fontan-Herzen is doing, this highly scientific work, and how the families are fighting together with the doctors. It's very special. The MVGM, also the technicians and our translators, Mrs. Göllner, Mr. Schwalb, and I think they deserve an applause. And it was really hard work for them. And it was a presentation marathon, and we had 3 cancellations, but we had a lot of presentations, and I couldn't do away with any of them. So many thanks to all of you. It was really unbelievable what we experienced today, and also the people who supplied us with food and drink, Anneke, who did our design, all the photos and everything. I think we are well supported with her, and I mentioned her in the heart clinic. Her child could undergo a correction, and she could see how much we were fighting, and remained by our side. Our photographer, Sandra Schröder, who is always here at our events, and takes wonderful photos, and in the meantime also has been acknowledged, and also my photo at the Tagesspiegel newspaper was done by her. Thank you very much, Sandra. Then all the people who helped us, I don't want to mention them in detail, but all our supporters who enable our work, and also the board and the advisory board of Fontan-Herzen, and they make it possible that we start all these projects. And I think they deserve the biggest applause. And finally, for all of you who stayed with us to the very end, I would like for you to come up to the front, that Sandra can take a photo of our group as a thank you very much gesture, and then in the meantime we can start changing the location again, because tomorrow the youth celebration will take place, and but let's come up here and make a final photo in this wonderful location.
Herzlich kämpfen uns durch.